Good morning. I'd like to call this Oversight Roundtable of the Committee on Health to order. Today is Monday, October 28th, 2024. The time is 11:02 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. We are in room 500 of the John A. Wilson Building, and this is a hybrid hearing with public witnesses testifying both virtually and in person, and then we'll have our government witnesses testifying here in person. Today, we are holding this Oversight Roundtable to hear from both the public and executive on the oversight, quality, and capacity of inpatient psychiatric facilities here in the district. Our focus will be on the roles of the Department of Behavioral Health, DC Health, the Department of Healthcare Finance, in monitoring these facilities and ensuring that the regulatory and contractual frameworks are effectively safeguarding patient well-being and identifying any oversight gaps. We'll also examine the capacity of the district's behavioral health system, particularly for children and youth, identifying in the continuum of care and what investments or recruitment changes are needed in order to bring providers to meet community needs. Lastly, we'll consider how these behavioral health facilities are integrated within a broader continuum of care. A lack of coordination often results in fragmented services, leading to higher hospitalization rates, increased emergency room reliance for behavioral health crises, and inadequate long-term care options for residents with chronic mental health conditions. I hope you all look forward to a very constructive discussion on how we can strengthen these critical systems for all of our district residents. I don't see any of my colleagues, but I do anticipate some of them will join us. I'll turn to them when they arrive. We're going to turn to the public witnesses. There will be 4 panels of public witnesses, each comprised of both in-person and virtual witnesses, and they're organized by witness type. And then we'll conclude the hearing with government testimony. All of our public witnesses will have 5 minutes to speak. However, if an organization does have multiple representatives, the second representative will only have 3 minutes. I'll provide a gentle reminder that the time is ending, just to ensure that everyone has the opportunity to share their perspectives today. Witnesses are reminded to please submit a written copy of your testimony, uploading that up on the DC Council website. And if you have any trouble doing that, you can talk to Ashley, who is over there, and she will be able to assist. Okay, so we'll start with our first panel. I think these are all of our hospital folks. Dr. Adelaide Robb, who's the Chief of Psychiatry and Behavioral Sciences from Children's National Hospital. Dr. Gregory Argyros, who's the president of MedStar Washington Hospital Center. Dr. Erica Richards, who's the chair and medical director of the Department of Psychiatry and Behavioral Health for Sibley Memorial Hospital, which is part of Johns Hopkins Medicine. Dr. Carlos Brown, psychiatric social work manager for Sibley Memorial Hospital, Johns Hopkins Medicine. He has an S already. Dr. Shabazz Khan, who's the chief medical officer for Psychiatric Institute of Washington. Kimberly Russo, who is the CEO of the George Washington University Hospital, and Tony Coleman, who is the CEO of the Cedar Hill Hospital. All right. Okay, I think everyone, well, not everyone. Let's see. 1, 2, 3, 4, 5, 6. Okay, we're missing someone, but they will join us. Okay. Dr. Robb, when you're ready.
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Adelaide Robb, and I am the Chief of Psychiatry and Behavioral Sciences at Children's National Hospital. Children's National has been serving the nation's capital since 1870 and is proud to be named a top children's hospital by U.S. News and World Report Best Children's Hospital Honor Roll. Thank you for the opportunity to provide testimony about the critical importance of inpatient psychiatry care in the continuum of behavioral health care in the District of Columbia. Children's National has a longstanding commitment to strengthening the behavioral health system for youth and adolescents in the district. In recent years, we have witnessed a concerning rise in mental health crises among our young patients, leading to an increased demand for psychiatric beds. This surge has placed immense pressure on available resources and services, highlighting the urgent need for enhanced support systems. As you know, we are currently the only institution outside of PIW that receives pediatric behavioral health patients for inpatient care. Our inpatient unit includes a 12-bed unit for children ages 2 to 14 and a 14-bed adolescent unit for adolescents aged 14 up until their 18th birthday. Both units provide a safe setting where our team provides crisis intervention and stabilization. Our interventions in the inpatient psychiatry units are critical for children and adolescents with a variety of behavioral health symptoms, such as changes in mood, behavior, or thinking patterns. While many children and adolescents can be effectively treated in the outpatient settings, some are evaluated in our emergency room during mental health crises. A portion of these young individuals require admission to an inpatient psychiatric unit to receive intensive treatment and stabilization necessary for recovery. Over the last several years, we have seen an increase in the number of involuntary mental health patients presenting in our emergency department. This increased need for mental health care has led to a shortage of behavioral health beds and increased emergency room boarding. We believe the loss of adult inpatient beds when United Medical Center closes will place a greater strain on the system given the limited behavioral health beds that are available for youth at PIW. As we continue to see an increase in the need for psychiatric beds, the district could greatly benefit from a pediatric comprehensive psychiatric emergency program, CPEP, with full psychiatric assessment, stabilization, extended observation, treatment, and referral. We currently have all the elements of a pediatric CPEP except for adequate reimbursement and dedicated space for extended observation. A CPEP model, one that operates in the space before inpatient hospitalization, would enhance the capacity to provide timely, specialized care for youth in crisis, ensuring they receive appropriate support in a safe environment. The program could also alleviate pressure on existing resources, reduce wait times, reduce inpatient hospitalization, and readmission to the emergency department, and improve overall mental health outcomes for young patients in the community. While Children's National plays a vital role in providing behavioral health care, it is crucial to recognize that our efforts must be part of a broader, integrated system. Without a fully developed continuum of care across the district, we cannot adequately support all youth in need. The district currently lacks partial hospitalization programs and residential treatment programs, which are essential components of a comprehensive behavioral health system. It also needs additional intensive outpatient program capacity. These services provide crucial support for youth experiencing significant mental health challenges, allowing them to receive intensive care while remaining engaged with their families and communities. In our written testimony, you will find additional detail and insights that we believe will be valuable for the committee's consideration on how to create a successful behavioral health system for youth. As we continue to face challenges in pediatric mental health, it is imperative that the district invests in the expansion of behavioral health services continuum. Children's National is dedicated to being at the forefront of this essential work and welcomes the opportunity to partner with the district on this critical issue. Thank you for the opportunity to testify, and I am happy to answer any questions you may have.
Thank you, Dr. Robb. Dr. Arkoros?
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Dr. Gregory Ardress, and I'm the president at MedStar Washington Hospital Center. I'm pleased to represent MedStar Health at this roundtable. MedStar Washington Hospital Center is a 910-bed major teaching and research acute care hospital. We are the largest private, not-for-profit hospital in the nation's capital and amongst the 100 largest hospitals in the country. We are a major referral center and receive the most complex cases. Our services include acute care behavioral health services, helping our community's residents get and stay healthy and improve the quality of life for patients by managing their own chronic diseases. I appreciate the opportunity to participate in this roundtable. And at MedStar Washington Hospital Center, behavioral health is highly integrated into the care of every patient. The behavioral health service includes a robust consultation and liaison service that covers the acute care hospital, 2 inpatient unit operating 30 beds, and a large outpatient program that is located approximately 1 mile from campus. We have collaborative relationships with Georgetown University, Howard University, and the University of Maryland for the training of psychiatry residents, medical students, and social work and nursing students at those locations. Our inpatient behavioral health service is an adult 18 years and older program for the treatment of patients with psychiatric and co-occurring substance use disorders. Patients with both acute psychiatric issues and those with severe and persistent mental illness are treated on the units. The primary diagnoses seen on these units include psychoses, major affective disorders, organic disorders with emotional components, and other psychiatric symptoms that are present with imminent risk of harm to self or others that are cared for on the unit. This important involuntary patient population is cared for at the hospital center and is something that we have provided for many years. Up until the closure of Providence Hospital, we maintained a capacity of 12 involuntary patients that we would care for on our units. And once Providence closed, that number was increased to 16, and we are committed in the future to continuing to be able to care for 16 involuntary patients moving forward. While patients are on the inpatient units, they receive care from a multidisciplinary team of providers, including psychiatrists, clinical social workers, substance use care counselors, psychiatric nurses, recreational therapists, nurse practitioners, and peer recovery coaches who work with the patients with substance use disorders to facilitate the transition to substance use treatment facilities. The care focuses on goals set by the patient to improve their ability to live independently in the community and to manage their behavioral health symptoms. Working with the patient's family, and community support system is part of the care model. Discharge planners collaborate with the community agencies and the patient's outpatient providers to arrange for continuity of care and a safe discharge into the community, while peer recovery coaches link patients with substance use disorders to treatment facilities after discharge. MedStar Washington Hospital will be relocating to a new inpatient behavioral health unit on the ground floor of MedStar National Rehabilitation Hospital. The new inpatient behavioral health unit will be a modern facility that is aligned with the latest 2022 Facility Guideline Institute guidance for inpatient behavioral health care. The new unit will have a state-of-the-art design with an expanded layout that will include private bathrooms and increased visibility for patient monitoring. It will provide a safer workplace and patient care environment. There will also be a new outdoor space for behavioral health patients, creating a healing environment and therapeutic milieu for the district's behavioral health patients. The new unit is expected to be completed in April 2026. And again, that unit will have a capacity of 32, which is what we have been maintaining since 2020, and we will continue to commit to 16 involuntary patients being cared for. We also have a full outpatient continuum of intensive care programs, including a partial hospitalization program and 2 intensive outpatient programs, one for patients with primarily mental health and one for substance use dependence. We also have a traditional outpatient psychiatric unit. We believe the initiation and growth of these programs has contributed to the decreased need for inpatient care and a decreased census that we have been seeing over the last 6 years since these programs were initiated. I also want to comment on our chronic psychiatry and therapy clinic that again is maintained 1 mile from the campus. This is staffed by a multidisciplinary team and includes licensed psychiatrists and social workers who assist with the care of these patients, to include providing gender-affirming services and culturally competent care. We have finally collaborative services where we work with multiple inpatient services, such as the burn program, the bariatrics program, and other services across the hospital that have patients that have significant mental health needs, so that we can provide not just state-of-the-art medical care, but state-of-the-art behavioral health care. Thank you.
Thank you. We're going to go to Dr. Richards, but before you start, Dr. Richards, I want to note for the public, we've been joined by Councilmember Zachary Parker, Councilmember from Ward 5, who's a member of this committee. Councilmember Parker, did you have an opening statement?
Thank you, Chairperson Henderson. No comment.
Okay. All right, Dr. Richards, when you're ready.
Good morning, Chairperson Henderson and committee members. We thank you for your time today and listening to our testimony. My name is Dr. Erica Richards, and I'm the Chair and Medical Director of Psychiatry at Sibley Memorial Hospital. I'm joined today by Dr. Carlos Brown, Psychiatric Social Work Manager at Sibley, and we're grateful for the opportunity to submit testimony. One of the things we wanted to talk about is at Sibley, we have 19 beds in our inpatient acute care unit. We provide consultation services for the entire hospital, including the med-surg units, as well as women and infant services. We provide urgent emergency room evaluations and additional procedures, including electroconvulsive therapy and transcranial magnetic stimulation. But in our limited time today, we want to walk you through the lifespan of a patient that presents to Sibley Hospital for acute psychiatric care. We'll start our journey in the emergency room. At this juncture, patients with behavioral health complaints, including potential suicidal ideation, are prioritized at the point of triage to ensure that we have them in a safe area and with appropriate levels of care and supervision. Sibley's in the process of adding additional behavioral health emergency room, which will allow us to treat larger numbers of behavioral health patients in a new state-of-the-art space, specifically designed to be safe for patients from a psychiatric perspective and to meet the complicated medical needs of many patients who present with primary psychiatric complaints. In collaboration with our emergency room colleagues, we will be able to treat up to 9 patients in a safe environment that includes single patient observation rooms, medical observation bays, and as needed, more secure holding areas. We're in the process of finalizing our certificate of need for this emergency room behavioral health space. Once triaged, patients are evaluated by a provider in the emergency room to ensure that medical interventions are not needed before psychiatric evaluation. So this can be seen in patients who present with altered mental status or new onset psychotic symptoms, those that present with dementia, or even some where we're concerned about severe alcohol withdrawal, just to name a few. Following that medical clearance, patients are evaluated by a psychiatric social worker who collaborates with a psychiatrist to determine recommended interventions, which typically range from discharge to home with additional resources, voluntary admission, or transfer to an involuntary facility. I want to now take a moment to talk about some of the challenges we face in caring for our patients. Staffing at hospitals remains challenging at all levels, from the behavioral health techs who provide one-to-one monitoring for patients with suicidal ideation in the emergency room to psychiatrists working in this acute care setting. Along with this is the ongoing drive to provide culturally sensitive care. In 2020, my colleagues and I published an article with data showing that within psychiatry, historically underrepresented minorities in medicine had significantly less representation compared to US populations. Females are also underrepresented as practicing psychiatrists, but their numbers in residency are increasing. We all need to be creative and collaborative in determining how to best handle recruitment and retention for the behavioral health workforce. I'll now pass the baton, so to speak, to my colleague, Dr. Carlos Brown, who will discuss additional challenges and proposed solutions facing our behavioral health populations.
Thank you, Dr. Richards, and thank you, Chairperson Henderson and committee members. On a daily basis, we struggle with navigating limited resources within several areas, including community providers accepting patients' insurances, complex social determinants limiting community members with engaging with core service agencies, and impaired community collaboration events to address the complex needs of patients. Our hospital serves as a crucial point for a safety net for patients involved in facing behavioral health challenges, many of whom challenges with stigma regarding mental health and barriers to accessing care. We have witnessed firsthand an escalating demand for services, exacerbated by lingering effects of social inequalities. And to effectively address these needs, we ask for more curated spaces that facilitate collaboration among key stakeholders within community members. About 17 years ago, DC Hospital Association formed a behavioral health collaboration with representatives from American academic institutions and community behavioral health programs. FQHCs and DBH work together to collectively identify how many and how we may collaborate on providing the best care across the district. By fostering additional partnerships between healthcare providers, community organizations, and local government, we continue to develop comprehensive solutions tailored for our residents. Investing in these collaborative efforts, along with increasing funding for community members and community-based programs, including act-level service of cares and crisis intervention services, is essential for improving quality of life for Washingtonians. Your leadership in this matter is appreciated, and we all seek to build a healthier and more resilient community. Thank you all for your time. We appreciate you all, and we'll answer any questions at this time.
Thank you, Dr. Brown and Dr. Richards. Dr. Khan?
Good morning. Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to be a part of this roundtable. My name is Dr. Shabazz Khan, Chief Medical Officer at Psychiatric Institute of Washington, and I'm also the Director of Medical Education at the Psychiatric Institute of Washington. I'm boarded by the American Board of Psychiatry and Neurology in the specialty of general psychiatry, child and adolescent psychiatry, and psychosomatic medicine, and have served at PIW for almost 6 years. I'm also a teaching faculty member at St. Elizabeth Hospital as well as Howard University Hospital. My testimony today is provided on behalf of the Psychiatric Institute of Washington. PIW stands as the largest and only freestanding acute behavioral health hospital in the district with 130 beds, with an additional 22 beds currently under construction and set to come online in early 2025. PIW provides safety net services to some of the most vulnerable and high-risk population in DC and in the surrounding DMV area in the quest to provide increased access to behavioral health services in a dwindling market. Specifically, service provisions include inpatient and outpatient services for adolescent and adult patients, detox and withdrawal management services, and a clinical assessment center that provides 24/7 intake, evaluation, and assessment for patients in crisis. PIW is also one of only 3 receiving hospitals in the district for involuntary committed patients, so-called FD12. To provide some perspective, according to the recent utilization data by the DC Hospital Association, PIW counts for almost 65% or about 2/3 of all FD12s in the district. This is a significant commitment that is expected to increase with the upcoming closure of United Medical Center in 2025. The committee cited the focus of this roundtable is to cover matters regarding quality, oversight, capacity, including discussions on the provision of aftercare services post-hospitalization. We're eager to weigh in on each of these areas. Specifically in regard to quality and oversight, the regulatory oversight in our market today is quite robust, but can be unproductive and uncoordinated between entities. As a provider, we understand the regulatory oversight is an important component in healthcare delivery to monitor compliance with regulations and standards. It has many benefits, including patient safety, quality improvement, and patient rights and compliance. PIW has a comprehensive internal monitoring process that includes patient safety initiatives, internal reviews of incidents, including action plans. PIW also self-reports all significant incidents to DC Health and Department of Behavioral Health. Due to our operating history in the district, our concerns are that the regulations may not be flexible enough to cope with the challenges and changes in the industry, such as increased patient-to-patient and patient-to-staff aggression, and may promote compliance over quality of care. We would respectfully ask that the regulatory oversight system in the district be reviewed to develop a coordinated, focused, and efficient system instead of increasing lengthy and frequent monitoring visits. In terms of aftercare services, we believe the transition from inpatient to outpatient behavioral health care is a critical time for patients. Hospitalization is not designed to be the only treatment that patients need to restore them to wellness. To help our community close gaps in care, improve patient experience and outcomes, and ensure appropriate supports are in place, we want to work together to provide aftercare services. While inpatient stabilization may be necessary for some individuals who navigate mental health crises, planning for transition back into the community is an integral component in ensuring that individual may sustain their recovery. In the district's 2018 health equity report, it was acknowledged that 80% of population health outcomes was driven by non-clinical determinants, such as transportation, food environment, and housing, to name a few. We continue to seek opportunities to connect and engage with community services. However, rapidly evolving services make it difficult to maintain a reliable compendium of resources to refer to. It is difficult to keep track of all the changes in the outpatient services available to our patients with high turnover rates. At times, our clinicians spend hours over the course of the admission trying to reach someone. We would urge the district to consider a live database where any changes may be recorded in real time to alleviate any confusion regarding the point of contact for social services agencies managed by DBH. The hope would be that if we were able to quickly identify the outpatient service providers, we could be able to coordinate care transition sooner and improve patient outcomes. Furthermore, we are also grateful for the outpatient clinical managers and providers who participate in the discharge planning meetings and care coordination
Dr.
efforts.
Khan,
We recommend that it would be a requirement for a clinician on the outpatient team to make contact with the
Dr.
hospital.
Khan, I'm so
Yes,
sorry. You're about 1:30 over your time, but if you can just hang on, we'll ask you some questions.
of course. My apologies.
No problem. Ms. Russo?
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Kimberly Russo, and I serve as the Chief Executive Officer of the George Washington University Hospital. The George Washington University Hospital has been a leader in providing behavioral health care to area residents for more than a century. The aim of psychiatric services at GW Hospital is to provide care that enhances the opportunity for recovery and exceeds the expectations of patients and referral sources. We appreciate the opportunity to discuss the behavioral health services currently available at our institution. The GW Hospital 20-bed unit for adults aged 18 and older offers a range of psychiatric and dual diagnosis treatments. The unit offers a highly structured mental health treatment program with 24-hour nursing in a locked, secure setting. The short-term stabilization unit is designed to help patients move through a mental health crisis and gain the coping skills and resources necessary to successfully transition to the next stage of treatment. Each adult works with a multidisciplinary psychiatric team, including a psychiatrist, social worker, nurses, mental health technicians, and a therapist to identify and meet treatment objectives and achieve stabilization. Treatments include psychiatric assessment, medication evaluation, comprehensive psychosocial assessment, client-centered treatment planning, psychoeducation, individual group, and family therapy. The objective of inpatient hospitalization is to provide a safe, secure environment for patients experiencing an acute psychiatric crisis. The length of stay is based on each patient's situation, ranging from a few days to a week. Treatment is focused on stabilizing acute symptoms and assisting each patient in assessing the resources, supports, and skills necessary to move through the crisis and develop a successful plan to continue treatment in a less restrictive treatment setting following discharge. GW Hospital also provides consultative services to the medical surgical population and emergency psychiatric services 24 hours a day, 7 days a week to evaluate patients who have a mental health concern or crisis. The psychiatric team works in consultation with emergency room physicians and peer recovery coaches to provide specialized behavioral health assessments, including psychiatric assessments, crisis intervention, recommendations for level of care, including inpatient psychiatric hospitalization, and referrals to appropriate mental health resources for continuity of care, which does remain challenging given gaps in offerings within the District of Columbia. To help our community close gaps in care, improve patient experience and outcomes, and ensure appropriate supports are in place. We support working collaboratively to ensure aftercare services are in place to support behavioral health patients. Instead of viewing inpatient and outpatient services as distinct, we seek to work collaboratively as a unified team to support patients as they navigate the various care settings. It is essential that the district assess the needs and further expand the behavioral health services available for the residents in the district to achieve these improved mental health and outcomes that we all desire. It is also important that we provide the appropriate transitions of care throughout the district. We welcome the opportunity to partner with the district, various agencies, and others providing services within the community to develop the necessary robust behavioral health services to meet the needs of our district residents. Thank you, Councilwoman Henderson and Chairperson.
Thank you, Ms. Russo. Mr. Coleman.
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Dr. Tony Coleman. I'm the CEO of Cedar Hill Regional Medical Center. Thank you for the opportunity to testify about UHS's integrated delivery network of care that includes George Washington University Hospital, Cedar Hill Urgent Care, GW Health, the Fletcher Johnson Freestanding Emergency Department scheduled to open in 2027 in Ward 7, and Cedar Hill Regional Medical Center, which I have the pleasure of serving as Chief Executive Officer. Cedar Hill Regional Medical Center, GW Health, is a full-service hospital on track and on budget to open in early 2025 in Ward 8. Cedar Hill Regional Medical Center is a private-public partnership with the district and Universal Health Services. It's also the first hospital to be built in a district in 20 years. The cost of this hospital is $434 million, and it will include 136 inpatient beds with the ability to expand to 184 beds. It will also consist of a level 3 trauma center, adult and pediatric emergency departments, maternal health and delivery, a level 2 NICU, outpatient dialysis, cardiac rehab, infusion, and other outpatient clinics, as well as a 500-car garage and a helipad for emergency transports. In addition to all I've mentioned, we will also have a dedicated 16-bed voluntary and involuntary behavioral health unit staffed by providers who bring vast experience in serving patients throughout the DMV, specifically in Wards 7 and 8. Thank you.
Thank you. Thank you so much to this panel of witnesses and for the work that you and your staff conduct each and every day. I have a few follow-up questions. Okay. So one of the impetuses for this hearing was around capacity and need in terms of capacity. And now, correct me if I'm wrong, but MedStar Sibley, PIW, let's put that to the side. MedStar Sibley and GW only accept for 18 and older, correct?
That is correct, at both Georgetown and at the hospital center. That's
Okay.
correct.
Correct for GW as well.
18 and up, Ms. Russo?
Yes, we are an adult facility.
Okay, so let me ask you this. If a child or a parent brings a child who's under 18 to your emergency room in crisis, what's the protocol?
For us at the hospital center, with children's being right across the parking lot, it's not uncommon for us to be moving patients, adult, child, particularly in that 16 to 18 realm, back and forth, depending on the size and complexity of the patient involved. Yes.
Okay. Ms.
And-
Russo?
Yes, and for the George Washington University Hospital, not so different. Our goal is to stabilize and determine the best place for that patient to go. So it would be engaging with our community providers such as Children's, PIW, and others that accept the juvenile.
Okay,
The
Ms.
same is
Richards?
true at Sibley also. We will evaluate, we can start treatment as needed. And if there is a need for an admission, we'll work with our colleagues either at Children's or our colleagues at Hopkins, as long as patient and more importantly, parent are willing to be transported across state lines.
Okay, so for Sibley, you would transfer up to Baltimore if there was space available.
Correct, if we needed to. We kind of cast a wide net, including in the Maryland hospitals.
Okay. So then, Dr. Robb, that comes to you. I think in your testimony, you said you all have a 12-bed unit for which age group again?
Our 12-bed unit is for children 14 and under.
14 and under, and then you have another unit for adolescents?
Yes, and that is 14 with 2 overflow beds going up to 16.
Okay,
And that's up to the 18th birthday. Once you turn 18, I defer to all the other colleagues who testified today to take care of them.
okay. Can you talk a little bit about capacity? How often do you not have any beds available?
It really depends on the time of year because many mental health crises in youth are school-related. So July and August are our quietest periods of time because people are on summer break and the stress of school and homework and final exams and all the rest of it is lower. But once school starts in the fall, we rapidly become full. And then we need to improve our discharges back to the community. So we work with all our community providers in the district and beyond and try and facilitate timely discharges and then bring people up from the emergency room.
Okay, but in the instances, has there ever been an instance where you all cannot admit a young person?
Absolutely.
And so what happens in those instances?
In those instances, if the person needs to be admitted, we then start to look for beds. And so we go to our other psychiatric hospital that serves children in the district, which is PIW. Or if there's a specialized need, for instance, somebody with an eating disorder, we would send them to Dominion in Virginia because they have an eating disorder inpatient unit. If somebody had autism and most of their issues were around autism and they were waiting in the ER, we would reach out to Shepherd Pratt and Hopkins in Maryland because they both, and it's Kennedy Krieger at Hopkins, but they both have specialized units for autism.
Okay. Are there any instances ever where a parent either cannot travel out of state or does not want their child to be served out of state?
That happens for families.
Okay.
And then we work to stabilize them in the emergency room. And as soon as a bed becomes available, we move them to our unit or we transfer them to PIW, depending on which is available first.
Okay. Dr. Khan, of the beds that are available at PIW, how many do you guys set aside for juveniles?
We have, at the moment, Chairperson Henderson, we have one unit that is dedicated to children, and we have a 13-bed unit at PIW for children ages 10 to 17.
Okay. So even in that, even though PIW has beds available, they only start at 10. So there's some specific age situations here. Okay. One of the things that I think several of you brought up is in terms of needing aftercare services, or once a child has stabilized but might still need care, where are the community providers and how do we find them? I think Dr. Khan, you mentioned in your testimony, you want a live database. I would love that. I think we did a bill. I think Councilmember Parker did a bill to try to do a live database in terms of what the community providers are. And, we had some challenges with our agencies in terms of, one, does this information exist? And two, how much they were going to charge us, how much it was going to cost from an infrastructure and personnel standpoint in order to stand that up. But I'll ask this, and I probably already know the answer to this, but do you all now, in your hospital staffs, essentially have to keep a person on staff just to be able to make the phone calls to community providers to see who has a bed available? Yeah, Dr. Rob.
So we have 3 people who do case management for our inpatients at Children's National. 2 of them do assessments for ongoing care, and 1 is solely dedicated to helping facilitate transfer to outpatient care. And DC Access Line through Dr. Bazron's team has a number you can call. Some of the agencies will take a call from our inpatient team. Some of them insist on having the parent or guardian call. And so we try and do that during a family meeting while the child is on the unit so we can make that connection and hand the child off to care in the community.
Okay.
And it's the same thing for adults. We use the court service agencies through DBH's Access Helpline. And whether it's a patient who has been deemed stable to be discharged from an emergency department or a discharge from our inpatient psychiatric unit, we use that same hotline for getting access to the court service agencies.
Okay. Are there any, or I'll ask this as both Dr. Richards, Dr. Khan, Dr. Brown, or Ms. Russo, if you want to reply, in terms of this sort of handoff piece, what do you feel like can be better about this? Because I get a little heartburn in the idea that we have some agencies who are saying, well, the parent has to call. And then I imagine for a parent who's overwhelmed, you're handing me a business card to say I have to call all of these various places to get my child to the next spot. There could be gaps here, but also a level of frustration in terms of being able to assess what's the right placement. Does anybody have any feedback here? I mean, how can we improve this process? Because I hear from parents all the time, it's not working well. Do you all think it's working well?
And this is Dr. Khan, and I will, I think in some ways, it's a very challenging step in the whole hospitalization. And at the time of discharge, I think if the handoff, if there are some ways to improve this handoff, I think some more involvement from the outpatient services and engagement to help to bridge this sort of transition, the whole treatment aspect moving from inpatient to outpatient. I think some more engagement from the outpatient providers would be helpful.
Okay. Dr. Richards?
I would add that this is key. If we're able to get this right, it will prevent readmission rates. It really sets people up for success when they're discharged, but it does come down to the staffing and having enough staff to not only help, hold someone's hand sometimes to make those calls to ensure that it works for parents. Or family members, do they have time off to get them to this appointment? We can't kind of do that without collaboration with them, but it is going to be key to have enough personnel inside the hospital, inside the emergency rooms to really make these calls and do these connections, especially with people that may have kind of a low acumen in terms of understanding how to navigate this process.
I would add, Dr. Richards, I think you and Dr. Khan are spot on. I think these are very complex situations. And having the appropriate care transition teams that are able to make the call is absolutely step one. But we also need the recipient of where we're trying to transition these care models and these patients to really be available, and that the services have space. I think what we find the most is that we don't have the access to the next level of care, which really prevents a warm handoff. And that's when we start really having the family, adult or juvenile, frustrations. And to your point, they don't necessarily understand the system. And as healthcare providers, we also are frustrated with the system, and we live in it every day. So I think that the care transitions handoff from acute hospitalization to inpatient hospitalization and inpatient hospitalization to the outpatient continuum of care is really an area that requires focus and investment.
Yeah. Dr. Rob?
I was going to say that the one place where it works quite well is HSCSN with Dr. Renata Hall and her team. Everybody has an outpatient case manager. And so when they come to our hospital, the outpatient case manager and treatment team join a multidisciplinary Zoom meeting to talk about what we need to do to get that child stabilized for discharge and make sure the outpatient team and the inpatient team are all on the same page in terms of what to do.
Yeah.
But not everybody has HSCSN in the
Right.
district, but that works well as a model.
Dr. Harris?
There are 3 new intensive outpatient programs at MedStar Georgetown University Hospital. One of them is for adolescents, and it is a program that does accept Medicaid patients. So that is a new offering of the city, that intensive outpatient adolescent program at Georgetown.
Okay. I think the frustration that I have, or not the frustration, but in the conversation we're having, I know what our capacity is on the hospital level. If you ask me today how many beds I have available on the outpatient side, I can tell you. Right? So I don't know, are we meeting need? Probably not. How far off are we? Hard to say. And what that infrastructure looks like in terms of quality, also hard to say, right? Because just because it's a bed doesn't mean that it's a bed that is going to be effective or meeting the needs of the client. But I'm well over my time, and now I've been joined by I have two colleagues who are here, a part of the committee. Before I turn to Councilmember Parker, Dr. Coleman, I just wanted to ask for clarification. For Cedar Hill, you said there will be 16 beds. Are those both for voluntary and involuntary, or has that decision been made?
So it's up to 8 involuntary beds.
Up to 8, okay, all right. Councilmember Parker?
Thank you all for your testimony. I'm gonna first focus as the chair of the council's new subcommittee on libraries and youth affairs and direct this question to you, Dr. Khan. What is your process for admitting juveniles, in particular in connection with DURS's YSC facility? And this is a continuation of Chairperson Henderson's question around admitting juveniles.
Thank you, Mr. Parker, for the question. Our process for evaluating a juvenile who's referred to PIW for admission is the same as another juvenile or child patient between the ages of 10 to 17 who is referred to PIW for admission. We start assessing the clinical information, we review the initial information that the referring agency or clinic or guardian provides us, and then we evaluate that clinical information and determine if there is any need to admit the patient to the inpatient services. So essentially our process is the same for any children between the ages of 10 to 17 who are referred to PIW to be considered for an admission.
Thank you for that. And I'm going to come back to you, but quickly, Dr. Rob, it is my understanding that the majority of youth at DURS are being treated at Children's, if at all. They do have medical services on site. Can you speak to what that handoff looks like in the instance that a young person needs to be committed for psychiatric treatment? I understand that you mentioned earlier, or you talked about the handoff, but what might that look like if you receive a call or a request for service from DURS?
And I'm terrible with abbreviations, DYS.
Oh, I'm sorry, the Department of Youth Rehabilitation Services. It's the facility where youth who are detained are held, and the YSC facility is in Ward 5 in DC. And one of the pain points that the facility is experiencing is a lack of treatment and support for young people with severe psychiatric needs. And I was trying to get a better understanding of how those young people might be treated at PIW, or when I visited the facility, I was told the majority of youth, when they have to leave the facility, they are being treated at Children's. And I wanted to get a sense of what that handoff might look like if there's a young person in crisis or in need.
So if there's a young person in crisis at DYRS, they're brought to the emergency room and assessed. We usually get records as well from the DYRS team if they have anything, or if a patient has previously been seen at our facility in any capacity through our medical record system. We can look that up and maybe see, oh, they had ADHD when they were 7 or something like that. We speak with the legal guardian as well to see if there's any input that they might have as well on the child. And then we make a determination whether they can be treated in the emergency room or need to be transferred to PIW or go back to DYRS.
And that determination is often happening within what span of time? Are we talking hours, days?
I would hope hours. If we are backed up in the emergency room and we have 6 people waiting for assessment, it may take up to 24 hours to complete the assessment. and then we make the determination. It may also have something to do with medical stability as well. If we think somebody had an overdose in the jail because they had things secreted in their pocket, or we think they're intoxicated, we do testing to determine that and then treat accordingly. If we thought somebody had acetaminophen or Tylenol poisoning, we treat that and admit them to the medical unit or the ICU.
Okay, thank you. And to confirm, how many juvenile beds or beds for youth would you have if you needed to commit someone?
If we needed to commit someone, we have 14 up to 16 beds on our adolescent unit and 12 beds on our child unit.
Okay, thank you. Dr. Khan, I wanted to come back to you. There have been, as recent, reports about incidents at the PIW facility. You talked in your testimony about a robust internal review process after every report or incident. Can you detail what that internal review process looks like and what it entails?
So it's the whole process, as I mentioned, is very robust, and we review all. We have some committees that review. We have safety committee. We have risk committee. We have patient advocates. So whenever there is an incident, whether that be between two patients or between patient and staff, or whenever there is a concern brought up by a patient or brought up by a staff, we have a process to review clinical matters relating to restraints and seclusions and treatment.
I'm gonna jump in quickly because the clock is ticking, Doctor. Sorry to interrupt.
Mhm.
I'm gonna give a specific example. So there were
Okay.
reports that one patient assaulted another. What might that process look like?
The
To be more
process in the immediate aftermath. So we can break down the process. What would be the immediate concern? At that point, of course, right away, immediately, assessments to determine safety, assessments to determine safety between the parties who were engaged in the fight. And then, of course, after determining that, first, that's definitely the first thing that the staff are trained to do. After that, then sort of a thorough deep dive into the triggers, into what brought this on, the antecedents, or sort of how did this happen? And that's a thorough review internally on a regular basis at multiple times during the day. That's done. And then, of course, changes in workflow, that comes after the review. That's done and is done on a regular basis. In all, we also self-report all incidents. If they get up to a point where they need to be self-reported, we self-report to regulatory agencies all incidents that are of concern.
And one last follow-up question. I am over time. When you say self-report, are you referring to the Department of Behavioral Health, or where are you self-reporting?
We to the Department of Health.
Department of Health. Okay, thank you.
Thank you. We've been joined by Councilmember Matt Fruman from Ward 3. Councilmember Fruman.
Thank you very much, Chairwoman Henderson. Dr. Khan, I think I'm gonna stick with you for a bit. I represent Ward 3, and PIW is located in Ward 3. I was really grateful to your CEO who gave me a tour of the facility about a year ago. You do incredibly important and difficult work. And there had been a dimension of impact on the neighborhood, and I honestly have not heard anything about that for a while. So I'm grateful to PIW for being a good neighbor. But at the same time, we get increasing reports of challenges on the inside. And I do want to ask about those things. When you talk about doing kind of an after action, I guess it raises the question, how often does that happen? There were reports that there were 28 incidents of patient-on-patient violence in February. And the day I went, there was an incident. The alarm went off in the 1 hour that I was there. The alarm went off and people had to go in different directions. How often do you have incidents of patient-on-patient violence?
Thank you very much, Mr. Furman, for your kind words and the question. So it depends on the milieu. Our patient population at one time may be.
I'm
very-
sorry, the volume somehow,
I'm sorry, my apologies. Is this better?
it's a little better, but it's not as good as you were before.
Okay, I will speak up. So,
Dr. Khan, you were louder just a minute ago. Is something covering your speaker?
Nope, nothing is covering my speaker.
Okay, we'll try to turn you up in the room if we can.
Okay.
Can we turn it up?
All right, well, I will, I'll say that that's it, at times our milieu population will change. So at one point, we may have a patient population that is more prone to incidents as compared to another point. There is no way to determine at how many per month incidents would happen. In terms of, we train our staff to work with patients who are in crisis, and they can present with aggression, they can present with self-harm, they can present with acute psychiatric needs. So the staff are prepared to help them, and from an administrative point of view, our process is to review all the incidents regardless of.
I understand that, Dr. Khan. If I can just jump in because time is limited. I understand that, and Councilmember Parker was asking about that review process, but I mean, there is a ballpark sense. I mean, you're saying that you can't give a number, and I'm not asking for a precise number, but the indication was on the order of one a day for a month, and on the one day that I was there was one. And are we in the 10, 20 range a month in terms of these kinds of incidents?
I'll tell you that our current data is, we are very close to the benchmark or UHS benchmark. And the incidents can be, they're mainly triggered by safety. And they're triggered by concern. What we have to, the alarms are to indicate that we have to act immediately to get staff to ensure patient safety and staff safety.
Dr. Khan, again, I'm sorry, but you said you're very close to the benchmark, so you sort of have a number. I'm asking for a number, and I'm a little frustrated that you're not giving me the number, and that in your testimony you were talking about the onerous quality of some dimensions of oversight. It's not that complicated of a question. What is the order of magnitude of these kinds of incidents in a month?
I don't have the number right now, Mr. Furman, and I'm sorry, I'm not able to give you a number right now.
Okay, so I mean, when you said to me that you're very close to the benchmark, you had a number, two numbers in mind. One was the benchmark and one was your number, and you're still not offering it, which you can imagine is a source of frustration. A different thing related to this is staffing, because we see concerns about the level of staffing. And what's been your staffing level and how has it varied over the last year?
So, Mr. Furman, thank you for your question. Our staffing is maintained at an organizational level. We are always staffed according to the staffing grid, and we take this very seriously. And staffing is challenging. We are a 24/7 facility. So we are always striving to ensure appropriate staffing. And I can assure you that our staffing is always according to the organizational grid that has been reviewed in detail by regulatory agencies.
So it's a grid that you developed and that has been reviewed by regulatory agencies, and you say you're always trying. Have you been able to maintain those staffing levels? I mean, we hear about challenges in all kinds of spaces in the medical area in terms of staffing. Have you been able to hit those targets, or is it that you're trying always to hit those targets?
Yes, we hit our targets.
So your sense is that you've been fully staffed, and that's not an issue, even though some outsiders have raised questions. What about turnover of your staff? And I'll stop with that. What does the turnover of your staff look like?
The turnover, it's also another area of concern. It's a challenging area. We are always trying to assure happiness. We are trying to assure proper fit. We are trying to assure that somebody is here who wants to be here. Our turnover fluctuates from one time to another. Our turnover right now, it's pretty at a robust, healthy state. We are always reviewing this. It's a internal quality of measure for us, and we are always reviewing that.
All right, I'm over time, so I will turn it back to Chairwoman Henderson.
Thank you, Councilmember Freeman. Ashley, can you do 5 minutes? Just have a couple of follow-up questions. Sorry, you guys are like the, what do we call it? I don't call it the varsity team, but you're on the front lines here of all of these things. And so when we're having these questions and conversations around what to do and what trends we're seeing, I hope you can appreciate that your insight is super important here. I want to pick up on something where Councilmember Freeman was sort of going around staffing. Obviously, the healthcare workforce has had lots of stressors over the last few years. And one of the things that we have been trying to actively think about, or I have been trying to actively think about and have been in conversations with some of the schools of medicine and some of the schools of nursing, is how can we grow the pipeline to fill some of the capacity gaps that your institutions are facing? So let me ask it this way. What do you need? Who do you need? Is it just more doctors? Is it more nurses? Is it behavioral folks? If entities are thinking about how do we grow out pipeline programs, what is the most important component of what's missing in your operations? I'll let anyone sort of talk about it.
And I'll jump in since I was addressing this question. I think we need all of the above. We need doctors, we need nurses, we need psych techs, we need qualified professional people who want to work in this field. This is a challenging field. This is a very stressful field to work in. So we need definitely pipelines. We need pipelines that would, when we talk about that, to build our referral sources so that we bring in qualified professional people. And I would say that we need all of the above that you mentioned, Chairperson Henderson.
Dr. Rob?
I think we also need to expand our collaboration with primary care teams, especially for outpatient. We are never going to have enough child psychiatrists and adult psychiatrists and psychologists to meet the demand. We have, through a program at Children's National, been embedding new child psychiatry fellows alongside pediatric residents in our Ward 7 and 8 clinics. We've added nurse practitioners to do psychiatric care in the same clinics. And we now have an additional person in charge of that education, as the American Academy of Pediatrics has asked all pediatricians to have 4 weeks of outpatient child psychiatry learning. We're trying to think what's the best model to optimize that learning and have partnerships with our pediatricians to expand capacity in the medical home.
Well, let me ask this, and I appreciate that. I think, Dr. Rob, you brought up the benefit from DC could benefit from a CPAP model. Yes?
CPAP, yes.
Yes, but you said it needs adequate reimbursement. And I think I've asked this when we've had hearings with the board chairs for the various health professional boards of what are the ongoing conversations with the Department of Healthcare Finance around whether or not the reimbursement rates are meeting your actual needs. Specifically on this issue, right? I'm sure you can tell me about the reimbursement rates of all the things, but is this an ongoing dialogue around to Director Turnage and his team, hey, you guys really need to look at the schedule because it's not keeping up with our actual costs?
So we haven't had the conversation with him because we have to have the conversation with our finance people first.
Okay.
And there's a model in New York State where they have pediatric CPAP units. In DC, CPAP is part of St. Elizabeth's.
Right.
So it's already through the state, well, through the city's Department of Behavioral Health. So they have hired all the people. They're already employees. And so the reimbursement is less of an issue. But if we're going to do it at Children's National, I have to have a business plan that would work. And we don't even know what the CPAP reimbursement rates are except in New York State. And I'm sure they're not similar
Okay.
here.
But this hasn't been a conversation where someone from our agencies have reached out to you all or to the association to say, hey, let's have a chat. And this is where the underscores, where I'm calling this hearing because I feel like we need a strategic vision around these issues. I hear about the challenges and I don't see what the roadmap is, as opposed to us just holding on for dear life and hoping that we have a plan or that it doesn't get worse. And I think that we kind of need to, we need some improvement here. Before my time is up, Mr. Coleman, Dr. Coleman, I wanted to ask you, or even Ms. Russo, who's sort of been involved in this, was there a particular decision point and or challenge as to why Cedar Hill will not accept adolescents? Like, is there a particular, like, the hospital has to do something specific to deal with that particular age group?
Yeah, I'll defer to Ms. Russo. I wasn't here during those negotiations.
You weren't here at that time. Ms.
Yeah,
Russo?
and I think it's a fabulous question, Chair Henderson. At the time that we did our initial assessment on what services were going to be provided at the new hospital, it was really based upon the Huron assessment of the gap. And I think we all have to remember that was maybe 8 years ago. And so upon that time, the adolescent services were not viewed as a significant gap. And given what was already being provided within the region, not just the District of Columbia, but within the region, it wasn't believed to be an actual need at that time.
Okay. All right. I'm over my time. Councilmember Parker, 5 minutes.
Thank you. Dr. Khan, I wanted to come back to you. If you give me 1 second, I lost my document. All right, here we are. I wanted to come back to the self-reporting over every incident. And so can you detail what that looks like? And by that meaning, you're reporting every incident to DC Health. And what is the follow-up from that self-report to DC Health?
So but there are some incidents that that are critical. There are some incidents that are mild. There are some incidents that would kind of fall in the in-between category. And then we self-report, and then Department of Health will follow up. And most times they will send a surveyor or investigator to review the complaint. And then that process includes review of the charts, speaking with our staff. So it's a very lengthy process.
And how many times has that happened this calendar year, that DC Health has sent a team out to survey or investigate after a report?
That's a good question. I don't have the exact number, Mr. Parker.
Okay. The challenge, as you can imagine, given what we are hearing, is that there are limited beds across the spectrum. And while DBH, I believe, manages the certification process, the question I'm raising is, is there a world where DBH can not certify PIW or hold you accountable in a real meaningful way? Yes, they can, but in practice, will they do that given that you are the main entity in the city to provide this level of psychiatric care across age ranges? You talked about needing to revamp the oversight system. In what ways would you say the oversight system from DBH and the Department of Health needs to change? And then I'm going to ask others, how might we recommend changing the oversight system for your respective agencies or hospitals?
Mr. Parker, that's good. Thank you for your question. The shutting down a place seems very punitive, but building relationships, building a better way to provide for our patients, building collaboration, and addressing the problems is a different thing altogether. Now, in terms of oversight, given that we already have a robust system in place, the oversight sometimes, if somebody else, like a consultant, comes in, can be at times very challenging, but we have been cooperative with all aspects of the oversight that has happened so far. And we will continue and look forward to build up on that, because our mission has not changed in the last 50 years and the 6 years that I've been at PIW, which is to provide care for the patient population, which we like to serve.
Okay. I will open it up to others. In what ways would you suggest we strengthen oversight from Department of Health or Department of Behavioral Health?
I think from the hospital center and MedStar's perspective, we have a very good relationship with the Department of Health and with Dr. Bennett and Dr. Bazaron with the Department of Behavioral Health. We tend to over-report situations just to make sure that no one is surprised by anything. And the elements that we report on could consist of a patient-related episode or a facility-related episode. And, there's good communication back and forth between both agencies and our hospital. Sometimes they feel like they need to come on site to do additional investigation, and we work very closely with them. Others, it's just an exchange of photographs, let's say if it's a facility related issue. Regarding the degree of oversight, I wanted to come back to a comment that Ms. Russo made, and that is the continuum of behavioral health care. I don't think there's a disease process that we care for in the district where there's better collaboration between the various institutions that provide it and the community. We know that it is it's a small community. Everyone knows each other, and there is routine movement of patients around the city as necessary. With only 3 hospitals that provide involuntary care, if a patient comes into the emergency department of one of those hospitals that doesn't, those patients have to be moved to one of those 3 facilities. If a patient comes to our hospital, for example, an FD12 involuntary acceptor of patients, if we are at capacity, we will move a patient either to another involuntary hospital, and that happens routinely across the city. The impact and connection of the core service agencies, the outpatient care, and the various outpatient programs that have been set up at the various hospitals that you've heard about this morning, the partial hospital program, the intensive outpatient program. One of the reasons why I believe that the inpatient census across DC has decreased over the last 5 or 6 years is because of the success of those programs. In the partial hospital program, that's someone who likely would have been an inpatient at one point. Now they're maintained at home. They're coming in every day. They're cared for from 9 to 5, and you're keeping them in the community. And the improved connection with the core service agencies has been key. We no longer have, someone being presented to the emergency department by their community provider and who then leaves and just leaves them there, or we have the difficulty with the handoff at the end of the hospitalization. We have excellent results around warm handoffs from all of our institutions to the community providers. And I can say from experience, that has improved dramatically over the last 8 to 10 years.
Awesome. Thank you.
Thank you. Councilmember Fruman.
Thank you very much. Dr. Khanna, I'm going to come back to PIW. I mean, Councilmember Parker asked about the number of self-reported incidents, and there is in a report a claim that there were 7 over a 16-month period of self-reported incidents from PIW, and then a comparison made to another institution where there was over 100 in a month. But is that the magnitude? Is 7 self-reported incidents over a 16-month period in your sense? You don't have to give me the exact number, but is it a number like that, or is it a number that's in the dozens?
Thank you, Mr. Furman. And I think, yes, that's good question. And I think the number that you're referring to is a number, I may be mistaken here, but you're pulling the number from the disability report. The answer, you have asked me some very specific numbers, and Mr. Parker also has asked me very specific number. I'd be happy to follow up and get you the specific numbers and the details for all these things. But the short answer, without the details, which I don't have with me at this point, is the numbers that you're referring to some old numbers, but I'd be happy to get you the new numbers.
Okay. And then in your testimony, you made a reference to a sense that the regulations were onerous and made your job of delivering care more challenging. I mean, you can imagine when there are reports out there of issues inside of an institution, they might be right, they might not be right, but when there are reports like that, it's not my inclination to lessen the oversight over that organization. But what do you think are specific things in the oversight that the city conducts over PIW that are too onerous?
One thing that would come to my mind is review of the process at length by by multiple agencies. So, and we've been cooperative with all the process, and we have been reviewing all the processes with the different agencies. And I think the numbers are different now than the numbers that you've referred to from the past. But given that we have now a very robust internal review process, our ask would be to make sure that the oversight is fair and judicious.
Okay. And I guess my last thing is, and you referred to, I cited from the disability rights testimony and reports. Has PIW, there's 3 reports, I think, by the Disability Rights Organization about PIW. So they've put a lot on the table. Has PIW offered a formal response to any or all of those reports?
I don't have the information to be able to answer that question.
So, I mean, you can imagine that when we see a series of reports like that from an organization like that it would be a source of concern. And so hearing from PIW what the explanation is or their response, I think would be something that would be useful.
Absolutely.
All right, with that, I think I'll turn back my time.
Thank you. Thank you to this panel of witnesses. I don't have any further questions, but we'll certainly follow up. Appreciate all of your engagement on this issue as we try to build out the continuum of care that's meeting all the needs of district residents of all ages. Thank you. All right, we'll go on to our next panel. Libby Deal, who's a registered nurse, Emily Bell, who's a psychiatric mental health nurse practitioner, Jacqueline Werner, who's the supervising attorney for Disability Rights DC. Kim Dalton, who's the director of social work for Children's Law Center. And we have one change, Dr. Shanique Cartwright, who is the behavioral health medical director for MedStar Family Choice, is going to join this panel. Okay. Okay, I don't see Miss Steele. I know. So we're gonna go to Miss Bell when you're ready.
Good afternoon. Honorable Chairperson Henderson and distinguished council members of the Committee on Health. My name is Emily Bell. I am and have been a registered nurse for 19 years and a psychiatric mental health nurse practitioner for more than 15 years. I have extensive experience in outpatient mental health clinics, inpatient psychiatry units, integrated psychiatry and primary care settings, and within emergency departments as a psychiatric consultant caring for patients across the lifespan. Having worked in public, private, and government facilities in 5 states has allowed me to bear witness to differences between how states administer their mental health care systems. While recently working as a psychiatric consultant in a Washington, D.C. hospital emergency department, I noticed several gaps in the system that impacted the quality and timeliness of psychiatric intervention. The first most significant gap is the involuntary bed shortage and the interrelated, inefficient transfer process to those facilities. Second, an important legal gap exists due to the lack of clarity about when exactly the 48-hour timeframe begins for the FD-12 psychiatric hold. The last significant gap I want to highlight is the lack of clarity of what to do for patients under FD-12 that are not medically cleared within an emergency department at a voluntary hospital. This phrase, medically cleared, means when the patient is medically stable to be admitted to the psychiatric unit for ongoing care. This gap is rare but serious because it happens when a true medical emergency is happening concurrently with a psychiatric emergency. There are legislative and regulatory changes that could impact all these current limitations. First, there's a known shortage of psychiatric beds across the United States. However, the local DC shortage is exacerbated when involuntary facilities refuse to accept appropriate transfers from emergency departments and hospitals with voluntary psychiatric units. This results in a backlog of patients waiting for transfer many hours or days if they're accepted at all. DC should consider significantly expanding the number of involuntary beds by allowing all public and private facilities and units to accept involuntary admissions. Other states where I've worked do not designate voluntary versus involuntary bed hospitals in this way. This unnecessary restriction may be hindering the timely evaluation, transfer, admission, and treatment of DC residents in mental health crisis. Second, when an individual is placed under a psychiatric hold, it's imperative for the facility and the treatment team to know the accurate length of time they have to evaluate, treat, and make recommendations for this patient. There's a current lack of clarity about exactly when the FD-12 psychiatric hold 48-hour timeframe begins, which impacts the treatment's team ability to plan for discharge. Does the timeframe begin when the form is signed and dated? Does the time begin when the patient arrives or when they're checked into the facility? This is something I highly encourage the committee to help clarify. Lastly, in an emergency department, the medical provider ordering the psychiatric consultation will simultaneously evaluate the patient to see if they're physically stable or, quote, medically cleared for a psychiatric admission. Usually this is a simple process and does not delay or disrupt a psychiatric admission. However, when a patient arrives with both a true medical emergency happening concurrently with a psychiatric emergency, this becomes more complicated. Moreover, there is a gap that fails to recognize when a patient is not yet medically stable before the end of the 48-hour timeframe. Though this may be more common Though this may be more uncommon than the first two gaps, this is important because it negatively impacts patients that are initially admitted to medical units, including those admitted to an ICU following serious suicide attempts. Other states where I've worked take this medical clearance process into consideration. It allows individuals to receive emergency medical care, stabilize, and then focus on their mental health recovery once they're medically stable to do so. I thank you for this opportunity to testify on this important and pressing issue. Thank you.
Thank you. All right, we've been joined by Ms. Steele.
I apologize for the technical difficulty, and I want to say thank you to the council for allowing me to testify. My name is Elizabeth Deal. I go by Libby. I am a registered nurse in the District of Columbia, and I am a former employee of the Psychiatric Institute of Washington. While it is nice to see some of my former colleagues here, and I want to treat them with compassion, I do want to answer some of the questions Commissioner Freeman and Commissioner Parker had. The answer is that there are daily incidents of violence at PIW. Most often, these incidents of violence are patient on patient, but sometimes they are patients on staff. I myself was employed at PIW from April 2023 to February 24. Only 10 months, and I was physically assaulted 3 times. I loved the population I worked with, and I'm very sad that I can no longer work there, but it was personally unsafe for my physical safety and for my own emotional well-being. And I'm so sorry, I need to compose myself, because the issue of mental health care in the District of Columbia, particularly for adolescents whom I worked with, is atrocious. First of all, there does need to be more staff, but in order for there to be more staff who care, like myself, it needs to be safe. What I would recommend, and I have lots of recommendations, not all of them I think are appropriate for this setting, but there definitely needs to be mandated staffing, especially for facilities that accept the FD-12 patients. And not only does there need to be mandated staffing ratios, particularly for the number of mental health technicians who do the majority of the work in these milieus, but there also needs to be security. I spoke to PIW leadership on numerous occasions about the lack of security staff at PIW, and I was told numerous times that it was in an attempt not to re-traumatize our patients, many of whom have had negative interactions with law enforcement and security officials. While I understand this, and I, of course, always wanted to provide, compassionate care, the safety situation, particularly inside PIW, is unacceptable. It's unacceptable for staff, but most importantly, it's unacceptable for the other patients who are there seeking treatment. There was so much covered already that I don't even really know where to begin, and my prepared statement has gone out the window. About the continuum of care, particularly for adolescents, I think one specific thing that would be beneficial is a need for a patient liaison and that can connect with the outpatient case managers who are familiar with the core service agencies. Parents are often too overwhelmed or do not have the health literacy themselves or the socioeconomic situation to really care for their children. They're with these high acuity needs. And so many of the adolescents we work with come from institutional settings, and maybe their parent is not in the picture. I also will reiterate Dr. Khan's need for a live database. So many of the frustrations I had as a nurse working inpatient was you would see frequent flyers, but every time they came into the acute setting, it would be like starting from the beginning or trying to figure out where they left off in our community and continuum of mental health care. So I'm sorry, I'm so unorganized right now. There's so much going on in my head. The other thing that needs to happen is we need to have better pay and working conditions for our behavioral health techs. You really need to understand what it looks like working inside one of these facilities, and our behavioral health techs carry the weight. There's often 18 to 21 patients, and there will be one nurse with maybe 1 to 2 techs. That is not enough when one of the techs is responsible for doing a Q 15-minute check on every patient on the unit. And the other tech is responsible for meeting a lot of the basic needs for patients. Patients in these types of settings are not allowed access to a lot of their personal belongings. A lot of times they just have simple requests like I need a towel or I need a tissue. And those requests have to be met by the staff, but we're short-staffed. I have a lot of ideas about the new facility that UHS is opening and GW is opening on Cedar Hill and requiring beds. Like I said, some of the things I would like to say, I don't want to say in this setting. So I would really appreciate and welcome the chance for this committee to speak again or to meet in a different setting. I only have 8 seconds left, so I'm going to end here. And one more thing that I really wanted to say. I read the disability rights report several times. I recognized a lot of the language in there. The one thing that I think really upsetted me was that there was a lot of mention about what the staff is doing. And I didn't think there was enough onus or responsibility put on the leadership of PIW. I think Dr. Khan is very brave for testifying today, but the person who needs to be sitting in this chair is the CEO, Eric Amo. And as well, the chief nursing officer, who at the time I left was Nicole Parker. These people have a lot of questions that they should be answering, not the medical officer, when it comes to the processes and policies of PIW. That is all I have to say, and I thank you so much for your time. And again, I apologize that I got a bit emotional.
No, it's okay. Thank you.
Very traumatic experience for myself, but I appreciate this opportunity.
Thank you. Thank you for being here. Ms. Werner?
Yes, good afternoon, Chairperson Henderson and committee members. Thank you for this opportunity to testify at this roundtable. My name is Jacqueline Werner, and I'm a supervising attorney at Disability Rights DC at University Legal Services, the designated protection and advocacy program for people with disabilities in DC. I'm joined by my colleague, Andrea Procaccino, who's another attorney at our office that's available to answer any questions that might come up. Pursuant to our federal mandate, Disability Rights DC advocates on behalf of hundreds of DC residents with mental illness each year. Our testimony today is focused on 3 areas that we will touch on briefly and that are discussed in more detail in our written testimony. First, as you know, DRDC continues to be concerned about patient safety and well-being at the Psychiatric Institute of Washington. We share in many of the same concerns that Libby just pointed out and absolutely agree that it is not just about what the staff are doing and that the leadership absolutely needs to be held accountable. In July 2024, we published our 3rd report since 2021, documenting abuse, neglect, and dangerous conditions at PIW. DRDC's reports have included adult and adolescent patients being abused and traumatized, being sexually assaulted, and sustaining serious injuries, including head injuries and fractures. Many patients reported feeling frightened, traumatized, and reluctant to seek mental health services in the future. Our reports have also cited failures at PIW, including insufficient staffing, insufficient supervision on the units, and an inadequate risk management system. PIW must make changes that put patient care above corporate concerns. At a minimum, staffing levels must be maintained at a number that ensures patients are safe and receive therapeutic treatment, and staff as well need to be safe. Staff must receive mandatory, intensive, and sustained trauma-informed care training, which also would be for them, as well as more support from supervisory staff. PIW must adequately staff their risk management department and increase its effectiveness. They must also be more transparent and provide the district government agencies and DRDC with all incident reports and investigation reports when requested. The district government can also do more. For years, DRDC has made FOIA requests to DBH for incident and investigation reports received from PIW, as well as internal investigations completed by PIW. Yet, we have received very few documents. For example, as has already been pointed out today, what's noted in our July report is that they're excluding incidents of restraint and seclusion for a 16-month period from January 1st, 2023 through March 4th, 2024. PIW submitted only 7 major unusual incident reports to DBH. During the month of February of 2021, February of 2024, there were 21 incidents of restraint and seclusion reported. So I'd like to note that. Contrast this, though, to St. Elizabeth's Hospital, which reported 109 MUIs for the month of March 2024 only. DC Health and DBH have oversight and investigation responsibilities at PIW, yet in some instances, the agencies failed to adequately investigate reported serious allegations. For example, in February of 2024, DRDC reported an allegation of a serious assault at PIW, which is referenced in our July report, to DBH and DC Health, and both agencies acknowledged receipt of the allegations. In April of 2024, in response to our follow-up email, DBH indicated that they do not normally investigate patient-on-patient assaults, and that since the allegation involves staff failure to respond, it would be a DC Health issue. DC Health has yet to provide evidence of an investigation. Moreover, DRDC received no evidence that PIW itself performed its own investigation of the incident, though under DBH policies, DBH can and should require it. So DBH, DC Health, and DHCF actually all have oversight responsibilities in the authority to take action to ensure the physical and emotional safety of patients admitted to PIW. So I want to quickly just touch on the district's current 1115 behavioral health transformation demonstration Medicaid waiver, which is relevant to this conversation. In 2019, the district applied for this waiver to be authorized by CMS to bill Medicaid for the full length of short-term acute psychiatric inpatient stays for individuals aged 21 to 64. So these are IMD admissions. An important reason to discuss the district's current 1115 waiver when discussing the oversight of PIW is the fact that when approving this waiver, CMS placed special conditions of participation on the district that must be met if the district is to continue to receive federal financial participation for IMD services. And PIW is the primary IMD facility in the district. So there's a whole lot of detail that I don't have time to get into, but CMS's special conditions of participation for this waiver have significant implications for PIW and this roundtable regarding that they have to follow CMS's special conditions for hospitals. The district has also promised to engage in much better care coordination and to be assessing the housing situation of beneficiaries transitioning to the community from psychiatric hospitals. We see that often not happening in PIW. And this is DHCF's responsibility under the waiver. Finally, DRDC also continues to have serious concerns about the district's ability to provide effective and responsive behavioral health services for youth and children. For district children and youth to thrive in our community, there must be intensive community-based care that does not remove them from their homes into institutional settings. This removal process creates another opportunity for trauma and imposes re-entry barriers that the district has historically not navigated well. We continue to hear of and work with youth who experience hospitalization, incarceration, and out-of-home placement, and these children were never offered and never accessed robust and community support. So overall, we urge the council to hold DBH, DC Health, DHCF, and PIW accountable to each agency's and entity's obligations under the law, and we welcome any questions.
Thank you. Ms. Dalton?
Good morning, Chairperson Henderson and members of the committee. My name is Kim Dalton, and I'm a Ward 5 resident. I'm testifying today on behalf of Children's Law Center, where I'm the Director of Social Work. I have been practicing social work in DC since 2004, starting as a community support worker at a DBH core service agency, and then as a child welfare social worker and supervisor before coming to Children's Law Center. Our social work team and attorneys work together to assess client needs and identify appropriate interventions, including behavioral health services. Thank you for the opportunity to testify at this roundtable. Our clients include children who are in foster care, students with special ed needs or health conditions, and caregivers who need legal support. Across our client communities, our attorneys and social workers spend a significant number of hours trying to identify and coordinate behavioral health services through the public system. Today, I will discuss how gaps in the behavioral health system lead to the escalation of behavioral health issues, repeated crises, acute inpatient psychiatric hospitalizations, and in some cases, arrest and involvement in the delinquency system for youth in the district. These gaps include insufficient access to community-based behavioral health services, inadequate crisis response systems, poor discharge planning and post-discharge services, and the lack of intermediate and long-term intensive treatment programs. Our clients seeking behavioral health supports in their communities are often unable to access the services they need in a timely manner due to protracted referral and intake processes, poor communication between providers and the team supporting the child, and long wait lists for specific services like community-based intervention, also called CBI. For example, one client waited months to be assigned a therapist after being administratively linked to a core service agency or CSA by DBH, and then went 2 years without a video or an in-person session. Instead, the client only receives sporadic, unscheduled phone calls from the therapist. The client was also not notified when the therapist went on extended leave and eventually left the CSA altogether. In another case, multiple team members attempted to reach the client's assigned CSA for several months to set up CBI services before learning from DBH that this CSA no longer provided CBI. During these extended periods waiting to receive services, youth with untreated or undertreated behavioral health needs can experience crisis situations. CHAMPS can be a crucial resource for de-escalating youth and connecting them to more intensive treatment if necessary. Yet response times for CHAMPS are often so long that police end up being called, which can result in escalation of behaviors and arrest of the child in crisis. We've had foster parents say that they cannot foster children with high behavioral health needs because they can't rely on crisis responders to show up quickly. This impacts placement stability, resulting in further distrust, disruption of existing services, and delays in initiation of new services. Youth who have repeated crises can end up in cycles of hospitalization where they are temporarily stabilized and treated, but then, due to the many of the reasons I've shared, don't receive the services needed to comprehensively treat the underlying behavioral health issues. The fact that youth often don't receive sufficient care when leaving hospitalization is likely also due to the structural lack of intermediate level services and to inadequate communication between the entities responsible for coordinating care after discharge. The district does not have any intensive outpatient programs, partial hospitalization programs, or bridging clinics, which are models of intermediate level of care that provide structured programming and treatment to youth transitioning out of inpatient or residential care. There is nowhere in DC for youth to go when they are not stable enough to be at home, but not unstable enough to be kept at the hospital. This likely explains why discharge from hospitalization is a common point of entry into the foster system for teens. Their parents are sometimes labeled unwilling caregivers because they don't have enough support to meet their child's behavioral health needs. The lack of intermediate level services also exacerbates the already strained capacity of community-based services, which hospitals must recommend for youth being discharged because no step-down or bridging programs exist. When youth need longer-term inpatient services, DC has no psychiatric treatment facility or PRTF. Our clients are often given no choice but to go to a PRTF hundreds of miles away. Having a local PRTF would facilitate youth reintegrating into their communities by allowing regular visits with family and other community connections to maintain relationships, practice what they've learned, and see where adjustments are needed. We want our clients and all DC children to be able to access the appropriate interventions and supports that meet their needs. I truly believe an ounce of prevention is worth a pound of cure. For this to happen and to ensure the effectiveness of acute crisis intervention and stabilization, we must have a functioning public behavioral health system with adequate capacity and a full continuum of services. My written testimony will expand on the issues I've discussed today and offer specific recommendations on how to fill the gaps in that continuum. Thank you, and I'm happy to answer any of your questions.
Thank you, Ms. Dalton. Dr. Cartwright.
Chairperson, please.
Oh, yes, ma'am.
Sorry. Good afternoon, everyone. And thank you, Chairperson Henderson, for inviting MedStar.
If you could just move the mic. Yep, just lean in on it.
For inviting MedStar to this hearing. My name is Dr. Shanique Cartwright. I'm the Behavioral Health Medical Director for MedStar Family Choice. And I represent the person who sort of structures programs and also assesses behavioral health for the 60,000 enrollees that we serve. MedStar has been focused over the past year on understanding the system that we have in front of us and trying to make sure that we structure programs that are appropriate in every age bracket. So we've looked at, for example, we're starting to plan maternal programs. What does each person within a family need as a family is expanding? How do we address some of the disparities, for example, with maternal psychiatric issues and also physical health care, particularly in African-American ladies where complications may be higher. We are also looking at school programs and how do we address the needs of children and youth within the school setting as well as within inpatient settings. We are looking at young people going into adulthood inpatient units, for example, in that regard, and also structuring something called an open access program, where we are physically going to locations of providers in order to get a better understanding of the capacity that each one of those offices has, and how do we move information from places where there is a need to offices that have the capacity to take care of those enrollees. some of what we found, and I'll just expand on this because I think that this is important. Some of what we found is that even when you look at the measures report, for example, that is on the district's website, of a $300 million spend for the budget, I think it was in 2021 or 2022, the majority of the funding went toward community support and also toward ACT services. But when you look at the percentage of funding that is being utilized within outpatient services, it's a very, very small percentage, which in other areas you would not expect to see that. You would expect that that would actually be a foundational cost, meaning that the majority of the cost would be absorbed in outpatient clinics. And so with our open access program that we're developing, we go to outpatient clinics, we get an understanding of how many persons each clinic is able to take on as new patients. And then we're also looking at, can they get walk-in appointments? Can the clinic access children and take care of children as well? Do they have Saturday hours so that we expand it beyond Monday to Friday when parents may be at work or children may be in school? Then we are also looking at, do they have family therapy, individual therapy? What is the capacity to take on those persons? Who is providing care? And how do we make sure that we get that information out to our enrollees? And so we're in the process of, like I said, moving that program toward taking on more and more persons so that people have access to care. But some of the feedback that we've received from the clinics that we've spoken to is the no-show rate is very high. And so some of the question that we've been trying to ask ourselves is, how do we get persons to be able to move from inpatient units over to outpatient clinics? Because in the hospital setting, you'll see inside the charts when you review them, that many of the persons will tell you that they go to the hospital when they need their next injection. Even if it's documented that it's recommended for the person to go to their outpatient appointment and you see dates and times there, and MedStar Family Choice even provides the transportation benefit and will take you to your appointment. Many times what we've been told by clinics is that the no-show rate can be anywhere between 25 to 40%. So the way this impacts the clinics is that they then have to ask themselves the question of how much are we to invest in having a psychiatrist or a psychiatric nurse practitioner on staff if the no-show rates are going to be so high. You can't bill for patients who are not seen, and you can't bill when the hospital will send an enrollee directly from the hospital to the outpatient clinic, even for them to be able to familiarize themselves with the team that will be taking care of them as an outpatient. So MedStar, again, has a firm understanding that this is an issue, and we are trying to be as creative as we can to be able to address those concerns. And we also looking, for example, at medication delivery based on some of the initiatives that we've had. We ran a study at United Medical Center from February until August of this year, looking at the impact, for example, that medication delivery directly to the hospital for the enrollee to take home, how does that impact their readmissions? And what we found was that it reduced readmissions by about 12 to 15%. So right now, what we are working on is trying to figure out how do we expand that program to all of the enrollees that we serve. So I see my time is up, but again, I just was trying to give sort of a comprehensive look at what we are trying to do to assess some of the concerns for persons in the district.
Thank you. And thanks to all of the witnesses. Ashley, if you put on 10 minutes, my colleagues aren't here, so I get to ask more questions. I want to thank all of you for presenting your testimony and again, providing an interesting perspective. I think each of our panels have an interesting perspective to bring to this conversation and some of the things that we talked about. Ms. Dalton, I'll start with you. You know, I think our first panel for the hospitals are talking about those who need the acute care, stabilization in that moment. And you talk about sort of the lack of intermediate care services, specifically partial hospitalization, intensive outpatient. Which I think is very interesting, and I think also something that we're hearing of, right? Not everyone needs to be treated in a hospital setting, but what are the other options that are available to individuals? When you all are doing case management or on behalf of young people or families or representing them in terms of the client space, what are you finding specifically if a person could benefit from, say, intensive outpatient, are you having to refer to Maryland and Virginia? Do those facilities have space? What does it look like as you're working with a family through that process?
Sure. So it's my experience, Chairperson, that the insurance won't necessarily provide or pay for the services in some place like Virginia or Maryland. So even if I've identified an appropriate partial hospitalization program, which I have, then there is a need to do like a individual contracting if the insurance is even willing to pay for that level of care.
Okay. And I think that's kind of interesting because I would feel like for our insurance companies would have a stronger understanding of what providers in their network are available in district versus not. And this is a clear area where it's not available. So like if you're not going to Maryland or Virginia, then your patient is simply going without, which
right.
is super unfortunate. Ms. Verner, I thank you so much for being here and for the work that Disability Rights DC does. I've had conversations with both DBH, DC Health, and the Deputy Mayor for Health and Human Services around quality and oversight in terms of incidents that occur at PIW. What I found in some of these conversations is that there's a mismatch. So incidents that you all wrote about in your report, DBH or DC Health have no record of, either from the institution or otherwise. Can you talk a little bit about the practice of DRDC in terms of if you have a client who comes to you and says, the following happened to me, are you all required to report that to DBH and DC Health? And if not, then why not? Because I kind of feel like in some instances, I can understand from the agency perspective of you have these incidents that are in your report. You have this knowledge of these particular incidents. If the institution itself is not reporting it, how can the agency follow up on it if they don't know?
Yeah, if you don't mind, I'm going to start us off and then Andrea can elaborate a little bit more quickly though. So I just want to give some background as to the fact that Congress did not, and we do, of course, we take the position we do tell DBH and DC Health. So we do not agree with, but Congress did not create the National Protection and Advocacy Network for people with disabilities, of which we are a part of, we're not required and nor can we report things to district government agencies, number one, if we don't have consent from the person who's coming to us to talk with us.
Okay.
And we were not created by Congress to assist these DC government agencies with doing their own job. And so that's number two. But I'm going to let Andrea take it over with the rest of our answer.
Hi, I'm Andrea Procaccino, a staff attorney at Disability Rights DC. Yes, I went through our latest report and we did either DBH, DC Health, or both knew about every incident. We reported several of them with letters asking them to investigate. And we also got information in our latest report. Much of our information came from FOIA incident reports that were reported to DBH. So part of our problem is DBH, and we've discussed this with DBH, they're not reporting that many incident reports. Aren't you not concerned with that? You know, when we FOIA and bring this up, they're not reporting incidents, but when they do report the few that they do, and there's a serious injury, there's a fracture, someone gets a fracture, why are you not investigating this yourself? As Jacqueline said, it's not our job. We have legal restrictions on what we can report, but when we have permission, we do report. And lately, we have not gotten any investigation reports back at all.
Is that
from DBA, DC Health? DC Health has gone and investigated.
Okay.
And has done some robust reports.
Is that the normal feedback loop where if you guys bring something up that the agency would respond or tell you that an investigation has been started and or completed?
Yes, they for the two that I reported in our last report, I got confirmation from both agencies that they've received the information and our request to investigate. Typically, DC Health has gotten back to us with some of their investigations. DBH lately has not been investigating or providing investigations to us. I'll put it that way. I'm not sure if they've investigated, but they haven't, which they typically did and they're required to do.
Okay. I brought up the report again when I met with all three of the agencies, and I met with them together because the finger pointing, there's a lot of overlap, but I just feel like if everybody's in the room together, then we can all be on the same page of music. And I started with one question. If PIW closed tomorrow, what's our plan? Because I feel like I have an institution who has nearly 60% of our FD12s. They're our only freestanding psychiatric hospital. I worry on our end that perhaps we are not conducting the oversight necessary because they're our only game in town.
Well, as we point out in our written testimony, there are things that government agencies can do to ensure compliance, to keep patients safe, to keep the staff safe. And we don't feel these things are, we elaborate that more in our testimony. DBH has a contract with PIW. DBH could change the contract, could maybe enforce the provisions of the contract more robustly.
So let me ask this though. I feel like there is a difference though between compliance on health and safety and quality of care that a patient might be receiving, right? So if I would talk to the agencies, they would say, we go in and we do the compliance checks, right? Do you have the right amount in terms of ratio of staff? Do you have the right number of, I don't know, soap dispensers, whatever the particular regulatory piece is? But that's a checklist. That doesn't get to, are we helping patients in terms of the delivery of care that's being provided?
Well, to us, there's a safety concern and then there's a quality of care.
Okay.
We've been focused on safety because we haven't even gotten to quality of care because we haven't had time because we're focused on the safety. And so they can ensure that PIW and the district government have to ensure that patients are safe. It is unacceptable. Other facilities don't get these complaints. Other places seem to manage without so many incidents of serious abuse and neglect.
Okay.
And so
is it a function of size?
it's a function, as we point out in our report, of many things. And it's a for-profit company running the institution. As the nurse pointed out, it's probably hard to get staff because staff don't feel safe there. It comes from nursing supervision. The nurse described it's usually just 2 techs out on the floor. Where are the nurses? Do they need more RNs to support each other and the behavioral tech staff? Do they need more intensive trauma and care training? I mean, there's a myriad of things that have been shown to work to improve institutional care.
Okay. Ms. Steele, you have your hand up.
Yes. Thank you for the opportunity to speak again. I think what the last speaker was just touching on, PIW is run by UHS. It's a for-profit institution. And I think because it is the only game in town right now, taking care of 65% of the district's FD12 population, the district can't shut PIW down. And PIW knows that. I think that most people who work at PIW do have really good intentions, and they're not set out to work at a place that has these safety and quality issues. But if you want to affect change at PIW, I think the way to do it, and this is my personal experience or personal opinion from being on the inside, is that you have to convince them you're going to have to affect their bottom line, because that is what UHS cares about. They care about their bottom line. So if you take away their contract, if you modify their contract, or if you require UHS maybe to open some more FD12 beds at their new Cedar Hill facility, I mean, maybe that's not punishment for them, but they can atone for some of the abuse and neglect that is occurring at their other facilities by having to pony up in other places and more beds. But again, I have a lot of ideas about this and a lot of things I would like to say that either need more time to organize or it needs to be a different discussion in a different setting. Thank you.
Thank you. We've been rejoined by Councilmember Fruman. I'm over my time. Councilmember Fruman.
Thank you very much, Chairwoman Henderson. Ms. Deal, thank you very, very much for your testimony. Really important testimony, and thank you for the work that you do in this area and your passion for it. You referred to, and I think some of the other witnesses have referred to, 1 nurse and 2 health techs per 21 residents. Is that what the ratios are?
When I was at PIW, we were supposed to have a second nurse on the floor anytime there was over 18 patients. That was often not the case. And the thing you also need to realize is even if we were adequately staffed with 1 nurse and 2 techs, anytime there is an incident or a code lavender, as they're called in another unit, one of our techs or even sometimes both of them need to attend to the code. So then you're left shorthanded on the units. Patients know that. Patients are aware of that. So then there might be an incident occurring on one unit, and that's a moment of opportunity for, things to erupt on another unit because they know you're by yourself. On one particular time I was attacked, it was because my tech had left to go assist on another code. I was by myself on the unit. There you go.
When I was there was one of those codes happened and people were scurrying around to different places. But when you go ahead.
I was going to say, PIW is operating under incredibly difficult circumstances. It's very difficult for me to be here as a past employee for PIW because I think so many of the people I worked with really are doing their best. I think the changes, like I said in my original testimony, leadership. I'm shocked that the CEO, Eric Amo, is not sitting here and speaking up for PIW. It's disappointing.
I appreciate that. Actually, I've have old family friends whose child worked at PIW for a period of time, and I know the passion of people who work there. But what I was getting at is that 1 nurse, 2 health techs, that's the grid that Dr. Khan was talking about. And so then there's another question of whether that grid is adequate. And Dr. Khan said that the agencies had reviewed the grid, but still it raises the question of whether or not that grid is adequate. Is that fair?
It's not adequate. I'll tell you as a staff member, it's not adequate. By the number of violent incidents that occur on these units, it's not adequate. It's also not adequate, and this is another point I wanted to bring up, because the current model at PIW houses your FD12 patients with your voluntary patients. That's not safe. It makes no sense. But they will put a patient in a bed because it's an available bed and there's already a shortage of beds. So that's how units are staffed, but it's not safe and it certainly doesn't provide quality care.
I hear you on that. And if it's not adequate, then I guess that's also a regulatory issue because PIW says we have a grid, it's been signed off on. So then it becomes, you can't blame them for staffing at the level that they're approved to be staffed at, but your point is you believe that that's not adequate.
And you can't blame them for when staff don't show up or staff get assaulted and have to go home early, but then there needs to be backup measures in place.
No, I hear you on that, and I hear you in your reaction to the disability rights report that you felt that it put too much on staff, which I doubt was their intention.
No, I know it wasn't.
And we did have, we had the episode last summer where there was the breakout, where there was an elaborate scheme to a ruse, I believe, at a suicide attempt, and then they were able to get the keys. The people who were there and escaped got the keys from the nurse or the health tech. So giant challenges in these facilities. So thank you very much for your testimony on this subject. We will follow up. My office will follow up with you. I think it's probably more important that you be talking to folks who are on the health committee. I'm here because this is an important issue and an important institution in Ward 3, but I don't serve on this committee. So
well, you're my council member. So.
And by any chance, is that a painting that my wife did over your shoulder?
Is it? We bought it at Friendship Heights at a gallery.
It looks like one of hers, but I don't see her signature. I have had that. I actually had that in a setting where somebody was, he came on screen and he had a picture in the corner and I thought, okay, this is a friendly one. And he just like went after me while he was sitting under the picture. He's still fond of my wife though. Anyways, so thank you very much. Turning to the other witnesses, I'm not on this committee and I have incredible confidence in Chairwoman Henderson, but I'm curious to hear suggestions about how we change the oversight framework so that we can get at these issues and how we change the incentive structures, because there's been some talk, it's a for-profit business. They need to make money as a for-profit business. There's punishments, but there's also incentives. Like how should we as a government be overseeing them? And how can we, both through enforcement, but also incentives, get to better results than we're getting today? So I'll turn that to the panel sitting here.
Hi, this is Jacqueline Berner from Disability Rights DC and Andrea Procaccino. Just to start off, I think in terms of the oversight piece, and Andrea can absolutely elaborate on this more than me, but yes, DBH has a contract with PIW. That's for involuntary beds, which they point out. However, DBH's Establishment Act and the DC Code is much broader than that. And so I'm just going to read the language that it already has. It says DBH shall be the exclusive agency to regulate all mental health services and mental health supports. DBH is also responsible for creating standards and procedures for internal and external monitoring and evaluation of the delivery of mental health services and mental health supports. That's very broad and clear in our perspective, that it does have oversight authority over PIW. And so I'll let Andrea, if you want to elaborate a bit more on the conversations that we have had with them about that.
I mean, really, since our first report, we've tried to meet with DC Health. We've met with DBH. We've encouraged them to work together. We've encouraged more investigations without us having to report when they get an incident report that there's been an injury, that DBH should go out and investigate by themselves without us having to write the letters saying we don't know. We FOIA this information. We haven't gotten evidence that they're doing investigations of PIW. We should be getting the redacted incident reports. We FOIA, we don't get them. So that's all I can tell you. And I think a more collaborative approach with the district agencies that do have oversight and can require standards, can require investigations. DBH can go out and investigate anyone that gets injured there, that maybe that's the standard. If there's an injury, a serious injury, they go and they investigate.
Hi, I'm Dr. Cartwright from MedStar Family Choice, DC. I think we also have to look at the substance abuse and the way those factors contribute to some of the behavior of the persons who are entering the hospitals. I distinctly remember attending a DC Hospital Authority meeting where the chief of police was also present because the degree of violence in the emergency rooms was also increasing. And so at MedStar, I was trying to sit down and think to myself, what is the common thread here? Can we look, for example, at the incidence of substance use and what can we do to sort of drive persons to programs that may be helpful? But what ended up happening is that it was very difficult to be able to conceptualize the number of persons with the primary driver being something like PCP use or acute drug intoxication, because that is not a billable diagnosis. So what ends up happening, you may have certain street terms, for example, for PCP, just based on the behaviors that persons exhibit when they're intoxicated. When they go to the emergency rooms, you will see that those persons would be combative. When we try to find the numbers in order to see how we can quantify the number of persons that's impacting, because of the laws that protect privacy with substance use, we can't find them. So because we can't find them, we can't structure a program to gear it specifically toward that. So you may say, what is the long-term implication of that? The long-term implication is if you have a parent who has 2 children, and that person is between the age of 40 to say 55. And the reason I use that age bracket is Howard University Hospital did a study a few years back, and they looked at the number of persons who were using substances for the first time. And what they found was that was the average age range where you saw substance use. Their children are not going to have someone to help with homework when the parent is intoxicated. It is very difficult to hold relationships together when you're intoxicated. It is very difficult to help to hold a family together in times of economic stress when you have a parent who may be using substances, but we can't find that information because it's not going to be listed as the primary diagnosis when you go into an emergency room. How do you correct that? I don't know. I've continued to think about it, but again, this is, in my opinion, a multifaceted problem. We also have to look at alcohol use. When we did our study at United Medical Center, what we found was one of the larger drivers of persons going to the emergency rooms for acute care is acute alcohol intoxication. How do we educate the general public about that? Also, when you look at, for example, some of the studies that came out of Colorado, where you saw rates of psychosis increasing as marijuana was legalized. What is the impact of that in the district? I'm not saying I take a position one way or the other on utilization. I'm just making the point that there's always a consequence to whatever it is that we choose, and we have to be able to deal with those consequences as we take care of the persons within the community, whether it's education, whether it's rethinking the ways that we can provide care for persons in those situations, I don't know. But again, at MedStar, we are trying to make sure that we have a thoughtful approach to some of these community issues, because I don't think it's just one specific problem. You have experiences across a lifespan that may be stressful to some at one point in their life and then stressful to others at other times. So how do we make sure that we take care of all of those persons across the lifespan? And I recognize that with inpatient hospitals, they present their own issue. One of the things, for example, that we've introduced for at MedStar Family Choice with making sure that we partner appropriately with PIW is the McClendon Center program. So McClendon Center goes into the hospital to assist with the discharge planning for the enrollees when they are preparing to be discharged. McClendon Center is responsible for a 30-day follow-up appointment at day number 7 and also at day number 30, so that we at MedStar can see what else can we do to improve outpatient appointments so that the enrollees, again, get better without having to be readmitted to the hospital so frequently, and also to address some of the concern that other persons on the panel have articulated. What we've also done is added one question to their assessment when they're leaving is, what has the MedStar Family Choice enrollees experience been at PIW? Thus far, we've not received any negative feedback. That doesn't mean it will not change, but we are having an independent party be able to ask those questions so that if there is an issue, we can track them.
Dr. Cartwright, I wanted to ask a follow-up question because I find this to be very interesting, right? As you mentioned, there could be an individual who presents in the emergency room in sort of need of mental health care, when in fact, a lot of their actions, as you say, are being driven by substance use of some sort, PCP otherwise. I'm sort of troubled by this idea that you all on the back end as the MCO wouldn't have information that would allow for your folks to follow up to say, once that person is stabilized and discharged, for you to be able to say, okay, we might want to encourage this person to enter a treatment program or otherwise. How else would you, in the absence of a billable code, to share that information as to why that was the primary reason for this person's visit to the hospital? How else would the MCO find that information?
So again, what tends to happen is that if a person goes into a facility, an acute care hospital, whether it's the emergency room, a psychiatric facility, what you will see is the primary code would be psychosis NOS. You'll see a secondary code that may have PCP intoxication, or it may have cocaine positive based on urine tox screen. If you go through the individual charts, you can find that documented, but as a managed care plan, if you look at what is the primary diagnosis on Axis 1, if the driver is psychosis NOS, because that's the best descriptor of what the person is experiencing when they enter into the emergency room, the substance use may be protected information. So again, we still pay attention. We still see that the facilities will offer substance abuse care to many persons. But the point that I was trying to make is that to structure programs specific for something like PCP use specifically, or cocaine use specifically, it's a little bit more difficult because of the primary diagnosis will almost always be psychosis NOS.
Okay. So then are we missing something? Or are you suggesting that we need to figure out some way to sort of change that?
No, I think that we are doing our best, again, to make sure that we are as meticulous as possible to look for ways that we can take care of persons within the district. I think we have to figure out how to engage persons more efficiently. And my task and my responsibility is to figure out, what do I need to do in order to get persons from the hospital to now have a solid relationship with the outpatient provider that they feel they have a therapeutic alliance with, so that we can turn the tables on what it is that you see referenced inside these measures reports, which is that a small number of persons are engaging with outpatient clinics. What was interesting, and then I will be quiet. I'm not trying to take all the time.
No, go ahead.
But what was interesting was when I went to at least 3 different on-site visits with the clinic, they had capacity for at least 1,000 new admissions each clinic. That would have been 3,000 new appointments that were available to the community. But when I go to some other places, I'm receiving feedback that we don't have a place to send persons. And on that call, I can say, but this particular clinic has 1,000 spots available.
Right. So this is the mismatch that often comes up, right? So I will hear from family members, or I'll hear from folks in the community that will say, we don't have enough capacity. And then DBH will say, no, we don't have wait lists at some of our places. And so then I'm like, okay, well, what's the mismatch?
I think the mismatch comes from when you have a patient population who may have had some practices where they are not accustomed to going to outpatient appointments. They have started to see the experiences. If I'm having difficulties, I go directly to the hospital. Then that becomes problematic because the person only returns to the hospital when they're deteriorating. I mean, it would make me happy to actually be able to reimburse more outpatient clinics. We approve persons for care. We want people to be able to go because it's a better spend of taxpayer dollars when you're much more responsible and can keep people out of a hospital setting.
Right.
But we still have a responsibility to take care of them wherever it is that they are, and to make sure that we educate the persons who are utilizing the hospitals frequently. We look at ACT team services, for example. How do we go ahead and improve ACT team services? Now, the Department of Behavioral Health recently increased the reimbursement rate. But the question is, are you still going to get the outcomes that you want? What are the goals? So there's so many different aspects to behavioral health care as a whole that you see in the district. I don't think that it's terrible or that people are not working the hardest. I think that anytime you have a process that a city or an area is going through, you can always have room for improvements.
Right.
And so our goal is to make sure that we identify areas where there may be some weakness and do our best to provide support for providers and the enrollees.
Well, I think there's definitely area or space for improvement. I think you said when we have places who have a no-show rate as high as 45%, that tells me that there is something's amiss.
I can give you a quick example.
Sure.
We spoke with one outpatient clinic who gave us the information on their no-show rate. We spoke with 35 K Street Community Bridges Substance Abuse Program. We introduced the outpatient clinic to Community Bridges. We made sure that we spoke about the timeframes that the enrollees could be dropped off with the MedStar Family Choice transportation benefit from Community Bridges to the outpatient clinic to make sure that we close that gap. And still persons will say, I don't need to go. So the question comes back to us then, what else can we do?
Yeah. I mean, I think when I have conversations with folks in the community, and Dr. Bazaran always reminds me of this, right? Many of these services are voluntary, right? We can provide information, we can do the warm handoff, but then you have a situation where someone will say, I'm good, until they're not. And then when they're not, they're going back to the emergency room. And so I think as part of our public health ecosystem, in the same way that we had to sort of educate people on what's appropriate to go to urgent care for versus what's appropriate to go to the emergency room for, to sort of bifurcate. I think this is sort of one of those areas as well, because you don't want the emergency room to be the default when there are options for maintenance in between when you're in a crisis. But how do we provide that information to folks and convince them to take advantage of those opportunities? All right. Well, thank you all so much for your testimony, and please make sure you provide your written testimony for the record. We're going to go on to our next panel. Jacqueline Bowens, President and CEO of DC Hospital Association. Gail Hurt, who is the Vice President of Patient Safety and Qualities for the DC Hospital Association. Ruth Pollard, the President and CEO of the DC Primary Care Association. And Mark Lavoda, who's the Executive Director of the DC Behavioral Health Association. Okay, Ms. Bowens, when you're ready.
Greetings, Chairperson Henderson, members of the committee. I'm Jacqueline Bowens, President and CEO of the DC Hospital Association. I am joined today by Gail Alano Hurt, who's our Vice President for Patient Safety, Quality, and Operations. And Dr. Greg Arduous is also here should any clinical issues come up that I might not be able to respond to. We all certainly appreciate this opportunity to present testimony at today's roundtable. DCHA's mission is to strengthen our system of care, preserve access, eliminate disparities, and improve health outcomes for our community. The behavioral health continuum in the district is incredibly important as we seek to meet the substance use and behavioral health treatment needs of district residents. The primary goal for our system of care needs to be preventative. The more we can ensure that behavioral health treatment is available in the community, the less likely we are to rely on emergency stabilization and intensive inpatient treatment. Needed community resources include increasing the provider's ability to take new patients for timely interventions, as well as residential treatment options for both substance use and mental health. And our roadmap to creating a roadmap, as you discussed, we all believe is critically important. That is why we are partnering with the Department of Behavioral Health and DC Health to undertake an assessment of the behavioral health continuum as well as surge capacity. This will be part of our hospital's community investment from the Deep Directed Payment Program. Building this community capacity also means ensuring that reimbursement rates, particularly for Medicaid patients, achieve parity to ensure the stability of providers. Financial stability is essential to a provider's ability to recruit and retain the behavioral health professionals that are needed to provide essential treatment services. On the acute care side, our association and its members have acknowledged the need for reform in the resources and processes that provide emergency stabilization and treatment for those in crisis. It is beyond time for the district to move into the modern era and provide probable cause hearings virtually permanently. We had nearly 3 years of experience during the pandemic, and the walk backwards over the last year is frustrating. Our communities provide virtual or mobile court services, and to maintain that the District of Columbia, for some reason, is different is not reasonable. District hospitals are more than capable of working with the DC Superior Court to ensure remote probable cause hearings maintain the dignity of the individual and preserve their right to a day in court virtually. The mandated in-person hearings is a large reason more hospitals are not able to take involuntary patients. Smaller units with less staff and attending physicians have less flexibility to lose psychiatric techs and physicians for hours at a time at the court. Moreover, moving the patients to DC Superior Court inserts an unnecessary risk for both the patient and hospital staff. Finally, as Dr. Robb noted in her testimony, we know there is a lack of adolescent beds to serve children in the region, including in DC. We look forward to working collectively to recruit new residential providers to support these children and adolescents with higher acuity conditions and require longer outpatient supports. We know PIW, Children's, and DYRS are managing adolescents that are more aggressive and need more options to ensure these children get the treatment and support they need to grow and thrive. Gail's going to speak a little bit more on some of the work that we're doing through our behavioral health collaboratives. And as always, I'm happy to answer any questions you may have.
Greetings, Chairperson Henderson. My name is Gail Alano Hart. I'm the president for Patient Safety and Quality Operations for the District of Columbia Hospital Association. I do appreciate the opportunity to present testimony at this Oversight Roundtable. I'm going to start today by highlighting what we're seeing in our utilization reports as relates to psychiatric care, particularly in hospitals. Looking at the latest annual and monthly reports, we saw that in 2023, district hospitals saw a 6.9% increase in psychiatric admissions overall, with 9,720 admissions to inpatient care in 2023. We have, however, seen an overall decline in admissions since 2019, and this number remains under the 12,170 psychiatric care admissions we saw in 2019. When it comes to involuntary commitments, we saw a 21.7% jump in 2023 when compared with 2022, with a total of 2,657 involuntary commitments. We started tracking this breakout in 2022, so I'm not able to provide the information prior to that timeframe. In 2024, we're seeing some variation. There is a lag in our monthly utilization report data, so I only have information through July at this time. However, as of July, there was a 7.47% increase in psychiatric admissions when compared to the prior 12 months for that period. However, we did see a decrease in psychiatric admissions of 5.58% over the previous 3 months, indicating variability and that there may be some stabilization through the end of the year in utilization. When it comes to psychiatric patient days, our acute care hospitals saw an increase of a decrease of 8% in patient days as of July 2024. However, the two psychiatric hospitals, St. Elizabeth's and PIW, saw an increase in patient days of 18.76% during the same time frame. These numbers are, of course, snapshots in time, but they at least provide some context for the discussions today. Changing gears just slightly, DCHA has long understood that hospitals alone cannot meet the behavioral health needs of the residents of the District of Columbia. Meeting the needs of our neighbors means having hospitals, community behavioral health providers, FQHCs, core service agencies, MCOs, and the Department of Behavioral Health at the table. That is why the association started convening the Behavioral Health Collaborative, which is co-chaired by Dr. Adelaide Robb from Children's National Hospital and Dr. Yavara Mogimi, who is the medical director for behavioral health at AmeriHealth Caritas, DC. In addition to the community providers Ms. Bowens may have spoken about, the collaborative has been quite clear around the need to strengthen emergency stabilization resources in the district. This is a topic that did not come up as heavily earlier today, so I want to dig a little further into that. We were pleased when the Crisis Stabilization Center came online. It was a long championed win for the city. And we very much look forward to a day when we can have crisis stabilization centers that support strongly both substance use and mental health. Switching gears slightly to CPAP, this has long been an important resource for the city, and the evolving needs of the district will require the transition of CPAP to a more comprehensive behavioral health crisis stabilization center model. For example, a focus on new models such as an emergency psychiatric assessment, treatment and healing, or empath model, and is an example of a model that holds promise for managing crisis stabilization and avoiding ED utilization and keeping patients and individuals in the community when it comes to treatment for behavioral health care. It will be a critical factor to invest in new models for behavioral health crisis services and will help us gain a better understanding of the needs of patients. Thank you, and I welcome any questions you may have.
Thank you. Ms. Pollard.
Good afternoon. I think I have some slides that are coming up. You're great. Well, while we're bringing, I can start if you want me to and just kind of walk. Okay, great. So good afternoon, Council. I'm Chairperson Henderson and the Committee on Health. My name is Ruth Pollard, and I have the pleasure to serve as the President and CEO of the DC Primary Care Association. I appreciate the opportunity to provide our perspective because we do understand that this is about inpatient psychiatric care. The first slide you can take, page out. Really, I want to say here is that we need partners in behavioral health ecosystem, hence why we're here today. You just heard from Skill about the ecosystem also. We need partners that can collaborate when patients need care that community health centers cannot provide. It also means that we perhaps need to consider expansions of what community health centers are equipped to do if the system cannot meet our patients' needs. Next slide, please. A few just post-pandemic stats that we wanted to share. Particularly, you see the use of shift from virtual 0 in 2019 to 65% of the SUD visits in 2023. Notably, from 2019 to 2023, we saw 50% fewer patients were served. At the same time, we had an increase in the visits per patient, as you see in 2023, at 12.7 visits per patient. Again, less patients, but more visits. Not quite sure what that is, but perhaps has to do with the acuity of the patients. Next slide. So from our members, I think here really want to focus on the integrated behavioral health as we saw other witnesses share their testimony about how important it is really to weave behavioral health care as appropriate into primary care. Really integrated behavioral health focuses on brief interventions to meet patient needs and support providers, addressing high rates of depression, anxiety, insomnia, chronic pain and illnesses, trauma, all of which are part of the integrated behavioral health model for most of the patients is the right approach. In addition, we have our both workforce and patients engaged in trauma-informed training, communication, de-escalation, working with implicit bias and structural racism in healthcare, resisting crisis culture in the workplace, identifying workplace hotspots, and really rethinking what workflows look like in our community health centers. We also are setting boundaries around short-term plan for long-term gain. Next slide. In terms of challenges that we see, we heard others speak about the access helpline, no longer providing that tailored referrals, and has left many of our providers with limited information to support patients with higher acuity needs. Really, the functions at the Department of Behavioral Health, when it was decommissioned and when MCO carved out the expected, the carve out expectations, that we really need to restore that. And then the gap between inpatient and community-based care, thinking about from the perspective of mid-level care that doesn't necessarily require hospitalization. The other challenges around social drivers, of which are impacting patients' ability to get well. For example, probably to the highest extent, something like homelessness that really makes it difficult to address behavioral health needs. And finally, in terms of recommendations, really establish effective process for placing individuals on the appropriate level of care. Again, a part of what does the entire ecosystem look like? Invest in robust care coordination, inclusive of high acuity and risk patients, and pilot innovations for patient and provider to co-design. So I think those are the things that we wanted to share today, and welcome any questions.
Thank you. Mr. Loboda?
Chairperson Henderson and members of the council, thank you for the opportunity to testify today. My name is Mark Loboda. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole person care for district residents with mental illness, substance use disorders, or both, including the 35,000 district residents that our 34-member organization serve annually. My written testimony today assesses current system limitations and outlines actions to improve services, navigate through current challenges, enhance the behavioral health workforce, and expand capacity. I encourage interested parties to consult those much more extensive remarks. The council needs to come to a shared understanding with the administration and the community that fewer good community behavioral health providers are better for district residents with severe behavioral health conditions than many inefficient and ineffective providers. There are now 44 DBH certified community support service providers. 19 serve fewer than 200 people per year. Despite the appearance of increasing access and consumer choice, expansion of the provider network has proven costly and diluted quality of care. Enrollment in DBH certified provider organizations has nearly doubled since 2019. Spending per consumer on community support services, DBH's largest service spending category, has more than doubled. Many DBH consumers don't appear to be better off from those changes. DBH data on key performance indicators show continuing weaknesses within the provider network regarding access to care, follow-up after hospitalizations, and consumer satisfaction. We've seen a steady pace of federal convictions for fraudulent billing and heard widespread reports of illegal payment inducements to switch providers. No care is actually being delivered in those cases. We've also received evidence of wasteful expenditures. For example, the dozen organizations that DBH reports delivered more than 50% of their billed claims for community support services exclusively by phone in the first half of 2024. Behavioral health capacity limitations outside the DBH provider network exacerbate inadequate performance by DBH community providers. There has been reasonable alarm at high demands for inpatient psychiatric care and overdose withdrawal management, especially given reduced psychiatric bed counts and apparent inadequate inpatient staffing. FQHCs, other primary care providers, and behavioral health group practices provide services for people with mild or moderate behavioral health conditions, but they cannot replace the need to connect people who need higher levels of care in a timely manner to a reliable DBH certified provider. These observations make it easy for us to support efforts to increase accountability in the DBH provider network. We support DBH's decision to make national accreditation a condition for certification. We support DBH efforts to decertify bad actors, including development of more robust provider compliance programs, active reporting of fraud, waste, and abuse that are suspected, and use of national provider identification numbers and DC Medicaid enrollment for unlicensed staff. We support reinstatement of community service reviews and DBH and DHCF publication of provider-level expenditure and performance data. We also support quality improvement through the redesign of assertive community treatment and community support services already underway, and we support DHCF efforts to strengthen primary care provider uptake of the psychiatric collaborative care model and interprofessional psychiatric consultations. Despite challenges that prevented the transition of DBH services into Medicaid managed care, extension of the so-called gap period policies since October 2023 has amplified DBH provider network weaknesses. DBH is severely under-resourced on multiple fronts, constrained as it is by responsibilities for St. Elizabeth's Hospital and the federal restrictions on use of block grant and state opioid response funds. DBH clearly did not and does not have the capacity to carry out functions that it expected to hand over to managed care. Many functions previously carried out by the Access Helpline, unrelated to its new role, a good one, as a behavioral health crisis call center, but those other functions need to be rebuilt. Finding a path to unpause the managed care transition is likely the best path forward to reinstate the capacity that's been lost. DBH and DHCF also need to reorient the DBH provider network toward whole person care by committing more firmly to a future certified community behavioral health clinic Medicaid benefit. Work to increase accountability, enhance services, and navigate through current capacity limitations will be incomplete without efforts to address healthcare workforce needs and efforts to overcome behavioral health current system capacity gaps, particularly in substance use treatment, behavioral health crisis services, and housing services for people with behavioral health conditions. My written remarks include extended comments on those subjects. We want to thank DBH, DHCF, and DC Health, along with OUC, MPD, and FIMS, and the council for their efforts, all, to advance high-quality whole person care for district residents with behavioral health needs. Thank you for the opportunity to testify today. I look forward to answering any questions.
Thank you so much to this panel. You guys certainly bring a wealth of data to the conversation, which I think is super important in terms of grounding what we're talking about here, but also what we're experiencing or what people are sort of experiencing in the field. Ms. Hurt, you talked a little bit about there's been a 6.9% increase in psychiatric admissions. It's less overall than 2019, but still higher than last year. Now, these are psychiatric admissions on the hospital side. And in the conversation I was having with Dr. Cartwright and the panel just before this, it was around if we could better help individuals get the proper maintenance care that they need after an episode or after an admission, can we decrease that number as opposed to having folks believe that coming to the emergency room is and should be their primary source of care? And so then I have a question for Ms. Pollard and Mr. Lavoda. What are we not doing that we should be doing to address that number? Because one of the things, or maybe you said it, are you all able to extrapolate how of the number of admissions, how many of those are readmits within the last year?
We don't gather that data in our utilization report data. We may be able to pull it from the hospital discharge data that we receive, but there are some limits on the data that we receive with respect to psychiatric and SUD care. So it would depend on the setting, likely from the EDs, yes. When it comes to inpatient, including St. Elizabeth's and PIW, no, we would not be able to.
Okay, so I think that's an interesting data point, right? How many of the admits in terms of the increase was a readmit, and especially how many was a readmit within 6 months? But my other question to Mr. Lavoda and Ms. Pollard.
Well, I think part of this starts with making sure the community-based resources are as strong as they need to be. And so we talked about in our testimony both ways that we can strengthen the DBH provider network as well as strengthen FQHCs and other community-based providers. That includes a combination of things like we talked about the redesign of assertive community treatment and DBH's community support services program. We have to increase accountability. We've got people who are assigned and enrolled, but they're not necessarily getting high quality care in the settings where they're being referred. And so we have to do something about that. And that also requires capacity building, training, and technical assistance. Some of these organizations are trying to do the right thing, but they've kind of lost their bearings in terms of how to do the right thing. And so this is about reinvesting. And I think we mentioned too, and I know Ruth had it in her slides as well, this is about also enhancing the capacity of primary care or other settings where they can deal with mild or moderate cases. This is all different steps to make sure that people are receiving not just care quickly, but care at an appropriate level of intervention and not putting too much burden on places that are not properly equipped.
And I would echo the same. I would say two things. It is capacity building. It's also that integrated behavioral health model that would be very much complementary in this ecosystem of, as you said, being able, you have your when necessary, right, your inpatient visits. But post that or pre that, if we get ahead of it or behind it, how do we support our acute care partners to ensure that the right kind of care, appropriate quality, and we have the appropriate workforce being able to do that. And so I think that that is that co-creation of the integrated behavioral health model.
Okay, so who is responsible for the capacity building piece?
All of us.
But I mean, no, I'm genuinely asking, what does that look like, right? Because we talk about capacity building, and I feel like in any number of situations that looks differently. We have independent providers, we have independent FQHCs, we have, and so who? And what does that look like? What is needed for the capacity building? Is it people? Is it money? What is it?
If I can interject, that's really one of the reasons why we really think, because I raise this question all the time, because people kind of look at it in silos. It's the hospital's responsibility, it's primary care's responsibility, it's community-based. And we really need to, this is why we want to do this assessment, and sooner the better, to really do a complete roadmap and looking at the whole picture, because I think we've historically kind of looked at it in parts, but until we look at this problem in total, every aspect of it, and looking at, to your point earlier, what happens if a provider goes away? We already know what happened when Providence went down, and, not being ready for that. So the idea of coming together, all of our entities, and bringing the right people at the table, working together with government in this public-private partnership, and we're looking to actually, invest in that to really have, I wish I could do it tomorrow, but we want to do it as soon as possible, is to really create that roadmap that's needed so that we really can have a clearer picture and not just look at it in terms of this is your responsibility, this is your responsibility. And as unfortunately, what we often see is then duplication of what we already said we were going to do. So until we look at it comprehensively, I think we're going to still continue with, the same type of thing. So.
Okay. Do you feel like we have the capacity to do this type of assessment in-house?
No, it's going to take getting resources to be able to do it. I don't think that anybody has it in-house. We're going to actually need a third party to kind of work with us, facilitate it, and everybody kind of step back and, bring their knowledge to the table, but we need someone else to guide it.
I don't know that we need to comprehensively wait for that kind of assessment, though, to know some things that need attention, right? We need to complete revising social work licensure. We need to take a look at the ways that DBH mandates administrative positions that don't affect quality of care. We need to talk about how DC Health collects licensing data elements that allows another part of DC Health to apply for new site eligibility for health professional loan repayment programs. We need to talk about expediting transfers of health professional licenses from other jurisdictions. We need to invest in healthcare workforce burnout reduction and prevention. Like, all of those things are things that we know how to do. We've got reports that have already been written that provide detailed recommendations for what those steps would be.
I hear you on that. I think the question, though, because part is capacity, part is quality. So even if I bring in a bunch of providers to an agency or a CBO that is not working well in terms of providing quality, then what was the point?
Right.
So let me ask a different question, or a separate question rather. Who is responsible for ensuring high quality care at all of these places?
I mean, I still go back to it's all of us. So in the FQs, of course, we're responsible for making sure that there's high quality care, respectively, at each of our points of care delivery is what I would say.
But I don't think I've ever heard of a.
Are you asking with respect to regulatory?
Yeah, I'm asking for a governance piece, not in terms of like theoretical. Yes, we are all.
You're asking regulatory.
But in terms of the framework, right? Like, I don't think I've ever seen a provider or a place be closed because of quality, right? I think Mr. Levoto talked about hospitals. Let me qualify that. In terms of community-based organizations who are providing some of these services, right? I've seen places who have been sanctioned and closed because of Medicaid fraud.
Yep.
And that's about the category. Not in terms of you had somebody who came for a visit and they were there for an hour and they didn't actually get anything out of it to sort of help or otherwise. And so, you know, one might say this is DBH, one might say this is DC Health because DC Health could pull the license, although it depends on what type of organization or agency it is. But I guess then the question is around how do we advance this? Because it feels like, again, we're stuck on compliance and not on quality.
Well, we did talk about things like community service reviews. Like DBH did used to have a process where they actually went out and talked to people who were receiving care from DBH certified providers. And there was a format for that. There were published reports.
When did that stop?
2016, 2017, sometime in that time range.
Okay. And did they provide a reason as to why they stopped doing those types of reviews?
I wouldn't want to speak for the former administration.
I'm sorry?
I wouldn't want to speak for the former administration. You can ask DBH current leadership what they think about reinstating.
Okay, I'm doing math in my head when you talk about the former administration. Okay. Okay. In terms of immediate next steps, what is the top thing that you feel like needs to happen here? Because unfortunately, I feel like now we've got a combination of things, right? We originally called this hearing, and I still feel that it is a central piece, is that I've got a true lack of capacity issue on inpatient options, period. All ages, particularly young people. So we're gonna deal with that. Then I have this other issue that, you know, there's a mismatch in terms of what folks say is available versus when they call, they can't find, right? Or otherwise in community. We've got a mismatch in terms of quality. Who's on first? If you guys had a magic wand, where should we be focusing first?
Well, everybody has to do their piece. And everybody has to do their piece individually, and they have to talk to each other about what they're doing. And I think ULS stressed that earlier today in their testimony, right? You have to call together everyone from DHCF and DBH and DC Health to get them to an agreement, not to just point fingers at someone else and say, it's our problem. Well, we have to keep doing that. And also individually, DBH is going to have to attend to the DBH certified providers. DC Health is going to have to attend to the people that they license and regulate. DHCF pays all of our bills, and so they've got to stay in the conversation about how Medicaid beneficiaries get what they need. I don't think that it's as simple as one agency can wave a magic wand. There's no silver bullet here. This is a lot of hard work by a lot of different parties.
I think that it's obviously the combination of kind of doing that roadmap, which again is going to take some time. But I also think the idea of making sure that there's clear kind of coordination of services in terms of, you know, appropriate handoffs and how do we change health-seeking behavior. So there's that, you know, to the degree that we can educate and elevate awareness around the services that are available to our patients and making sure that, you know, whatever we can do to ensure that, you know, we are doing that preventive piece and that people come to the emergency room as that last alternative, but also that we're able to make sure that we're taking advantage of the resources we have, particularly with, you know, with CRISP and other things to make sure that, you know, we know where patients are. But the idea of really coordinating and really getting clarity around what those barriers are to services, if it's licensure, if it's education. And again, some of those things would take time, but I guess my members would say really being able to make sure that there is a path to when patients are in the hospital, belong in the hospital, and when they need to transition to other sorts of care upon discharge, that we have a clear pathway for that to happen, and being able to appropriately track those patients. So when you talk about readmissions, that's the best way to avoid readmissions, if we're ensuring that patients are where they need to be at the right time. And to the degree that we need to be able to provide wraparound services to those patients, that we not only know where they are, but that we ensure that they're available. You know, I think back to COVID, you know, hospitals open 24/7. And again, for whatever reason, it could be lack of resources or others, community providers weren't. And so people were inappropriately staying in the hospital longer than they needed to be. And so if I had a magic wand, it would really be around that coordination around after discharge, and ensuring that when people need to leave, they're appropriately where they need to be, and that we worked them from an integrated system on the primary care side so they don't have to be in the hospital in the first place.
Yeah. One last question that I had. So I'm told that where we are now with, besides St. Elizabeth having one inpatient option, and then also not having any partial or any intensive outpatient or very few options, was that was not always the case in DC. That there were other providers who were here who, for whatever reason, left. Any of you understand why that was the case? Was it reimbursement rates? Was it other regulatory issues? What was it? Because I think if we're trying to address around that part of how do we attract providers to come into the district, then I got to ask the question of what are the reasons why you left and what are the barriers that still exist for us today? A couple of weeks ago, we had a hearing on legislation around certificate of need reform. And I had the director of SHPTA here who said, nope, the law with regards to behavioral health, DBH has always been able to waive the con for that. They haven't until recently. And so if it's not CON, then what is it?
Well, I think it has been CON, particularly for SUD residential, and so we do need to keep looking at that. For IOP and PHP, it's been reimbursement rates, but not just in a straightforward way. It's figuring out the payer mix, because people end up with behavioral health conditions at all income levels and with all kinds of insurance and none. And so what I often heard were things like, well, the Medicaid rate was actually decent, but it didn't offset that the commercial payers weren't willing to pay enough. And so then the total service mix didn't end up working. And so I think we do have to scratch a little further than just the what's the first obstacle that people hit. The other thing is space, right? I mean, space went to a very high premium, and we can all have our discussions about what DC real estate looks like now, and if it's quite as bad as it was, and what else that means for tax purposes.
Yeah, plenty of vacancies.
Well, but they're not all equipped to be healthcare spaces.
That's correct, yes.
And so I do think that that's the other continuing concern around many of those services, is some of them are pretty space intensive, and we don't necessarily want them located in places where we have other high intensity needs and uses.
The one thing I forgot to mention that I also would be very helpful, at least on the hospital side too, with respect to capacity, is that if we could move the Urban Act so that we can have that flexibility to ensure mobile court, as opposed to having the doc and the patient having to go down to Superior Court. We know that it worked. It worked for 3 years under COVID. And so being able to make sure that we're able to do that permanently, I think is a quick win, and that would be extremely helpful to our providers. So.
All right. Well, thank you so much to this panel. Really appreciate you being here. All right, we're going to move to I'm going to tell folks where we're going. We're moving into our final panel of public witnesses, and then we'll take a 10-minute break, and then we'll have our government folks testify. Shannon Walsh, who's the clinical director of the Court Urgent Care Clinic. Dr. Charlene Haling Williams, president and founder of Community Wellness Ventures. Ann Chauvin, CEO and executive director of Woodley House. Judy Ashburn from Samaritan's Inn. Dr. Sarah Goldman from Capital Integrated Care. Cheryl Dondero from Gonzina. And Karen Oslow for Catholic Charities. For those who this might be their first time joining us for a virtual panel, you have to affirmatively accept our invitation to become a panelist. So there'll be like a little square that pops up on your screen. You have to say yes to our invitation for you to join. We'll give it just a minute. Okay, I see Shannon. Shannon, when you're ready.
Thank you. 1 second. Good afternoon, Chair Henderson, council members, and council staff. My name is Shannon Walsh. I'm a Ward 8 resident, a licensed independent clinical social worker, and the clinical director of the Court Urgent Care Clinic in DC Superior Court. The Court Urgent Care Clinic is a partnership between DC Superior Court, the DC Department of Behavioral Health, and Pathways to Housing DC. My testimony today will focus on the adult clients we work with, and in my written testimony, I will provide additional information about the Court Urgent Care Clinic's experience with completing forensic child evaluations. The Court Urgent Care Clinic provides same-day mental health substance use assessments and treatment, connection to individuals regardless of insurance, DC residency, ID, legal status in the country, or involvement in the court system. At the clinic, our clients intersect multiple systems, such as the courts, the Department of Behavioral Health, Disability Services, Homeless Services, and others. Each of our clients' needs are unique and often complex as they are navigating through multiple systems. There's a dire need for a comprehensive, well-integrated system for our clients and others of the district's most vulnerable residents. Unfortunately, we do not have enough resources to bridge the gap for clients with higher needs of care. Clients are released from hospitals. There are not step-down programs. Clients are sometimes linked to core service agencies, but many of these clients need help setting up an appointment and transportation to the appointment. We cannot keep discharging clients with unstable housing and chronic mental illness without proper supports to make sure they can receive the care they need. The current outpatient services in the district are not adequate to meet the needs of district residents. Oftentimes, linking clients to core service agencies is not enough. Many of the clients we see need to be linked to assertive community treatment teams, but there are not enough openings, and the process to refer clients to these teams is not straightforward. Additionally, to be linked to an assertive community treatment team, a client must already have insurance. For clients with complex needs, the process of applying for insurance on their own can be overwhelming and time-consuming, which can delay their ability to get care. Since the change with Access Helpline, the process of being connected to core service agencies has increased in difficulty. Now, some providers require clients to go through their office directly to link to their services, yet other providers require clients to go through DBH to be connected to their services. And we don't have any information until we speak with the core service agency who prefers what. We have also found that some of the clients that come through our door have been connected to core service agencies, but have been dropped due to their Medicaid expiring. It's the Core Urgent Care Clinic's anecdotal experiences that some core service agencies are not assisting their clients and recertifying for Medicaid and are instead stopping services until the client's Medicaid is active. This leaves clients without psychiatric and therapeutic services, which leads to deterioration of their mental, emotional, and physical health. From the point of view of our clinic, there's a lot of finger pointing within our mental health system about whose job is what, instead of asking how best we can assist our most vulnerable neighbors. As a provider, I'm able to shed some light on changes that could potentially better our community, but I also think it's imperative that we hear from individuals who are currently in these systems. Their perspectives are essential in creating a successful, long-term, comprehensive, well-integrated system. Thank you for the opportunity to speak. I'm available to answer any questions you may have.
Thanks, Shannon. Dr. Haling Williams.
Good afternoon, Chairwoman Henderson. Thank you for allowing me to speak today. I'm Dr. Charlene Haling Williams, a Ward 5 resident, CEO and co-founder of Community Wellness Ventures. CWV has been a certified core service agency and freestanding mental health clinic since 2017. As a psychologist and business leader committed to addressing the opioid crisis here in the district, I'm here to discuss the regulatory, financial, and logistical barriers we face in launching essential adolescent residential substance use disorder services. In April of 2023, we secured the district's only certificate of need for adolescent residential SUD services, an achievement that required a significant investment of nearly $100,000 and countless hours of preparation and time. Yet, as you recently mentioned, DBH reported waiving this requirement altogether, raising questions about the consistency of our regulatory framework. It is difficult to comprehend a fair and just rationale with the full awareness of CWV's readiness. We also applied for a human care agreement with DBH in February of 2024 to deliver reimbursable adolescent SUD services. However, it was denied because we lacked certification, something impossible to obtain without an operational site, a hurdle the DBH only recently addressed. We need clarity on whether the HCA process will reopen early in FY25, as we're prepared to meet these needs if the pathway is clear. Of note, DC has not provided this level of care since 2021, when Mountain Manor departed the provider network, citing inadequate funding and regulatory challenges. Another barrier is DBH's new provisional certification, which reportedly allows providers 6 to 9 months to establish a facility and initiate managed care contracting. However, this timeline is a bit impractical, given that construction alone takes 6 to 9 months. We need a realistic time frame that aligns with the demands of setting up a high-quality residential care facility. Despite being nationally accredited by CARF, we find that DBH still imposes additional certification requirements, often duplicating CARF standards. This approach creates redundancy and burdens providers rather than supporting them. National accreditation should streamline, not complicate, our regulatory process. Finally, there are challenges operating this facility around finances. The fiscal landscape is just unclear and not really supportive. We've learned through a national market analysis that this should cost about $900 per day per bed to do this well. Yet DC Medicaid reimbursement for these services remains less than clear, but it is estimated that DC only covers about $300 per day, including local dollars, leaving us with a significant funding gap. Our national market analysis also revealed that Arizona's Medicaid rate for similar services is about $678 per day, which comes closer to our cost. Nevertheless, DC's cost of living is nearly 38% higher, making it difficult to bridge this gap without further assistance. Without a sustainable rate structure or additional support, providers like us should not be expected to close this funding gap on our own. Questions remain regarding the plans for utilization of both opioid abatement and state opioid response dollars to support adolescent residential SUD services. The reality is that CWV has taken every necessary step to be part of the solution to the opioid crisis here in Washington. We have secured the only con, we are nationally accredited, and have even procured a site and supported in part by DMPED for a 38-bed facility in Ward 7 to include residential, outpatient, and IOP adolescent services. And yet, we're faced with a maze of shifting requirements, insufficient reimbursement rates, redundant certifications, and a series of regulatory catch-22s. Our experience illustrates a broader issue with the district's behavioral health landscape, a system that, despite good intentions, often leaves providers with more barriers than support. In closing, we know that national entities have been guaranteed enhanced Medicaid rates to ensure that their costs are covered across the primary care and behavioral health spectra. The question is, how may we work together to provide similar support to the local provider community? We have termed our model Community Wellness Village, as it truly takes a village to adequately meet the needs of our youth who need us most. The district government is most certainly an essential member of our village, and we envision charting a path to progress and adolescent SUD residential care together and quickly. I look forward to answering questions.
Thank you. Ms. Chauvin?
Good afternoon, Chairperson Henderson and members of the Committee on Health. My name is Ann Chauvin, CEO for Woodley House. Thank you for the opportunity to share my testimony with you today. Founded 66 years ago, Woodley House is a nonprofit organization providing housing and support services to DC residents who face behavioral health disorders. As part of our continuum of care, we operate a residential psychiatric crisis bed program, one of only 2 in the district. As such, we are part of the Department of Behavioral Health's crisis service delivery system and in a unique position to interact with other crisis services, hospitals, and community-based organizations. Our 8-bed crisis stabilization residence serves approximately 150 clients each year. Our goal is not only to stabilize a person experiencing a psychiatric crisis, but to ensure that the person has support in place when they leave. These supports help the individual avoid future crises and reduce hospitalizations and ER visits. We rely on intensive collaboration and coordination of care with the person's support system, which often comprises only community-based organizations. A large majority of the clients in our crisis stabilization program, up to 80% of those we serve annually, are unhoused. Many have co-occurring substance use disorders and complicated physical health issues. Woodley House is proud to be part of DC's system of care for individuals who are experiencing significant behavioral health issues, physical health problems, and in many cases, homelessness. We want to highlight that we have experienced a particular subsystem of care that has been quite effective in terms of improved health outcomes for those adults who come to us who are unhoused and have significant behavioral health issues as well as physical health problems. As partners in this subsystem, Woodley House works closely with McClendon Center and AmeriHealth Caritas DC. In most cases, clients come to us after being discharged from a hospital medical inpatient unit or ER and are connected to McClendon Center's Patient Discharge Coordination or PDC team with oversight from AmeriHealth. These individuals are given sufficient time and resources to stabilize their behavioral and physical health problems and to obtain a safe, stable place to live. When individuals receive this level of support and residential stability, they are less likely to visit the ER or have hospital stays, and they are more likely to follow through with outpatient appointments and medication adherence. The PDC team helps coordinate an outstanding level of care. Our crisis team reports that we receive most hospital patient referrals from PIW, GW, Georgetown, and Sibley hospitals. All have been very good about giving us the information and assistance that we need, and we appreciate the good work being done by the social workers at those hospitals. At the same time, our team at Woodley House faces many challenges, helping our residents obtain and connect with the community-based services they need. Many of the community-based organizations on which we rely struggle to provide the level of care necessary, especially in light of the system-wide attrition in our behavioral health workforce the past 5 years. Unfortunately, our community-based service delivery system for the residents we serve is not functioning in the way that we need it to. Woodley House's crisis stabilization program has relied heavily on DBH's Access Helpline over the years, which has been our central point of contact at DBH. The Access Helpline is doing a wonderful job as the centralized crisis line, and they had been doing a wonderful job at centralized enrollment and disenrollment. However, since the planned transition of functions to managed care organizations has not happened yet, the resources DBH needs to restore those functions has not been provided. Testimony for today's hearing provided by Mark Lavoda, the DC Behavioral Health Association's Executive Director, addresses current system performance and capacity limitations. He provides recommendations to increase provider network performance accountability and improve quality of care to support navigation through current system limitations, to continue to invest in behavioral health and overall healthcare workforce development, and to enhance system capacity. We share DCBHA's concern that DBH is severely under-resourced on multiple fronts, and that DBH clearly did not and does not have the capacity to carry out functions that it expected to hand over to managed care. From all of us at Woodley House, we appreciate the committee's time and consideration, and I'm also happy to take any questions.
Thank you. Ms. Ashburn.
Good afternoon, Chairwoman Henderson and members of the Health Committee. My name is Judy Ashburn. I am the Director of Treatment at Samaritan Inns. Samaritan Inns has been providing residential recovery and treatment services for the last 40 years. We are one of only 4 remaining residential SUD facilities in Washington, D.C. We service men, women only, and women with children. And our Women with Children residential SUD program is the only one of its kind in the city. Thank you for the opportunity to provide testimony at this roundtable. SUD residential services have drastically changed with the implementation of COMAGIN, contracted by DHCF and implemented in stages in 2023. Samaritan Inns added new positions and trained staff to incorporate 14-day authorizations, along with biweekly reports into the daily treatment rhythm. And though cumbersome, this has been accomplished by Samaritan Inns and all other SUD residential treatment providers. However, systemic challenges continue with payer-provider relations in the following areas. Late payments. In March 2024, new billing codes were introduced. And though the SUD community raised concerns about how the new codes would affect billing and did not align with Chapter 63 regulations, the codes were changed by DHCF. 7 months later, we are finally getting paid, but with hours of work to be done on the back end to resubmit claims. The mounting financial implications of all these changes in the past 3 years have made it financially unfeasible to continue providing SUD services in the district with DBH DHCF. Number 2, duplication of certification accreditation efforts. Many states are only requiring national accreditation and not duplicate state certifications. In DC, providers are still required to do both, and no crosswalk has been provided by DBH so that providers would only need to provide information pertaining to DC to be certified in the district in addition to CARF. Number 3, gaps in providing quality client care. One is the lack of awareness by hospitals and other organizations of SUD residential providers, as well as outpatient providers for seamless referral processes. There have been progress in the hiring of peer support specialists in many hospital settings, which has improved warm handoffs, as peer support specialists are aware of SUD providers. I commend several medical directors who've reached out to Samaritan Inns and just learned about the Women with Children program after we've been providing residential treatment with a certified daycare facility on site for 9 years at a great cost to us. Samaritan Inns will be presenting at Howard and Children's Hospital, and we look forward to building more opportunities because it is up to each individual agency to reach out and enter into designated collaborative organizations and work with peer support specialists to assist in tracking data between agencies and the MCOs. Youth services. Samaritan Inns is able to admit ages 18 to 20 in their SUD residential treatment programs for men, women, and women with children, as we have done in the past. We are requesting that DHCF expand the ages served from 21 to 65 to 18 to 65 to immediately address the increasing needs of youth for SUD residential treatment service. This is a season of change for SUD residential services as we prepare for the MCO carve-out, now delayed until 2026. This move will require us to work as designated collaborative organizations working together with agencies who provide services Samaritan Inns does not. As we track data and seamless referrals from one selected agency to another in a closed system, we will begin connecting the behavioral health silos in the district. Working with the MCOs has not been as cumbersome as co-imagine, and is hopeful that the value-based approach of the MCOs will help bring SUD programs align with other behavioral health agencies that provide quality services and track data that will reduce the administrative burden and improve provider-payer relations. There's hope with grants becoming available through SAMHSA, the Opiate Abatement Commission, that we will soon receive notice of grant awards. Though Samaritan Inns has been awarded 2 grants, we are still waiting for the NOGA, and this has prevented clients from receiving ongoing recovery and housing services after Medicaid authorized payments have run out. I thank you. This concludes my testimony, and I'm happy to answer any questions you may have.
Thank you. I don't see Dr. Goldman, but I do see Ms. Dondero.
Good afternoon, Chairperson Henderson and members of the Committee on Health. I am Cheryl Dondero, Director of Government Affairs for Gadenzia's Regional Addiction Program, or RAP, as you know it. I'm pleased to be here testifying on behalf of RAP, which for more than 53 years has been an indispensable provider of substance use disorder treatment services to the district's most vulnerable residents. Indeed, today, RAP is the only district entity that provides the full continuum of SUD ASAM levels of care, from crisis stabilization, walk-in assessment and referral, both levels of withdrawal management and clinically managed residential services, as well as intensive outpatient and standard outpatient. 6 months ago, I had the privilege of presenting testimony before this committee regarding the budget. At that hearing, we urged the district government and this committee to focus on certain initiatives to improve residential SUD services in the district, including addressing the challenges of recruiting and retaining SUD clinicians in a safety net setting, focused coordination between the sobering center and residential treatment, consideration of regulatory flexibility related to establishing new services, and a review of existing SUD residential rates to ensure their adequacy. I'm pleased to report that important progress has been made on a number of these initiatives. Among other things, RAP was very pleased to see the passage of B250287, the Counseling Compact Approval Act of 2023, which we hope will increase RAP's access to licensing counseling professionals who are currently licensed in other counseling compact states. Additionally, we were thrilled to learn of recently announced policy that will remove SUD services from the Certificate of Need process. This agreement between SHPTA and the Department of Behavioral Health will significantly lower regulatory barriers, potentially permitting of expansion of residential SUD services and providers in the district. To be sure, residential SUD providers, which serve the safety net populations, continue to struggle with recruiting and retaining significant staff to meet the service needs of the district's population and ensure compliance. As one might imagine, our client population can be particularly challenging due to the complexities of their conditions and circumstances. All too frequently, we see staff departures very quickly for less demanding positions. RAP experiences very high turnover, especially in key counseling positions, which is a barrier to access for our clients. We would welcome an opportunity to collaborate with the district to explore targeted incentives for attracting and retaining these critical workers, which could include enhanced loan repayment and district-funded retention bonuses. To be candid, without some type of workforce development assistance, safety net residential SUD providers will simply not be able to expand the services needed to meet the current opioid crisis. During the last fiscal year, RAP served over 860 individuals. Our clients are predominantly Black, male, and over the age of 45. Additionally, 62% of the clients we served are experiencing polysubstance use, 2 or more illicit substances, and more than half of our clients are experiencing homelessness, and at least 1 in 10 is HIV positive. This data does not capture the percentage of clients which are diagnosed with a co-occurring mental health disorder, but that percentage is very high. Indeed, RAP serves the population most at risk from an opioid-related fatal overdose. According to the most recent report from the DC Medical Examiner, opioid-related overdoses more than doubled between 2018 and 2023. And tragically, for the first 6 months of 2024, the district averaged nearly 33 deaths per month. Yet at current staffing levels, we are unable to meet these demands for services. In addition, in recent years, the closure of 2 of our providers have left Gadenzia one of only 4 remaining. In addition to workforce development, we would appreciate efforts to simplify the Medicaid fee-for-service to mirror that of all of our surrounding states, rather than having to bill for each unit of service. It would be much less administratively burdensome if we could transition to a per diem rate for each of the residential SUD services. As a companion request, we urge the Department of Healthcare Finance to conduct a long overdue rate study. It's included in my testimony that I submitted, but we have outlined the difference in reimbursement rates for residential levels of care between the district, Maryland, and Pennsylvania, where we also operate. And while the district rate for 3.7 is comparable, the length of stay there is days as compared to months. So we really experience a revenue bleed at the residential levels of care. We would sincerely like to thank all the dedicated team at DBH for their considerable assistance and support as we endeavor to improve our systems. Dr. Vazwan, Dr. Jones, Mr. Neff, Mr. Moyes, and Mr. Barry, among others, are true partners to us, and we truly appreciate their service. Thank you very much for this opportunity to testify.
Thank you. Karen?
Good afternoon, Chairperson Henderson and members of the council. Thank you for the opportunity to testify today on this important topic. My name is Karen Ostley, Senior Director of Behavioral Health Transition at Catholic Charities and a Ward 6 resident. Catholic Charities provides a full continuum of services to meet the whole health needs of children, youth, and adults in the district through our freestanding mental health clinic, our core services, assertive community treatment, school-based mental health services, and CHAMPS, the district's mobile psychiatric services for children and youth. To address gaps in care for children and youth, our CHAMPS team reports challenges with connecting children and youth to timely core service agencies, or having access to the appropriate level of care. This process can sometimes take up to a month for an initial intake and another month or more for the first appointment to services. The best practice for follow-up post-discharge from an inpatient stay is to have a 7-day and 30-day follow-up. However, given the current challenges with timely access to care, those quality indicators are difficult to meet and can result in an increased use of emergency department visits or inpatient admissions. Having sufficient intensive community-based interventions for children and youth is another area for consideration. It would be useful for DBH to review current regulations to determine if changes may support additional providers being certified by reinstating mixed license and unlicensed teams for children's intensive community behavioral health services. Catholic Charities had 2 separate CBI programs in the past, but could not make them sustainable with the current regulatory requirements and challenges with maintaining an adequate workforce. Another challenge for our children and youth is the lack of fully integrated mental health and substance use care. When our CHAMPS team receives a call for youth who are reporting co-occurring substance use, they find there are not enough community-based providers who provide both mental health treatment and substance use treatment. If youth are referred to 2 different providers, they often won't complete both intakes, resulting in poor outcomes and inadequate treatment. Lastly, as you know, the only 2 inpatient psychiatric facilities for children and youth are in wards 3 and 5. In the future, considering an urgent care psychiatric clinic and inpatient psychiatric care in wards 7 or 8 would be a welcome addition to enhance capacity and the continuum of care for children and youth. For our adult services, we appreciate efforts over the past year to move assertive community treatment teams from a fee-for-service model to a monthly billing model. Although implementation has not been without its challenges, we appreciate DBH's and DHCF's willingness to engage with providers to adjust billing requirements based on provider data and feedback. We also appreciate the technical assistance being provided by national consultants from the University of North Carolina Center for Excellence in Community Mental Health. Getting good fidelity requires the appropriate staffing for our ACT teams, which continues to be a challenge to good fidelity and the ability to accept referrals for this much-needed service. I do want to thank the committee and DC Health for revisions to the Health Occupations Revision Act that offer licensing exemptions for BSWs and MSW graduates who perform non-clinical work, as well as their intent to provide an alternative pathway to the LGSW license that does not require passing the National Graduate Work Exam. The ACT model is shown to reduce repeated emergency department visits and hospitalizations. And I've seen this work again and again. However, the gaps in the system that create challenges can increase the use of both emergency department visits and inpatient hospitalizations. Adequate communication when somebody is hospitalized is key. We do get notifications through the CRISP system or calls from the hospital, but there are times, even when timely notification and discharge planning have happened, when unexpected discharges create challenges to timely post-hospitalization and access to discharge plans, which may result in repeated inpatient stays. Another barrier is appropriate housing, which is critical to meet the significant challenges in reducing ED visits and inpatient stays. Individuals need access to a range of housing options, including permanent supportive housing, community residential facilities, and assisted living or skilled nursing care. I have additional details in my comments, in written comments that I've submitted, and I'm also open to answering any additional questions or provide additional information. Thank you.
Thank you. Thank you so much to this full panel of witnesses and for the work that you all are doing, excuse me, out in community to help in terms of residents. Ms. Walsh, if you're still here.
Yes.
You mentioned in your testimony about some of the changes to the Access Helpline, and this has been something that we've talked about with a couple of other witnesses as well. And I'm summarizing, but you sort of implied that things are much more difficult now. Can you say a little bit more about that?
Yes. So, right now, it's my understanding that core service agencies, some of the core service agencies are requiring that clients go through, like, be linked through DBH, through Access Helpline to their services before they'll schedule someone for an intake. But then others only want you to go through them and they want to do the linkage through DBH themselves. Does that make sense?
Okay, so it's just to clarify, for some, they are saying, we're happy to schedule when Access Helpline calls to do so. And then there are others who are saying, no, you need to go through our individual website to schedule?
Yes, you need to call our office directly. So, and there's no like list of core service agencies that are saying, yes, you need to go through DBH first, or you need to come through our office first. So it's kind of just hit or miss in terms of how best to get people connected to services.
Okay. All right. Well, we'll ask some follow-up on that. Ms. Haling-Williams and Ms. Dondero, you guys kind of brought up similar issues concerning the reimbursement rate issue. And in fact, I think Ms. Chauvin also had a similar concern as well around what DC is offering on our reimbursement schedule is significantly less, either A, from what's happening in our region, but also B, to actually meet the full need of care. Ms. Dondero, you said that healthcare finance needs to do a rate study. Now, we've heard of rate studies in a variety of different areas. And the rate study will go on for 18 months.
Yeah.
Not everybody responds, and we go on and further X, Y, or Z. When's the last time there was a rate study on residential?
So I actually, I'm fairly new to DC. working with DC, and I tried to find out that information. I believe it's my understanding that there was a group put together to talk about doing a rate study a few years ago, but it never went anywhere. But I don't know when the last one was actually done, that there were rates published from that study and that they were either implemented or were given reasons why they couldn't be implemented by a budget. So I'm not entirely sure, but none of my coworkers at RAP in DC could really remember when one was done, only that there was tried to be one a few years ago, but it didn't go anywhere.
Ms. Chauvin or Ms. Ashburn, you all also do residential programs. Do you either of you remember in terms of the last time that there was a rate study?
Yeah, it was a number of years ago. I don't know the exact year, but I would say 2016, maybe Mark LeBeau. Well, that would be in the former panel.
Yeah, Mark's not here.
It's been a long time.
Okay, well, then I must ask you this for all 1, 2, 3, 4 of you who are sort of in the residential space here. As we're thinking about a desire to get more providers into the space, is this a hindrance? Is this a barrier?
100%. This is Cheryl with Cadenzia. 100% yes. And without taking too much time, but just with the residential low 3.1 and 3.5, if I'm going to go RAP, Maryland, Pennsylvania, 3.1 RAP is about around 122 a day, Maryland around 157, and Pennsylvania 242. And for 3.5, the high intensity residential RAP's around 210, and I'm saying without the cents, Maryland 298 and Pennsylvania 358. And the RAP rate is only if we assume that we bill for and get every single unit of service billed that would equal that, all of the Act 63 required services, and that's not happening either. So I think we're even probably receiving reimbursement at less than that rate. The 3.7, the higher intensity and withdrawal management is more comparable, but as far as it's usually only days in a 3.7 as opposed to weeks and months in a 3.5. So the 3.1 and 3.5 are where we're really having a significant gap in reimbursement and even getting something. So in lieu of a rate study, we'll be happy to get closer to Maryland. That would make it easier.
I'll say, as a youth and adolescent provider, considering, standing up a facility like this, it has been extremely difficult, and it's definitely a barrier because you can't make the necessary business decisions or projections without the information. As far as I understand, the rates are not evident in the fee schedule that call out adolescent residential SUD services. Was not included in the most recent state plan amendment for the enhanced rates. And furthermore, they're insufficient if we compare them to the adult side when we think about what's required in terms of ratios, specialty providers, educational services, and the like for young people, and the just dearth of services and the extreme regulatory and just quality issues that we have to face when providing good care in this space without the adequate rates and no real path to it. There's no wonder we've been without those services since 2021.
Yeah, I mean, that's, I think, an important caveat to what Ms. Dawn Duro was sort of talking about. That was all for adult, right? And so there's an entirely different look in terms of fee schedule. And even on the adult side, I'm like, okay, 157, that seems, if I gotta pay for people, I gotta pay utilities, I gotta pay rent and or mortgage, I gotta feed you, I gotta pay for cleaning services. Like, I don't see how the math, even just on a sort of just that basis, is working, especially if we're talking about I think, Ms. Chauvin, you said you guys have 8 beds?
Yes, that's correct. But so I can speak to this, but we run a psychiatric crisis bed program. And so that the rates for that are good. We wish that the authorizations would that we would be given more time. But I can speak to having operated SUD residential programs in my previous job.
Okay.
And Judy Ashburn is familiar with this too, that at my previous organization, they had to close the women and children SUD residential program because the rates were so inadequate and they couldn't sustain it. And I know that in my previous organization, when it was considered to open and operate an SUD residential in the district for adults, it was just not financially feasible.
Ms. Ashburn, did you want to add to that?
Yes, it has been the Women with Children program, though everyone applauds it. It's taken a huge amount of effort, and we've been in the hole in that program ever since we started it. We are looking at some collaborative agencies now to assist with that, and I hope that that comes through. But it's not just the Women with Children, it's all the level 3.5 programs that we have. And what has been told to us is that we cannot, by DBH, DACF, is that we cannot rely on fee-for-service funding to fully carry our programs, that we need other sources of revenue.
So charitable, I'm confused in terms of how you're supposed to build the gap here.
Well, yeah, I guess other grants. I mean, we have the Opiate Abatement Commission. We have, now coming on the front with Samson's or grants. We have to increase, diversify our funding streams.
Okay. It's a little challenging for me when I look at what our substance use rates look like, right, in terms of the need and the increases we have seen over time, to suggest that those who are providing the services, you essentially have to have a full-time grants manager to layer on to essentially be able to apply for funding to just keep your program open, a program for which is keeping individuals out of the emergency room and house. Yes.
If I may, I just wanted to add a layer of onto that. We have a grants department, but when applying for grants that say you can't supplant Medicaid funding, you really have to be careful and find things to apply for the grants that are not typically what is expected to be paid for Medicaid and a Medicaid reimbursable service. So you can look for other grants, but you really have to, if it's the Medicaid services, you can't supplant them with other grants. So yeah, could you maybe find other little case management, things like that around, but it's really difficult to try to supplant an inadequate daily rate or fee-for-service rate for services that are supposed to be covered by Medicaid.
And if I might add, it's come up a few times today, this term around bad actors. And this is really the other side of the same coin, because that's just simply not good business. You don't buy things you can't pay for. So business is predicated on the resources being available and the margins to be able to sustain any variability in the number of people in the beds and, just the changing tides and all those things. Well, if you're starting out already at a deficit and looking to grants and philanthropy and so on and so forth, and then when those things don't come through or they run out at the end of the fiscal, you're back at square one. And then we wonder why we see the types of decisions being made out of sometimes, I guess, desperation and sometimes character flaws and all of those things. But either way, it's really a trajectory that we don't want any ownership of sort of setting people on by starting down a path that wasn't sustainable to begin with.
Yeah. I mean, I think one of the things that sort of highlights for me is that as we're seeing more of these venture capitalist firms sort of entering into the health space, buying up, otherwise, or just large systems, it's very hard for an independent provider to be able to sort of operate in this space because you're truly at the margins. And, Dr. Hailing-Williams, you and I have talked, and the process of delays that you have seen had another small business that's completely out of the health space who, again, was trying to do everything right, had the pre-meeting with an agency. That agency didn't include another agency, approved a plan. And now at the point of ready for construction, I have another agency who is now saying, oh, no, you can't move forward. It's a $10,000 mistake that now that small business has to quote unquote eat, but they came to the government to get an approval. We just didn't do our part. And so it's this like vicious cycle that we're kind of going through here around, if this is a priority, why does it take, since 2023?
Since the award, absolutely, yes. But, the initiation was obviously before that. And that is the question, is it really a priority? And as I sort of referenced in the testimony, we have other agencies, both in the executive and, some of the departments at the table ready to go. DIMPED supported the procurement of our site through the Commercial Property Acquisition Fund. And this is Ward 7 site. We have a building permit, we have architectural drawings and all of the renderings for a 38-bed adolescent SUD facility. And it has not in any way expedited regulatory or given us, we wouldn't have ever thought that there would be this little sort of commitment to expeditiously moving through and ensuring that we had funding to actually provide the care to Washingtonians.
Mm-hmm. I mean, I also just sort of think about something else that you said around, this isn't just a DBH issue. We certainly hear it on the DC Health side around licensure. But if you're nationally accredited, and then we're like, nope, you got to submit all the paperwork that you submitted to the national accreditation people, plus 5 more pieces of paper, then is national accreditation not good enough as a standard? And if it's not, let's say that, but also what more do we need on our end that the national accreditation folks aren't necessarily asking for? For all of the folks who do residential programs and variety of, whether it be the emergency psychiatric care or for SUD, if you had a building that was paid for, right? If the capital costs were covered, how would that change the calculation in terms of the business model of the work that you do?
Chairman Henderson, Samaritan Inns has already merged one program with another. So we've had 2 empty houses sitting here, paid buildings. And so it's not that we don't have the capacity. There are so many other layers of the increased regulations, or as one said, workforce development, staff shortages. You can't get paid enough to do residential treatment. We provide, and I've heard it said so many times, you don't know what SUD does. They don't know what you do in resident. It's really difficult to manage. It's like PIW on a smaller scale for us in some regards, because they come in just withdrawing from PCP. There's no withdrawal management for them to go through technically. So they're in our programs withdrawing from psychotic drugs. All this increases potential for violence or just not even engagement in treatment. But we've had all our buildings are paid off.
All right. So you're saying the building is just for some, it might be important, but for you got 2 empty buildings. So there are other things, just kind of crazy to think about in terms of I have an organization who has full on capacity to serve. I've got patients who need a residential option, and yet we can't still make the math work.
Correct.
All right. Ms. Chauvin, you came on camera. Did you want to add to that?
Yeah, I will. And I think this points to, what Judy is saying. Earlier, Councilmember Fruman was asking about at PIW, what's the, staff to patient ratio? I know for our psychiatric crisis beds, we never have we never have more than 1 staff to 4 clients at that program. So it's very staff intense. So while yes, property, particularly in the District of Columbia, as we all know, is incredibly expensive. Judy is right. There's the costs are, so extreme for staffing when you have 24-hour care.
Right. Ms. Donderow?
Yeah, I was just gonna say there, rather than getting a new building that would be given to us, we have a large loan on the Ronald Clark Center, which is our largest building in our campus that offers all the levels of care. And that loan, and we would love to talk to you about loan forgiveness on that, but that loan prevents us from accessing lines of credit and other capital loans because many of our buildings need renovation, need fixing up. So that loan is sort of a preventive from us being able to really improve the safety and soundness of some of our other buildings, or to make much needed modernizations and renovations in the buildings that we have. If we didn't have that loan and you were just saying, could you expand services if we gave you a building? I think I'd point back to all of the other issues around the rates and the not having a per diem rate, to say that would probably be not something that we would pursue. We're trying to figure out how to weigh a way to keep offering the services that we're offering rather than expand.
Okay. And Dr. Haling-Williams, you have a building, but no certification. So it's like, I got mismatches all over the place here.
Precisely. And I mean, while we don't expect any, gifts, so to speak, but nobody lives anywhere for free, let alone a city as expensive as DC. And we don't ask the same of our hospital partners or other businesses in the district. And so why would we expect it for residential behavioral health services and community? We've got to house these people. I think she's sort of referencing, and that's something that's not often talked about, but the likelihood of damage to the space is pretty high due to people sort of coming down from losing touch with reality due to the substances. And so holes in the wall, things being, stained, and all of those things. And so that's an additional layer, plus security, plus all the electronic health needs and data collection and analysis and back office that goes without saying. It's hard to get my mind around it, really, in terms of what's the why? What's the problem we're really trying to solve, if one at all?
Okay. All right. I thank you all for your testimony. And please make sure we have copies of your written testimony. We'll certainly follow up with you if you have some additional questions, but I thank you all for being here.
Thank you.
As I sort of telegraphed before, so we're going to take a 10-minute break. Ms. Marcia and I have been sitting here since 11. And then we'll come back and do our government witnesses, but back in 10 minutes. Thank you.
Okay, we are back. We have our government witnesses, Dr. Barbara Bazaran, who is the director of the Department of Behavioral Health, Dr. Ayana Bennett, who's the director of DC Health, and Wayne Turnage, who is the deputy mayor for Health and Human Services, as well as the director of the Department of Healthcare Finance. You all have teams here with you. As you guys know, before we get started, I need to swear you in. So if you can raise your right hand. Well, you and anyone who might testify today. Okay. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth? Awesome. All right. Who's starting? Great. If you just turn your mic on, Director.
Good afternoon, Madam Chairperson and members of the Committee on Health. My name is Wayne Turnage, and I am pleased to be here today to discuss the behavioral health system in the District of Columbia with a special emphasis on inpatient psychiatric care. I am joined by two directors, Dr. Barbara Bazaran, Director of the Department of Behavioral Health, and Dr. Ayana Bennett, the Director of DC Health. Both will offer remarks today as we work through the presentation that has been loaded for the committee's consumption. And also I am joined by Melissa Bird as the Medicaid Director on Medicaid policy issues, and our Senior Finance Deputy at DHCF, Angelique Martin, who is here to address any reimbursement questions that may surface. Our focus with respect to the presentation is on the evolution of the district's behavioral health care system, the continuum of care that as it presently exists in the district, the intersection of Medicaid as the primary payer for behavioral health, and a discussion of the challenges and opportunities. I think it's important to begin our presentation by reminding all from whence we came. Due to the work of many mayors, council members, agency leadership, and mental health advocates, the district's system of mental health has been reshaped and reformed from a dark and pernicious past. Through visionary leadership and multi-year investments of millions of dollars, the system has been lifted from the aptly described subculture of misery that defined mental health treatment in this country. Nationwide and in the district, this was a system that was widely characterized by frequent and long-term use of involuntary confinement, was poorly staffed, and was largely located in depressingly benighted state mental hospitals, which had high death rates, patients who were often and against their will controlled by using psychotropic medications, and a near complete absence of structured outpatient services. While there remains much to justify our attention and future efforts, as we will discuss today, we are decades away from the old injustices that depersonalized and cruelly neglected those suffering with mental illness. Yet those dark days are appropriately serving as a punishing specter for this country's past sins against persons who are mentally ill, but it is also an admonition for government officials to vigilantly eschew policies that will return us to that shameful era. As we consider the state of behavioral health today, we cannot responsibly allow our desire for perfection to obscure all that has been done to improve the system. My initial comments around the evolution of the behavioral health system, they are summarized for your review on slides 3 and 4. In the interest of time, I will not discuss the information in detail, but rather make the following points. The 1964 Urban Act was groundbreaking legislation for the DC system because it embraced the goal of treatment for mental health, persons receiving mental health in the least restricted environment, while establishing a formal 3-step process to govern involuntary commitments. Because the district's response to the Urban Act was a bit slow, the federal government was hit with a class action suit that ultimately spawned a consent decree with specific performance and exit criteria for the newly established Department of Mental Health. Through the labors of many, the district successfully exited the lawsuit in 2010, and since that time, as illustrated on slide 5, has been making steps to transform and fully integrate behavioral health services into the broader healthcare system. I offer a slight caution on where some might be hoping to take behavioral health for young people. Notably, CMS, the principal source of funding for most all mental health services in this country, continues to strongly push home and community-based care for children in crisis. Further, there is a litany of research that argues against long-term hospitalization and certainly treatment with justice system involvement for those who are seeking mental health treatment in favor of an effective community-based treatment system. Additionally, if you look at SAMHSA's guidelines, they recommend that youth in crisis from mental health and substance use disorders receive care in the least restrictive setting, and if it's safe, at home and in the community. Whenever possible, hospitalization and justice system involvement should be safely reduced or prevented. This possibly explains why the federal government has not mandated this type of treatment unless the screening process for children identifies this as a need for a given child. So if there's a push for the district to invest millions in building a state psychiatric hospital for children, we will be swimming upstream. So with that, I would turn to Dr. Bazran to talk a little bit about the current system of behavioral health in the district. Then I will follow her, and then Dr. Bennett will follow her to talk about the role of DC Health. And then I will discuss the Medicaid payer information. And then there's a challenges and opportunities section that will mostly involve taking questions from the committee.
Good afternoon. Good afternoon, Madam Chair and staff, and thank you for the opportunity to speak here today. Upon the exit from the Dixon case 12 years ago, the district had laid the foundation for a comprehensive and mature behavioral health care system. The DC Department of Behavioral Health supports a healthier and stronger community through the provision of a high-quality system of care for individuals suffering from mental illness and substance use disorders. In FY23, 42,613 people received mental health services and 4,063 received substance use disorder services from DBH certified providers. A total of 2,932 received co-occurring mental health and substance use services. DBH provides a range of community-based prevention, treatment, recovery, and support services for residents of all ages through a network of 74 certified behavioral health providers with 124 locations all across all 8 wards. The continuum of care includes prevention, intervention, treatment, and recovery, services and supports for children, youth, and adults experiencing behavioral health challenges. A robust crisis support system is also available for individuals with immediate and acute behavioral health care needs. We are also responsible for the management of St. Elizabeth's Hospital, the district's 292 psychiatric hospital. Slide 8, please. Slide 8 really depicts the Department of Behavioral Health continuum of care and care coordination services, which now shape the behavioral health service delivery system within the District of Columbia. I'd like to start by making a few remarks on each of the major components of care. Prevention and early intervention services are designed to build resilience and self-care skills, promote healthy decision-making and pro-social behaviors, and improve well-being. DBH funds 4 DC prevention centers, which cover all 8 wards. They provide a variety of education and prevention services to adults as well as youth. Each center has a youth prevention leadership core, which is a youth-led, adult-supported group equipped to provide prevention education to both their peers and other community members. DC also funds prevention and early intervention services for children and youth through its school-based behavioral health program, Healthy Futures, and the Primary Project. School-based behavioral health clinicians provide evidence-based prevention, curricula, and observe youth in their classrooms to determine if early intervention support is required for those who evidence early signs of behavioral issues. Our infant and early childhood mental health consultants conduct observations within our 116 early childhood development centers. They provide information to staff and help them recognize and provide appropriate support to the district's youngest learners. We also have a robust system of outpatient treatment services. The Department of Behavioral Health offers several pathways for residents to receive the services that they need. This includes our 24/7 access helpline and the ability to enroll at any of DBH's 74 certified provider sites. Residents can get connected to care offered by DBH and its certified providers by simply calling 1-888-7-WE-HELP or the recent 988 line. This is available 24 hours a day, 7 days a week, and is staffed by behavioral health professionals who can refer the caller to immediate help, ongoing care, or provide support through both chat and text. Residents seeking care may also just simply walk in to one of DBH's 75 providers to enroll in services. Care coordination is provided to ensure that behavioral health care delivered by different agencies or entities are connected and aligned. All certified providers are required to develop and manage each consumer's person-centered individual plan of care across providers and service systems to ensure that services are integrated and coordinated. DBH staff provide intensive care coordination for those with complex behavioral health needs and physical health care needs that require cross-system level support. In FY24, 1,643 individuals received this intensive care coordination. Care coordination is also provided by this team for individuals being reintegrated into the community from a psychiatric hospital stay. Crisis services and supports are provided to residents who require immediate and acute mental health interventions and support by DBH's community response team. The CRT is a 24/7 multidisciplinary team comprised of DBH's clinicians and peers in recovery who connect on-the-spot assessment and referrals to behavioral health care for individuals experiencing a mental health crisis. CRT members are certified to have an individual taken into custody and transported to a crisis psychiatric emergency program or a hospital for emergency observation and diagnosis if there is a reasonable belief that they are a danger to self or others. A total of 2,901 involuntary commitments were made in FY24. The Department of Behavioral Health also contracts with 2 acute care hospitals, Washington Hospital Center, which has 30 operational beds for this population, and United Medical Center, which has 34 operational beds, and the Psychiatric Institute of Washington, the district's only mental Institute for Mental Disease other than St. Elizabeth's Hospital. PIW has 45 psychiatric beds and 12 beds for adolescents. It is important, however, to note that all acute care hospitals must accept involuntary and voluntary psychiatric admissions for assessment and stabilization in accordance with EMTALA. If person seeking care is no longer deemed a danger to self and others, they can be discharged. However, if an individual requires long-term inpatient treatment to address a serious and persistent mental illness, they are transferred to St. Elizabeth's Hospital. If screening and assessment indicates a less acute need, then behavioral health treatment is provided in an outpatient setting by DBH's network of certified providers. Additionally, DBH has strengthened its crisis system through the investments by Mayor Bowser into our first DC Stabilization Center. DBH's people assisting the homeless team or our PATH teams, funded by the Substance Abuse and Mental Health Services Administration, work with about 450 consumers a year in homeless shelters and encampments to connect unhoused persons to behavioral health services. DBH continues to partner with certified behavioral health providers to ensure the incorporation of crisis planning and treatment plans to help residents avoid psychiatric crisis episodes and reduce their severity and duration. In addition, we provide a range of recovery services and supports. Behavioral health can be a chronic and relapsing condition. As such, recovery supports are an integral component of the continuum of care. DBH offers recovery supports through certified peers, certified providers, and family-run organizations. In addition, over 188 certified providers with lived experience provide these recovery services and supports within our system of care. At this point, what I would like to do is now turn the presentation over to Dr. Ayanna Bennett, Director of DC Health.
Hello. Thank you for having me.
Next
ma'am.
slide, please.
That's me.
Yep, slide 11.
Okay, thank you. Thank you, Madam Chair, and to the committee. I'm going to talk about our existing regulatory framework, which DBH is the lead agency in. I'm going to actually start by giving some information I think that might be a corrective to some of what I heard from the testimony that was given by other witnesses and perhaps even by some of the council members. So our regulatory framework is, for the most part, fairly dominated by the federal regulatory framework. We are the representatives of CMS in the district. They fund the majority of the inspection staff. We are most of the time enforcing CMS regulations when we're in a hospital. There are certainly local regulations and statutes, but they are far less numerous. And we are doing both at once whenever we are somewhere. Because of that, CMS has a role in everything that we do that does restrict some of what we are able to do in terms of communication and coordination. So according to CMS rules and our local statutes acknowledging that, we cannot let someone know that a inspection is happening, and that means anyone other than the designated agency, which is us. We are going to work out something to see how we can expand that team to include other people. We are talking about including having different people on our own staff, but the coordination that has been mentioned is not something that's allowed. We also need CMS approval to go on some of these inspections, which takes time. We need their approval to share the results of an inspection, which takes as much time as they take approving it. So we may have done the inspection. One of the ones that was mentioned, we had done it within a week, but getting approval of our results so that we then could share it, even if FOIA'd, takes more time than that. And that is factoring into what people are seeing happen. They are not necessarily choices that we are making, but they are rules that we have to comply with. So overall in the district, inpatient psychiatric facilities, just like inpatient medical facilities, are overseen by DC Health, while outpatient care is regulated by the Department of Behavioral Health. DC Health and DBH have a primary focus on patient safety and physical infrastructure in that oversight and are able to act when a deficiency is identified through a routine survey or complaint. For inpatient settings such as hospitals with psychiatric services or like PIW that only do psychiatric services, in order to become a facility, they must attain a certificate of need from the State Health Planning Development Agency, which is part of DC Health. SHIFT is charged with determining whether there's a public need for that facility, for that type of care, or an expansion of that type of facility. The health systems plan is critical in determining whether such a facility is needed. And while the current plan is undergoing final review, the 2017 plan does say that we need behavioral health services and how new services can fill gaps and coordinate with other systems of care, including our physical health services. Additionally, if changes are made to a CON, so an institution wants to use beds differently than they were initially awarded, SHPTA must also approve and issue a new certificate. The CON process maintains an equitable integrated healthcare system and focuses on healthcare affordability and access for patients in all 8 wards. While this process applies to inpatient psychiatric facilities, it also applies to other provider types. Through this process, SHPTA can ensure that facilities are serving priority populations, including those in specific geographic areas or covered by different insurance types. Once a hospital has its CON, the entity is eligible to receive a hospital license through the Health Systems and Preparedness Administration, which I'll just briefly tell you, we have broken up the Health Regulation and Licensing Administration, which had oversight over things like restaurants and rodent control, but also health facilities, to remove the things that were not health facility related so that we can get a more focused, active oversight of our own facilities work. And so that is one part of the agency now, separate from all of those other functions. So the Health Systems and Preparedness Administration has an Office of Healthcare Facilities. That is a key component, and it licenses and regulates hospitals to ensure their compliance with infrastructure, safety, protocols, planning requirements, a whole host of things. In its role, the Office of Healthcare Facilities routinely surveys licensed hospitals to monitor for sustained compliance with licensure requirements and standards of practice, and investigates reports of alleged and potential noncompliance. When noncompliance is substantiated, the office has different mechanisms of enforcement, including imposing plans of correction to ensure that identified issues are remedied. That the HISPA, I forget what we're saying for that, HISPA also, through that office, licenses and regulates health professionals, including the majority of staff at hospitals. Those staff, including psychiatrists and other physicians from the Board of Medicine, as all nurses, and other folks who are overseen by the boards of social work, psychology, professional counseling. I just want to point out that we do have rules about what kind of staff need to be in a hospital. We and the federal government also do not actually mandate staffing ratios in any way, and never have done. So there's some assumptions being made in what we are able to oversee that we actually don't have authority to oversee. So finally, the process of outpatient psychiatric facilities requires entities to obtain certification from DBH. Additionally, both inpatient and outpatient psychiatric facilities must pursue Medicare certification through DHCF, allowing them to treat patients with publicly funded insurance. In the fiscal year 2024, providers certified through DBH saw 42,613 people receive mental health services and over 4,000 receive substance use services. These providers are critical to ensuring that at-risk populations have access to quality behavioral health care. There are additional mechanisms for oversight when entities contract directly with district agencies. For the most part, that is DBH. One relevant example is Psychiatric Institute of Washington, which contracts with DBH for its FD12s. Those patients that are contracted are overseen by DBH. The hospital in general is overseen by DC Health. That oversight's in terms of the contract. So to talk about the way the financing is done and how that is a form of oversight is, I'm going to give it back to you,
Okay,
Deputy Mayor.
Before I quickly summarize the financing piece, you probably noticed that there was no discussion of DBH's state authority with respect to regulating outpatient services. That's because Dr. Badron skipped completely over that slide. So she wants to summarize the result, the authorities they have on the one slide.
Director Turnage, while I appreciate the presentations amongst the three of you, I will get to some of these in the questions if we can get to the questions. You all collectively have been going for about almost 40 minutes.
So you want us to stop right now?
Oh, go ahead, because the financing part is important. So go ahead.
Oh, okay. I was hoping you said you could skip it. If you turn to slide 14, you will see the penetration in the Medicaid program by both adults and youth who have diagnosed mental health issues. They're about more than a quarter of adults in the Medicaid program that have been diagnosed with a mental health issue, almost 20% of youth. The dollars spent on mental health in this city are substantial. In fiscal year 23, we spent almost $185 million through DBH, mostly on the mental health rehabilitation side. They accounted for 88% of the $184 million that was spent. Of that 88%, the vast majority was spent on community support, 63%. And then there's some specific services that were targeted outside their 63% that accounted for the difference. If you turn to slide 15, you shall see that during the pandemic and after the pandemic, Medicaid funding for mental health was largely sustained. And then when you worked in the enhanced payments that we got from the federal government under the public health emergency, and there was a significant spike in the dollars that were spent. We went from 147.7 million to 185.2 million. That number has roughly sustained itself since the PHE ended. The budgeted amount for fiscal year 2024 is over $176.4 million. Now, there are some, one of the reasons that the numbers have continued to stay at a fairly high level can be seen in our shift to telehealth services. We did this during the pandemic because we feared that people who really needed to be in treatment would not come outside for fear of getting COVID, and they would their mental health crisis could easily exacerbate. And so we emphasized the use of telehealth. What we didn't anticipate was the growth in audio-only services, which, justifiably raised some scrutiny. It is difficult, at least from a layperson like me, to imagine how you can capably deliver quality mental health services by just talking to somebody on the phone. I think you can do some things, but if people are in severe crisis, I question how we could end up spending almost $40 million on telehealth services. So we have our people we have an excellent fraud investigation unit. They're looking at this issue closely. DBH is looking at it closely. And we want to make sure that if it's, even if it's audio health, that it's quality. But we have some concerns about that. On the inpatient side, we set inpatient psychiatric rates for 4 types of providers. The PRTFs, we don't have any in the city. So what we do is when we send a youth out of state for a PRTF, we either pay them their existing state Medicaid rate, or we pay them their commercial rate if they do not accept Medicaid. And if they don't accept any commercial insurance or Medicaid, then we pay their private rate. When you look at the average of what we pay, it's about $550 a day. And if we go above that, we would need to change the spot. We also pay PIW. We pay PIW 147% of their costs. And if you adjust it for the patient acuity, then the amount paid goes to $2,259 for per day for the treatment that is provided. Inpatient hospitals the rates are set annually by Angelique and her staff in a meeting with the Hospital Association. Children's attends those meetings. We go through a detailed discussion of our methodology. We show them their utilization, and we show them how we set their rates. The present rate methodology, we do make adjustments when a hospital may say, well, we don't believe you fully captured our acuity levels. We can make some changes as we've done for children's. But the rates that we pay are pretty significant for children's, for example, because I know there was some concern about whether or not we pay them sufficiently. And I will say, we've not had any discussions with them outside of their rate setting process about our rates being insufficient on the fee-for-service or our MCO side. On the adults, on the MCO side, we pay them 122% of their costs. On the pediatric side, we pay them 101% on the MCO side. On the MCO side, we pay them 101% of their costs. On the fee-for-service side, they don't have any adults, as you would expect, and we pay them 83% of their costs for pediatric on the fee-for-service side. Now, what does that mean in dollars? That 83% accounts for $27,252 per episode of care. It is more than any other facility in the city. And if you look at the utilization, that average, they have, in 2023, they did 28 days. They had 28 stays that totaled 473 days, which is significant. If you go to slide 18 quickly, it'll show you how many youths that we have placed in out-of-state PRFTs and as PRTFs. And as you can see, next to that number, the placement process is explained. There are multiple agencies involved before a child is sent to another state for care. And I would say that it is difficult to envision a facility in the district that would be sufficiently broad in its scope to provide the kinds of services that we send kids out of state for. These kids are severely emotionally disturbed. They have specific behavioral problems that require us to send them to treatment facilities that specialize in those particular illnesses. They could be fire starters. They could have, they could be identified as people who are prone to commit sexual assaults. And you can have a PIW or another facility or hospital, and they can't handle that kind of dysfunction. So we have to send them out, and they cost a lot of money. So if we're thinking about a facility in the district that would minimize or reduce this number of kids who are going out of state, it has to be a very, very comprehensive facility, and it has to be adequately staffed, obviously. There's a whole slide that I won't get into on how we set rates for community provider types. Angelique is here, she can give you the details, but the community provider types are freestanding mental health facilities. Obviously, mental health rehab. We have adult substance use rehab, adolescent substance abuse treatment expansion programs, and then we have the behavioral health transformation waiver. That completes the substance of our presentation. We have challenges and opportunities that we've identified, but rather than, I think you all know what they are. There are issues around capacity. I know you have issues around quality and whether or not we are adequately monitoring quality, and if so, what are we doing about problems that we identify? So we are here to talk about, answer your questions about those issues, and also discuss what you may feel and what the directors may feel are regulatory gaps in the process. So with that, I will stop talking and let you raise any questions that you have.
Thank you all for being here and for the information that you provided in the presentation, which I think is super helpful in terms of grounding us in this conversation. And for those who are watching in the public, we'll make sure that that is part of the record so that folks can take a look at that. There are lots of different pieces that came up today in conversation, but let's start with the regulatory framework of things. Dr. Bennett, you talked a little bit about the relationship between you all and CMS, specifically as it relates to the psychiatric inpatient hospital facilities and then other facilities as well. And that, I guess, in some ways, as you describe it, you all are an extension of CMS in terms of the authority pieces, and there's conversations that happen back and forth and those kinds of things. What's the feedback loop exactly? And by that, I mean, let's say you do the investigation, you determine that there are, in fact, infractions or something egregious that is taking place. Are you required to report back to CMS what was found?
Yes, and they both approved us to go out. So they were informed about the incident before we went out, and they approved the results of the inspection.
Okay, how long does it take for CMS to generally approve for your ability to go out? I imagine if there's some sort of, I don't know, assault on a staff or assault on another patient, I would hope it's not days.
It can be short, but it also can be a number of days in different circumstances. Yes.
Okay. Is the CMS authority alone enough?
And explain what you mean by that.
I mean, do you all see gaps or challenges in the fact that you are operating through a CMS authority as opposed to a local authority?
We have some local authority. It is not nearly as robust or detailed. Most of what is under DC Health Clear Authority is generally for hospitals. There's very little that's specific to a psychiatric facility or even the psychiatric services at hospitals, there are regulations that are referable to that are really written in the statutes as if they are meant only for DBH funded services. So we have been looking for some months around working on our oversight of psychiatric facilities and other facilities. And so our current plan is to duplicate some of those from one part of the regulations to another to give us much clearer, more detailed authority over some of these issues, and to probably see what we can duplicate of CMS's authority. We don't have independent authority on some of the things that folks were mentioning. So we are imposing a consequence being directed by CMS rather than deciding on a local consequence for many of the things that we would be noting.
Okay. I would imagine that, well, and I don't know, I mean, for CMS, are they more about compliance and safety versus quality?
The entirety of regulations more about compliance and safety more than quality. Quality is quite subjective. And so, and also the definition changes. So if I'm doing processes that were state of the art in the 1950s, I'm probably not doing quality anymore.
Right.
But legislation and regulation don't change that quickly. So for the most part, what we're enforcing is patient safety and infrastructure, that you have the kind of staff you're supposed to have, that you run your kitchen in a way that's not going to give people infections. So we are enforcing safety and a general baseline standard of behavior. We are not nuancing between whether or not you're doing a good job or a bad job at making people better. There are some ways in which that is very clear. So you have surgery mistakes. It is less clear in psychiatric care, but it does not mean there's not possible to set those standards. That has not been done in the law that has been passed in the district to this date.
Okay. Director Turnage, you kind of mentioned this in the ending of your comments around like, in terms of out-of-state facilities, that they need to be adequately staffed. Obviously, we would want that for any facility, but and we don't do staffing ratios for hospitals in general. But is that something to the question of safety, right? Not infections or surgery type safety, but just physical safety of staff. We heard a couple of witnesses testify about this today. Should staffing ratios be a requirement when it comes to psychiatric facilities?
You, me or her?
Either one.
Well, she's a doctor. I'll let her.
Staffing ratios can be difficult. We do have staffing ratios, and so does the federal government around nursing homes. But that is quite different in that there's a really regular standard of what is happening at a nursing home. It's not so different from day to day. In a hospital, who is there at any given point? You may have a full surgery wing, you may have half a surgery wing, and people call out. So do we want them not to operate?
Right, no,
For
but
the hour that somebody's out?
Outside of the traditional setting, right? Because psychiatric is a little bit different. You're not.
But it also varies depending on who's, if someone's length of stay is 6 days on average for some of these services, that's also quite a lot of variation. So it would be difficult to do, but if it was the law, we would enforce it. I do think there's a nuanced discussion to be had with all of the facilities about what that would mean. Because I think what we probably said as the minimum is probably not the best. We don't set a minimum right now, but if we did set a minimum, you would want to leave some room for reality, and that things change, and you manage to do this with one person instead of two. We change the kind of people who are doing the job, which is kind of how healthcare has happened in the last 20 years. So I think it would be difficult to do, but it would be enforceable if we did it.
Okay. It seems a little interesting that we look at adequate staffing of out-of-state facilities in more detail than perhaps we look at our own in-district facilities.
Yeah, my view on it is, I think, first of all, if you want to increase the staff to patient ratio, you have to be prepared to pay for it. That's the first challenge. And these services already cost a lot of money. So, and then you have to be fairly certain that the incidents that occur would be mitigated, if not eliminated, by more staff. I don't think that's the case. I think when you're dealing with people who are in psychiatric facilities, it's a very volatile population. They have come from some deeply troubled backgrounds. And you could have, almost 1-to-1, and you can still see assaults. And of course, it's the facility's job to control the quality of the input. In other words, if you go 1-to-1 staffing, that's not going to stop somebody from preying on kids if they're not. So that's the facility's job.
Right. On that front, sure. But on some of the others, I think we had a registered nurse who testified earlier. One of the times that she was attacked, it was only 2 people who were on the floor, 1 got called away, right?
Yeah.
So then it's me
Yeah.
against 6, right? Or whatever, what have you.
Yeah, and that's a problem, but I think to Dr. Bennett's point, even if you had staff ratios, people call in sick.
Yeah.
People leave the floor for whatever reasons, and you could end up with a number that's substantially below the staff to patient ratio. So I guess my point is, even if you put more staff in the facility, which is never a bad thing, and if you want to eat the cost, you're not going to bulletproof yourself from having the kind of incidents that were described. Very troubling, but when you're dealing with that mix of children, it's a challenge that will be hard to defeat. So you just got to manage it.
Dr. Bennett?
I just want to caution, what we mean by staffing ratios is generally who's assigned in an area. There's no reason other than we didn't have someone or we didn't have a protocol why when someone left the floor, someone temporarily could not have come to a floor to provide the kind of support that was needed. That is not outside the usual behavior of a hospital. So sometimes what we're seeing is a inadequate system of backup and protocol. We're seeing a leadership issue, or we're seeing a complex process that is not really being accounted for by the protocols that are meant to keep things consistent. So things don't stay consistent. So you should have protocols in place for what we will do if. So if someone calls out, what will you do? If someone needs to go to their car, which we had an incident like that, what will you do? So not having the kind of flexible support that you would need in order to be able to have things be variable, because reality changes things from moment to moment. That's about the protocols and leadership of the agency, not necessarily a staffing ratio. Because even if you had the number, so having a rule that you must have adequate staff in order to ensure safety is likely specific enough for us to say, well, 1 person on a floor was not adequate.
Right.
But we have not articulated even that to some degree.
So there's
in
some
our-
gaps there that we
Right,
need to.
We do have some gaps in where we are not articulating probably in the detail we need to what we mean by safety or what we mean by some of the other requirements that we say are what we would like to have in our quality care. Some of them are in CMS statutes, but we don't have local authority to enforce those. We enforce them on behalf of CMS, and then they decide what the consequence of that miss is. We don't have the authority to do that. And where we do have authority, we do need some work on our funding and our fee schedule, which I believe has not been changed in 20 years or nearly 20 years. We might want to work on that as, a 2000 price and a 2025 are not equivalent. So there are some things that we have already got in a set of things we're working on to change in terms of adding regulations. Some of them may in fact need to be statute, not regulation, and then we can have a conversation about where statute might be better.
Okay.
One point of clarification, we update the fee schedule.
For the, no, not the payment. fee,
Oh,
but the-
okay. Angelique was about
Sorry,
to call her.
no. I meant the fees for infractions.
Oh,
So
I
if
see.
we say an infraction, what is the fee we could charge you as a punishment?
For enforcement purposes.
Right, an enforcement
Not
fee schedule,
payment
not
upfront
the payment.
purposes. They were freaking out over here. Okay, so in FY '23 and FY '24, were there any adverse action taken by DC Health against any of our inpatient psychiatric facilities?
Adverse action meaning we found and noted, we did a notice
There
of
was
infraction.
deficiency that posed a serious threat? Yes.
Yes,
Okay, and what was the outcome of that
I do.
in terms of a corrective
Look them all
action?
up. I have a long list of them. Hold on. Some of them, for the most part, what we're doing is telling people you have failed to have a condition in place, and then you must do that, and then they correct it. So mostly what we're trying to do is maintain the set of correct conditions. This person didn't have a license. You need to have somebody with a license here. I don't have that list in front of me. I know I have the list prepared, so give me a moment, but we have done notices of infractions around patient rights, which was a safety issue. We have done them around different technical issues around who was present somewhere or whether or not you had a licensed person. But usually it's a corrective action plan and not a punishment per se.
So I think the testimony that you all provided earlier was helpful in perhaps clarifying the demarcation of responsibility between DC Health and DBH, because I feel like there is some confusion, right? In some instances, someone would say PIW would be a DBH from an oversight standpoint, but we treat PIW as a hospital, and therefore inpatient facilities are DC Health. Yes?
Yes. Because PIW is private and not supported, at least entirely supported by DBH, it does not fall under the certification regime that St. Elizabeth's does.
Do you all get information on that patient payer mix for PIW?
Well, they're not owned and operated by them. So they would have to be owned and operated. That the way the statute reads, it really is that the things that are owned and operated by DBH are regulated under the certification regime.
Okay, Dr. Bennett.
Is not.
Sorry,
yes,
that's wrong.
Even though, hi.
All the B's.
Even though DBH does not have regulatory authority over inpatient hospitals, because we have a contract with PIW as well as the other two hospitals that provide services and supports for individuals on FD12 status, we do in fact go in as a part of our contractual relationship to provide oversight. We actually have increased our oversight since beginning October 1. We, prior to October 1, had monthly site visits on site for PIW to observe environment of care, to see whether or not the appropriate strategies and so forth were in place. And we also twice weekly did case reviews, looking at the individual plan of care and where people were in terms of the progression towards having their issues resolved. As of October 1, we doubled that. We also increased.
You doubled the
number of
frequency.
visits, the frequency.
Okay.
We doubled the frequency. And in addition to that, we also added an additional advanced practice nurse as a part of the on-site review team. Rather than simply having an LICSW, a licensed social worker, do that review. We now also have an advanced practice nurse who does that review, who can look, really specifically at the clinical care that's happening.
Yeah, Dr.
I
Bennett.
just want to clarify, those are under the contracted patients.
Contracted patients.
Not all of the other patients at PIW. Those would have to fall under a regular licensing review.
Okay. Okay, so DBH is going in and you're having these conversations and you have an APRN who's coming in and doing this work, but it's only for the cases for which we have contracted for.
Correct. For individuals who are there on FD12 status, who are a part of our contractual oversight responsibility.
What percentage of the patients at PIW are usually there on FD12?
I think that there is a chart. PIW probably provides about almost a little bit more than half of services for all of the FD12s.
Yes, nearly 60%. But my question is, and I should have asked Dr. Khan more of these questions or the CEO if he had come, but around, if you got 100 beds, what percentage of that are FD12 or contracted with us versus everyone else? Does that make sense?
Yeah, it was a good question. I don't know if we have that data.
I can tell you how many
We'll get it. We'll get that data.
beds
Okay.
they have, but the percentage.
So I think that's helpful to sort of have a better understanding, right? If it's FD12 contracted or DBRS, well, we have ebbs and flows with them on that front. But if for PIW, 80% of their funding is coming from the district government,
Mhm.
then I feel like we could be asking more than if it's 25% and then everything else is private. You know what I'm saying?
Well, Medicaid and Medicare pay
Right.
for a lot of care everywhere. So the district government, one way or another, is paying for care in a lot of places. We don't necessarily consider those to have different
Yeah,
oversight. This
yeah.
is something different. The
Yeah.
FD12 contracts is not the same thing. It's a
Sliver.
part of district
Yeah,
government
I would be
support.
very surprised if PIW had a large private pay population. It is mostly Medicaid.
It's mostly Medicaid.
I mean, a substantial portion.
Okay.
But we'll get those precise numbers for you.
All right, I'm over my
All right.
time. We've been rejoined by Councilmember Fruman from Ward 3. Councilmember Fruman?
Thank you very much, Chairwoman Henderson. I'm looking at the presentation and I think, I don't know what slide number it is, but it says monthly FD12 admission
Admissions.
40, oh, no, for PIW, it looks like 112, which seems like probably close on 80% of the full.
They're short stays. So who is in a bed is a little more complicated than that because they're short stays, right?
I
You
see.
might be there for 2 days out of the 30.
Ah,
So
you'll
we
check.
really would have to
Right.
check to get that answer. And it would be a point in time at any given time.
So I'm trying to square the circle on testimony this afternoon and earlier in the day. Dr. Khan said they have a grid and it was 1 nurse and 2 health techs per 21. But then you're saying, and he said that had been reviewed by the agencies, then you're saying there aren't staffing ratios. I understand how the two could be possible. I guess what I'm wondering is it as part of their presentation of their costs that they show that, and that's what how do you square what he was saying and what the former employee said, that when it's over 18 in a unit, then it's supposed to be 2 nurses, to the idea that there aren't staffing ratios?
So they and all other hospitals have protocols that we do review that have to have some degree of reasonableness. But we don't tell them what that number has to be. So that's the difference. So if they said we have 2 nurses for every 100 patients, we would have a problem and probably want to have a conversation. But we don't tell them it has to be 2 for every 20 or 15 or whatever, because the severity of their patients may be different. The nurse to nurse assistant may be different. So you square it by saying we have seen it and said that it's not overtly dangerous. It is a reasonable way to go about it. And that is the protocol they use, but it is not the same protocol as other places.
And does that protocol, I mean, you pay 147% of their costs. So how does that process work? Do they come to you upfront with a pro forma of what they're going to do? Do they come to you afterwards and show you what their costs are?
We have I'll let our finance deputy come. We do a annual rate setting with all the hospitals. And Angelique can explain. It's a very detailed, tight, data-driven process based on our analysis of provider cost and some of the policy requirements in our SPAs, our state plan amendments that we submit to CMS. Angelique can give you more detail.
And so for PIW.
Angelique, you just got to
Just a little
introduce yourself
closer.
for the record.
Angelique Martin, Senior Deputy Director of Finance at Department of Healthcare Finance. And so when we set hospital rates specifically for PIW, we consider them a specialty hospital, and we do it based on cost reports. So they're required to send us an annual cost report. We also compare and look at their reimbursement as well. We look at the severity of stays, their case mix. We also look at their cost, as well as look at how much we've paid them. And based on a calculation, we determine how much they should be paid based on that data. So it's based on actual cost.
So it's looking backwards, and that's what you
Yes.
pay for the next year?
Correct.
I see.
Correct.
And so, when you look at that, do you say, this cost, we're not going to reimburse you for this cost because for whatever reason? Do do you cull through the cost or you just take the costs?
On a scheduled basis, because we do this annually to make sure that we're staying with the most recent cost, on a scheduled basis, we do audit hospital cost. And so we bring in a third-party auditor and they review all of our provider rates. And so when they look at the hospital rates, we do make sure that we're paying allowable cost. And allowable costs are determined by federal regulation. And so if we see costs that have been included that should not be, we do disallow those costs.
Okay, and then why 147% of costs? I can't be the first person.
And so what happened was years ago, we based the rates on cost. And that particular year, the costs were high. And so every year after that, we were inflating because our previous SPA stated that we would inflate every year until it was audited again. And so what happened was we continued to inflate where the cost did not carry that same increase. And so what happened was inflation took the rates above 100% of cost. As we've been working with PIW over the last 3 years, we've been reducing the percentage of cost. PIW has complained about sufficient payment between DBH and DHCF. And so we want to make sure we're allowing a sustainable PIW to exist. And so we incrementally reduced the percentage of cost that we were covering.
And is there a goal over time of where, because a different entity, it was 122% of costs that you talked about, and another one was 89 or 102.
So with inpatient hospital rates, we set rates across all of our hospitals. And so it gets to an average. With specialty hospitals, each of them are 100% individually. So we have 3 specialty hospital systems.
And one thing that drives, on the inpatient side, you might see one hospital, we'll use Children's, they're being paid at 83% of their costs, but that could be influenced by their use of their charge master.
The use of what?
What they call a hospital charge master is how much is they basically identify what their charges are, and then they use that as a basis to negotiate with insurers to try to get a favorable price. So hospitals will sometimes run that charge master up pretty high, and then they'll go to the insurance company and say, look, these are our costs, how much you're going to pay us. And even if you pay them a percentage of it, not their full cost, they'll probably in some cases get more than the item that they're charging you for. For example, I'll give you one case of a drug, amlodipine. Some hospitals charge you 5 cents per milligram. Some hospitals charge you $50 per milligram. So it's what their charge master dictates as their cost. We don't argue with them about what's in their charge master, but we're not obligated to pay them over the cost of their charge master.
Fascinating. So, I mean, because you get the bill and nobody ever pays. The only people who pay the bill are people who have no insurance and they have to pay out of pocket, which is a tragedy. But we're not paying it either, although we don't know whether we're paying more or less than the insurance companies are paying, probably more. Back briefly on the protocol. So if you looked at you've heard testimony, you've seen reports from the disability rights. If you looked at a protocol, do you ever say, I'm worried about the kind of scenarios that have been described where people shouldn't and make a suggestion for things that could strengthen safety? I hear you that you're never going to make it all go away, but where you have one a day, it sounds like feels like an issue.
It is one of the things that I consider a regulatory hole. If you look at what our regulations are specific about, consent, restraint, there isn't really much specificity around patient safety. It is something we consider to be a hole that we're working on. What kinds of regulations would we suggest in here, and can we do it under regulation and not change it under statute? So we are still in that review process that's why the staff from the office is here and their lawyer is here, but we have not finished that process. So I can't give you specifics on what we would say, but if you look at what is already there, it is not robust.
So, I mean, that's a place, I'm sure, Chairwoman Henderson, we want you to be in a position where you can have requirements that promote safety. Last question, and there's the number 42,613 people who have received mental health services in FY24, and then a certain number for substance issues. How did those numbers compare to pre-COVID?
Go back and get you those. We can go back and get you those precise numbers. We can look at our claims data.
Right.
But in general, do you expect that they're higher, that we're serving more people today than we were before, or the same?
I would say in terms of substance use disorders, we did see a slight decrease in the numbers. The other thing, though, is we saw telehealth, as the deputy mayor said before, really go through the roof. And we found that a large percentage of people were receiving their services through telehealth during COVID. And in addition to that, there were also other virtual opportunities for people to receive services. For example, our school-based behavioral health program, the clinicians provided virtual opportunities for individuals to receive the therapeutic interventions that they needed. And so we saw substance use go down a little bit, but we also saw telehealth go up.
So, I mean, the work that you all do is so important. It does feel to me like COVID was an earthquake in terms of mental health, and particularly for kids, and we're still feeling the aftershocks. So I want to see you fully equipped to deal with that reality.
And that's one of the reasons why I think our school-based behavioral health program is so important, because we have the services right in the schools where kids are all day long. We do have, as was mentioned, some service gaps that we would like to really fill, particularly around residential services, IOP and PHP for our youngest citizens, as well as inpatient.
I would just to say that some of what we've seen is not a difference in number, but a difference in severity. And that is where needing to kind of rebalance the system, which is not an instantaneous process. That's part of what we're talking about in the health services plan, is that if a child who might have been able to maintain some level of balance with just a school counselor talking to them once a week, now maybe needs to be an intensive outpatient program for a few weeks. That maybe wasn't needed as much before, but now we don't have it. So some of the things that we're looking at as holes are holes that maybe we were okay without for some period of time, but we aren't anymore. And so we're having to move things around. It's not always number. Sometimes it is just the kind of care.
Good point. All right. Thank you very much. I'm over, so I'll step back. Thank you.
Thank you, Councilmember Freeman. I want to go back to sort of talking a little bit about quality or outcomes. If a lot of our regulations and the information with CMS is focused around compliance and safety, how do we determine what is quality in terms of outcomes for patient success?
Good question. And I'll let the doctor handle most of it, but quality, measuring quality is so subjective. If you talk to the patient, you can get their perception of whether or not they receive quality treatment. If you look at the patient records, they might suggest something else. And certainly if you talk to the hospital, or they might suggest something even different. And you know, if you use, for example, if you use the CMS surveys of patient satisfaction for hospital services, you would probably, based on those results, say we need to shut down a couple of hospitals. But that doesn't mean that was a good reflection of what was actually delivered.
Right, but I feel like in traditional hospital settings where you have surgeries and procedures and otherwise,
I could say what is quality based upon how successful that procedure was completed,
Correct.
lack of sepsis rates, this
Yes.
X, Y, or Z.
Yep.
But on behavioral health side of
Very
things,
That is true.
Mhm.
I would say partly that is just that we have been doing that in medicine for longer, but not forever. We did not really talk about quality and the fact that you had readmissions or somebody else didn't as a difference between two hospitals until, what, 20 years ago? And we are still learning how to do that. Payment has only been attached to that for 7, 8 years.
okay.
We have not really been in the same pathway with behavioral health generally.
So
in
Dr.
terms of
Bazaran,
PMS payment.
Dr.
Yes.
Bazaran, let me ask, right, if DBH gets a call from a client with a complaint about something that occurred in an interaction with one of the core service agencies, it's not a safety, it's not about money, but they felt that it was inadequate care. How do you all evaluate whether or not that's a legitimate complaint?
Well, first of all, our Office of Accountability would then take the complaint and then would go out and do an investigation to determine what happened, to interview both the person who provided that information as well as going on site and doing an investigation. And then if it's found that there's some culpability, a corrective action plan could be developed to address those issues.
We also do, while we do have much more clear outcome-based quality in medicine, people got infections during their surgeries or didn't. We have always used standard of care and the judgment of other providers to determine whether a provider was doing the right thing. And that is true in behavioral health as well. That is why we have multiple boards. So if someone was given care, the practitioners who delivered that care would be reported. We would have the other providers of a similar type look at what it is they said they did and whether or not that conformed with what is the current standard for their profession.
Right, that's
Right.
for
It's
licensed
for-
professionals,
for
right?
professionals,
I
not
got a
for
whole
facilities.
peer situation. I got community health support situation. Right? There's an ecosystem here
There
that
is.
is just kind of just floating in a way, sort of. I mean, it's tied to the facility, obviously, but I am just trying to understand this even more deeply because, Director Turnage, correct me if I'm wrong, you all are starting to sort of evaluate MCOs based on readmissions. And so if I'm I'm not trying to take up for the MCOs, but let's just play out the hypothetical situation. I am an MCO. I've got a patient, an enrollee who was in a hospital. I've connected them with a CBO or core service agency that Dr. Bazaran licensed, et cetera. And 4 weeks after they're discharged from the hospital, they're back. And now I'm getting dinged for that. But I don't control the quality of the services that are being provided on that side.
That is correct. And you sound like me when I talk to my staff who want us to go further in penalizing hospitals and MCOs for stuff like readmissions. And I tell them what you just said. A lot of this is patient compliance. And if the patient does not do what the doctor says or what the MCO suggests, there's nothing they can do. And that patient shows back up with a problem that has been aggravated because they didn't follow their discharge requirements. We should only go so far in holding providers accountable for that. You've got to realize that the patients have some responsibility here.
I think we need to have a larger conversation on this. Unfortunately, Councilmember Fruman left, but this has definitely come up a lot in his particular area of the city, right? People hear services, constituents, the public. They hear, oh, DC government is providing X services, and their definition of what services means varies widely. But perhaps the biggest thing that I feel like is different is that folks don't understand services is also voluntary. Right?
That's right.
So, they might be in a permanent supportive housing program receiving services from DBH or from DHS, but what does that mean? And what is the quality of that? And can it be quality if the person on the other end is not taking up that offer?
It is always both.
Okay.
Right? There are patient responsibilities, but we do know that there are barriers that prevent patients from participating in things that are perhaps amenable to change. When value-based payments have been done well, it has impacted how much people came in. And it's because it forces the system to stretch itself to do things it otherwise would not do, make people have transportation. It also means we have a commercial system. So the degree to which an MCO or somebody else takes their money and walks to a better provider, it changes the quality of care. We are not paying that person, they are. So the degree to which they exercise their power as a consumer to move things to better quality care, that's how the care gets better.
But that also recognizes though that the patient has some level of determination that
They
what
do.
they are
Absolutely.
receiving
They do.
is not
They do,
working
which
or
means
good.
some of it's not going to work. They're going to get dinged on some level, but they are motivated to change the parts they can change,
Okay,
which
'cause
is
I-
quite a lot.
Yeah, and within the behavioral healthcare system, as you and I've talked about, services really are not only voluntary, but individuals in care can decide, I don't want this particular core service agency and re-enroll in another one if they feel that that's where they can get better care. Consumer choice is certain that something that we really adhere to.
Okay, I mean, let's see, you said FY '23 and fee for service, $184.6 million that we have spent. Somebody's not moving,
A lot of money.
right? Because folks are only getting paid if a service, well, in theory, a service has been completed. Correct? I have,
You touch on a really good point, and I'm not sure how if it can be incorporated in this. This is what we don't do very well, at least on the healthcare side. We don't go back and look at providers for whether or not the treatment they provided had any efficacy. We don't. And I'm not sure we can, because it's a difficult thing to do, but if,
I understand, but then we're just
oh, I know. Look.
not lighting money on fire, but that's what it feels like.
Oh,
right?
absolutely.
Because it's in the same, in the same vein as, sometimes we have nonprofit or advocacy organizations. And one of my questions to them is, are you trying to put yourself out of business? Are you trying to end the thing that you say is harmful?
Right.
Or are we trying to take a little chunk out, but stay enough so that you can continue to receive your 5% administrative fee for whatever it is that you're doing? And so on this front, I have to ask the question, do we have providers who are simply maintaining the status quo, or are they moving people to a place of no longer needing their services?
I think many of them try.
Yeah, I think they try.
I think they try, but it is, I don't think a lot of people understand how amazingly difficult it is when you have someone who has a mental illness and that cannot be completely resolved by medication. I got high blood pressure, I can control it with medication. Mental illness, the relationship between, you and your medication and whether or not you have episodes is not as definitive. And they're always experimenting. And then when you get beyond the medication, you're talking about what is the efficacy of the treatment, the actual therapeutic care, the counseling. It's just really difficult because people have some really severe illnesses.
Right. And I don't doubt the complexity of it.
Right.
But in the age of, on this side, right, if I'm going to do it from a pure money standpoint.
Sure. No, it's a good point.
I think it's fair.
Yeah.
A fair
I want to make sure the
question.
money is going to something that's working. And right now you guys are saying we can't really evaluate.
That's correct.
I think we don't have great definitions of what work would look like, what it would mean for you to be successful. Many of the problems we're asking them to deal with include major portions that are outside of their scope or control. So I'm trying to deal with somebody's mental health issue and I don't have great control over housing. I don't have great control over employment. So there are limitations that they all have that I'm not sure it makes that a fair question, but they are the degree to which they are not moving people as far as we want them to move. I think we have not quite defined what movement we're requiring. So I don't think they're failing because I don't think we have a standard.
Well, for some of it though, take opioid deaths. Clearly, mental health addiction leads to opioid use. And you have a very, very definitive outcome measure you can look at. Did they die? And what we're seeing now is the death rate is dropping dramatically. And I think it's dropping because, the Live Strong DC strategic plan with the sort of infusion of Narcan across the city has really slowed the number of people who are dying from the use of opioids. Now, I don't know if it's stopping them from using opioids, but it's just making sure they don't die. I mean, I think that's certainly a worthy measure. But in terms of the mental health issue and the addiction, the chemical addiction that drives you to opioid use, I'm not sure it's touching that. And I'm not sure it can. And so that's where the therapeutic counseling comes in. That's where, and I just don't know what the efficacy of those treatment modalities are with respect to something like substance abuse.
Well, within the department, we do have a number of evidence-based practices. And those do have efficacy in terms of addressing the mental illness that's experienced by individuals. And so there is that efficacy, and you can show progression towards illness management. However, what the deputy mayor says is very true, and that is behavioral health or chronic relapsing diseases. And so as people can stabilize, and then there may be some event where they once again need to have a different level of care. So you have to really look at the progression of care over time, the service needs of the individual, and make sure that they get it so that they can move to kind of an illness management and recovery framework.
I think we should talk more about this particular piece, right? In your slide, Director Turnage, we talk about $38.7 million spent on audio-only services.
That's troubling.
I'm just a skeptic, right? How do we spend $40 million on just audio only? That seems like an area ripe for fraud, because you're not physically having to see a person come in and those kinds of things. And what we have seen happen in some of our other Medicaid fraud cases, that seems very, very high.
And we agree with that. And that's one of the reasons why we're really doing a deep dive to look at those agencies that have had very high rates of telehealth, and doing targeted audits to see what's going on, because we don't disagree with that. And we're working in partnership with Medicaid around that. We've collected the data, we looked at the data, and we're looking at it over time, and we're doing those investigations.
I want to go back to sort of talking a little bit about capacity. So as I mentioned before, a couple of weeks ago, we had a hearing about the certificate of need bill to sort of reform the process. Director Thompson from SHPTA, the State Health Planning Development Agency, I'm getting better at all of my acronyms, said that the Department of Behavioral Health has always had the ability to waive a certificate of need for facilities under your purview. And so then it begs the question of, why did we not do it until August?
I don't know why. I can tell you what has happened. Essentially, the certificate of need came into being when APRA, or when substance use was actually under the Department of Health. And so that's really a piece of that. And one of the things that we started discussing very early on is, so how can we really not have a certificate of need for residential treatment facilities, because we have a certification process. And Dr. Bennett and I both agreed to that and moved to remove that as a barrier.
Okay, but then my question is, we had seen increasing rates of SUD usage and overdoses since 2020, straight up. If we looked at a chart, why did it take until August of this year for us to say, you know what, we don't need to have the CON process for a residential SUD?
I can't really respond to that. There haven't been that many CON applications for substance use disorders.
Right, but that's what I'm saying. When I ask providers,
yeah,
primary care, specialty, et cetera, they point to the district's CON process as a barrier for their decision to enter into our market. The cost, how long it takes, all of the various pieces. And so when I'm thinking about how do we get more providers to come into the district, that was the whole impetus of us looking at the CON process. It was like, how do we make it more streamlined? And so if this was a priority issue of us needing more providers in this area, I think it's hard for the public to hear. We waited until a couple of months ago to make the decision to waive this process when you've had the ability to do it the entire time that we've had this rise in numbers.
Well, quite frankly, I think that through discussions, we learned that we had the ability to do this. Before that, it was a part of the regulatory framework for DC Health. And so when we found we could do it, we really made that recommendation to remove it.
Okay, so I asked a question for DC Health. If y'all have known all this time that DBH could have waived it, why do we continue to require CON applications? Oh,
We don't know.
I don't know that we knew it all this time. I can talk to Director Thompson to find out where that statement is coming from. But because an ability to waive something exists does not mean it is not hampered in some way or not traditionally used in some way. So I don't know, when it was brought to me, we agreed.
Yeah.
So that's all I can really say. And I'm not sure if the issue came up before then, but there are many things that we've discussed before about what we might need to do with the CON process as a whole. And we have been looking at it as a whole and not really looking at let's piecemeal, but we can look through and see if there are other things that we can move past the process.
Okay. I'll ask just two more questions. I'll turn to you, Councilmember Parker. Dr. Bazarang, you and I have talked a little bit about what I feel like is a bit of gatekeeping in terms of people who might want to enter the market in terms of providers. So if I go to your website, I can't find the requirements for certification to open up any type of facility. There is a little note that says, call this person or email this person to get information. Is this something that we could be more forthright about?
Yes, as a matter of fact, my team will be putting the application information on our website. And that was one of the follow-ups from a former conversation.
Great. Okay. Overall, when we had on the first panel, we had all of the hospitals who came in and spoke, and it became very clear as they're sort of talking through who has beds available versus who doesn't, right? I mean, are you all troubled by our capacity issue in terms of youth inpatient?
Yes.
Okay.
Yes.
I'm also troubled by the fact that we think we have beds that are then not being used.
Yes.
So
Right.
that the number that are licensed versus the number that are actually used seems quite dramatically different. And I'm not sure we've been included in that conversation.
Okay. One thing I do want to follow up on, Director Turnage is around Cedar Hill. When I asked Ms. Russo around the decision for Cedar Hill not to have adolescents, and she says, well, it's based on the Heron report from 8 years ago. I mean, that seems like is it too late?
Is it too late to do what?
Is it too late is it too late to have a behavioral health unit at Cedar Hill that also treats adolescents?
Yeah, let me answer it this way. Am I troubled by the shortage of psychiatric beds for our children? The answer is yes. Mitigated by the questions I have from years of looking at data on this issue about the effectiveness of these of psychiatric facilities in helping kids who are severely troubled. It is not always sufficiently different from the juvenile justice system. The deeper you go in, the more dysfunctional sometimes you become. So I think we need a much broader focus on youth than we currently have. But yeah, more beds would help. Can you do it at Cedar Hill now? I think the answer is no. The contract is set. If you wanted to do a separate physical facility, a part of Cedar Hill, we couldn't pay for it. It's $40 million facility. You'd have to add more money to the contract to build a facility. And I will say this, one of the concerns when Huron was doing this study, we were trying to look at, why is UMC failing as an acute care hospital to the point where, a lot of residents justifiably complained that they had no option for acute care that they trusted in Ward 8. How did that happen, given that you have credible physicians there? And the answer was, one of the answers from Huron and, others through observation was because we were asking UMC to take on a heavy position as the deliverer of mental health services for adults and kids. And if we do that, then sometimes the hospitals get labeled as, this is a mental health facility, not an acute care facility. And so the people who will determine whether or not your hospital succeeds assuming you provide good care, whether or not your hospital succeeds from a financial standpoint, won't go there because they will begin to see it as a mental health hospital. Fair or not, that's what happens. And so we wanted to, during the early stages of development of a model to replace UMC, we wanted to avoid those pitfalls that created UMC as a financial albatross around the neck of the city.
That's fair. I would also say that probably when the Huron assessment was done, Providence was still a hospital. And so now we have a situation where I got UMC closing, and then they have 32 on their unit. Cedar Hill is opening with 16, with up to 8 for FD12. So I got a gap.
Yeah, but you can't, I would say, and I've said this to the Hospital Association, and they understand this as well. When the rubber hits the road on this shortage, it's going to need to be a partnership between the city and the hospitals to come up with a solution that everybody can live with. And so that means bringing all the hospitals to the table, bringing the government to the table, and then coming up with a solution to address what is a legitimate gap in services or shortage of services, psychiatric beds for kids, bringing a solution that everybody can deal with. And I think the process on that has started, at least from the recognition that, I've talked to MedStar, I've talked to Jackie at the association, I've talked to Kim Russo, and they all agree we have to come up with a solution to this. And it can't just be one hospital taking a load of patients.
Well, yeah, I mean, I would say probably Dr. Argos would say we're doing more than our fair share. You can't really put it on PIW because, again, I feel like we're creating an institution that's too big to fail if they're already doing 57% of our FD12 cases. And so what?
Yeah. So
rope Sibley into the process?
Well, Sibley is a hospital, acute care facility in the city. So I think they would be a part of the discussion that we have with all of the hospitals in the association. Maybe it means, everybody getting together and funding the formation of a psychiatric facility for kids. And then having, hospitals contribute to the operating costs, cities subsidizing it. There are a number of things you can consider.
Yeah.
We have to look at the models. And of course, anything that we propose that has money will have to get by the very sharp eraser of our CA, who is worried about, justifiably worried about the city's budget and where it's going.
I share his concern, but I'm also justifiably worried about the care of.
So one, just to be clear, the care that we're talking about for adolescents is not generally the long-term stays that we are concerned we might not have for adults. These are generally very short stays.
Right.
And so they are not so outside the realm of something that could happen at many of the facilities that we have. We are best served when there is a diversity of providers around any type of service. We have a lot of only service providers for things, or nearly only service providers for things. So the degree to which we can try to encourage, even if it's not at their location, encourage more actors in the space. I don't know that we need a facility that's only for young people, but you do have to have some physical separation from the adult units. So one that's already built as a single unit, like Cedar Hill, is not going to be able to flex in that way.
Right.
But we should have other facilities. We are lacking psychiatric emergency care in the true way in which that's defined. We're lacking. So there are multiple things that we need to speak about as a system that hopefully we can move to exist in multiple locations. I worry all the time about some facility going out for some physical reason, because many of them have all of what we have.
Flooding
for
of,
one thing.
pipes of some sort.
Yes, the flood at any number of them is a problem for me because I have no idea what I do. And it's not even just the capacity to move somewhere else, because you have to have the staffing, you have to have the expertise. People have to be able to do the thing that you're asking
Yeah.
for. So
I would
it's
just
a longer
say,
conversation.
And I'll turn to Councilmember
Yeah.
Parker, like it's the infrastructure piece, right? It's whether we have places for partial hospitalization. Do we have options for intensive outpatient? I think there's a model whereby someone spends their day.
That's right.
And then,
Partial hospital. Mm-hmm.
Post inpatient.
Okay. I don't know, in some ways, I'm sort of feeling like we probably should have started this conversation 3 to 6 months ago.
Well, we did start the conversation 3 to 6 months ago. We've all been.
Yes, we've been having the
Okay.
conversation.
That's great.
Yeah.
Then I hope then.
We've all been
Yes.
everywhere.
Oh, you guys don't have your mics on. It's okay.
Yeah, and the other thing too is that, remember, we have a 292 bed a state psychiatric hospital. And that's another place where we see, we need to really look at that also.
But St. Elizabeth's doesn't take kids.
That's St. Elizabeth's.
Do they take children?
St. Elizabeth's does not take children.
That's what I'm.
That's
Well,
correct.
I mean, obviously it's a little bit different in terms of
Does
committing,
not take children. no.
but, okay. Councilmember Parker, sorry.
Thank you. And very fascinating conversation. I want to say shout out to Councilmember Henderson, who's been at this all day. I've left, had many meetings and come back and we're still here. I mainly want to get clarity on the oversight function of DC Health and DBH as it relates to PIW and other agencies, just given the number of reports. But I want to put a pin in the conversation you all were just having, because I think it's critically important. Dr. Bennett, I take to heart what you're saying. We're already having these conversations. What might it take to have formal recommendations for the committee by time the budget is underway in a few months?
I think we could be there.
Beware.
To have recommendations around what we're planning to do around this area. I don't know that means we'll know where we want to have a facility, but what I'm currently working on are the things that are under my scope, which is what are the regulatory changes or perhaps even recommended.
And let's say we had a
changes.
magic wand and you gave formal recommendations and somehow Chairperson Henderson was able to find money. What might be what might be the best case scenario in terms of timeline that we might be able to scale up or ramp up our services, namely for juveniles in the district?
Services is Dr. Bazaran, but in terms of our oversight, it would be a number of people probably. We don't necessarily, subject matter expertise for behavioral health it's not a large part of our portfolio, so we would need to add that. So there are some things that would take some time, but I don't think they would take years by any means.
Okay.
And some of the regulatory things I think we can do relatively quickly.
Got it. And some of the conversation, admittedly, I missed today. So if I'm asking repetitive questions,
I
please
would pass
forgive
it
me.
off.
And Dr. Bazaran, I'll ask the same thing. Assuming we could get recommendations, find money, what might be a best case ballpark scenario for our ability to ramp up services for juveniles in the district?
Well, and it's what services are needed to
For
fill the gap.
psychiatric care.
Yeah, that's what I'm saying. What services are needed? And we've talked a little bit about intensive outpatient and partial hospital services, as well as youth inpatient psychiatric services. And I think there is agreement that those are some areas where we really have some significant gaps in our continuum of care. And so I think
But are we talking months, years? I was struck by the conversation Chairperson Henderson asked, like when we were planning for Cedar Hill, why didn't we think ahead of this gap? And the response is, well, at that time, this really wasn't a gap. That was before my time on the council, but that to me struck me as odd, just given the current gaps that we have. And so I'm trying to understand from this point where we do recognize that this is a gap, what is our timeline or continuum looking forward?
I don't know that I have a specific timeline that I can share with you. because it depends on a number of factors. In addition to financing, what the policy framework is for doing that, and then also providers.
I got
And
you.
having
Right.
providers who can come into the city and provide those services, or those who are already here who can deliver the service.
I got you.
So,
Dr. Bennett.
I do just want us to, we do need psychiatric beds, and those are dramatic when we can't find one. But the vast majority of kids who are not getting what they need, who are in school, who really should be doing something else
Yep.
during the day, those are the partial hospitalization and intensive outpatient. They would stay with their family. Most of the things that we think are negatives around psychiatric care can be avoided that way. But also, that is the stage at which I think many of the youth we're talking about needing care are at. So that is a very different bar. We'd absolutely need people to do it, but you could do that in an office park. It's less about let's find a facility and build something. So if we can focus on the lower barrier, not no barrier, but lower barrier things, I think we'd be better served. And
Can't wait for those
focusing on the beds.
recommendations in a few months.
You know, I think as a prelude to any recommendation on a youth facility, I think there has to be a general consensus on what the goal of that facility would be. If you're talking about, most of the studies that you look at will show you that, kids who leave those facilities, they show some progress while they were in the facilities, but they left there with the same symptoms that put them there in the first place, and those symptoms have a high association with recidivism. And the response from the treatment facilities will be, our length of stay is not long enough for us to eradicate these problems. We're trying to stabilize. So think about this, you're gonna spend a ton of money, because if you're gonna do this right, it's gonna cost a lot of money. Apart from the capital costs, which is gonna be enormous, you're gonna have to have a very qualified, high number of staff that are working with kids, even if it's a short-term length of stay, to stabilize and then release to the community. And if you release them to the community stable, but they have the same symptoms that put them there, you could be dealing with them again.
Yes.
And so the question is, do you want a facility that just stabilizes, or are you looking for something more long-term that provides continuous care until the person moves beyond a danger point to themselves or others? And I don't know, clearly there are cost implications for choosing one model over the other, but those are difficult issues. And I'm not sure it would have to be a serious discussion with a lot of the experts, of which I'm not one, about how to do this and what the best way is to do it. Because if you look at the stabilization facilities, they all use evidence-based models, but they all have high recidivism rates because they are there to stabilize and then release based on their short length of stay.
That is why I was recommending you build the system that's meant to catch them before you have them in a place where you're discharging. So it is both preventative and it is extending the efficacy of whatever the inpatient intervention is,
understand.
just going back to community with not going back to, because going from inpatient to partial hospitalization, where the only change is that you sleep at home, is a much softer landing than it is to say you're done. So that is what we want for adolescents, to have them move gradually to less and less support as they're able. But that means you have to have the outpatient system ready first.
Thank you. And I just want to make sure we're clear on the commitment. So Director Turnage, Dr. Bazaran, are you also committed to working towards formal recommendations for the committee ahead of the budget process?
Yes, with the caveat that I will need to sit down with the CA and talk to him about this issue, and I meet with him twice a week. So I can talk to him about this issue and what you all's interests are and what the need is. And he's aware of the need because we've talked about it before this meeting about, well, we have to figure out something here, because if the bed need is as challenging as it appears to be, we got to figure something out. So I will share with him, if he's not watching this, that we are committed to offering some recommendations without a price tag on them until we can get some clarity about where, if anything, where, if any path we have in the budget.
Understood.
Yeah.
Dr. Bazaran? Okay, all right. I would just throw out one last thing, given my more recent work with DRS, that the psychiatric care for detained youth is also a top concern, and they are really struggling with how to deal with that piece within the facility. So just throwing that out there as you're huddling. I wanted to spend my last 2 minutes just getting a better sense of the coordination and oversight function from DBH and Department of Health for PIW in particular, but for all of these facilities that are treating patients. As you know, there have been a number of complaints specifically against PIW, and we kind of hear both things. We hear from advocates that, oh, there are a number of complaints that are not being followed up on. Some complaints are never being reported. And then we heard from PIW today to say, oh, I don't really know how many situations there are, and we're self-reporting everything. More specifically, it's my understanding that the complaints are going to DC Health.
Not all of it. If you look at, in particular, what disability rights put out, many of the time, they're not saying they informed us. They informed DBH, or they know there's an incident report. We know for some of those incidents, we were unaware of them altogether. So there is a problem in terms of reporting. And then our second problem is that by the time we're informed, which is after the incident, after the disability rights investigation, some of the evidence or witnesses are not present anymore.
I got
So we have been somewhat hamstringed in that. So that is a regulatory fix that I don't think has a price tag, and I don't think I need any additional authority to do that we need to work on. And there are several things like that. At the moment, I don't think we have what we need to be able to respond appropriately.
And that regulatory fix is providing greater clarity for where that information should be reported and to whom.
And requiring what needs to be saved and available until the investigation's complete. At the moment, I don't think it's very clear that video should be included in that. I would have interpreted it that way, but at the moment it is not being interpreted that way. And so we are not being given that.
And what type of information sharing is there between agencies to say, hey, this is what we've heard. What do you have?
Again, that's what I meant by some of the constraints from CMS. I can't announce an investigation to anyone else.
Correct.
We have talked about, is there a way we can do it with a detail of a stat? Like, how can we do it in a way that would allow them to participate? They would have to be part of DC Health. These are some of the consequences of bringing up. We're going to figure it out. We're going to figure it out, but we haven't yet. And at the moment, that has meant we have been not including them, except for one time we did try, but it is a difficult thing to do without breaking CMS regulations. So we will figure something out, but at the moment, we don't coordinate and we cannot inform them of anything that CMS has not released, which can be several months.
One of the things that I can share is that we have increased our oversight of PIW in terms of, we have a contract with them for involuntary beds. And we were formerly doing on-site visits once a month. Now we're doing it twice a month. In addition to that, we are also doing chart reviews twice a week with them. And during these interactions, we are asking them specifically, are there most unusual incidents that have happened and have occurred? And
You're asking them.
Asking specifically, because they have a reporting requirement in accordance with our contract to report those things within 24 hours. And so we have really stepped up that communication and saying, is there something or isn't there something? And what we found, for example, is that in the past, we got very, very little information, but now that we're asking, we're beginning to get some information, and then we can investigate what's going on.
Okay, I'm mindful of the clock. I know it's been a long day. If I could have just 60 more seconds. And I just would throw this out as it relates to individuals needing psychiatric care and their involvement with the criminal justice system. This is more of an observation from the outside looking in, that there is a missing communication loop that is needed back with the community. And I've worked closely with Dr. Bazran, given a situation that happened in Ward 5. And I get the sensitivity of talking about someone's mental health and health needs. But repeatedly over the last year, it's been very challenging to just know what is what from all agencies involved, including PIW, for an individual that poses a threat to society. And I don't know what the solution there is, but we have to figure out a way to adequately inform neighbors, adequately inform community partners of an individual that poses a severe risk, while at the same time honoring and respecting their health needs.
And their privacy, their rights to privacy and confidentiality. Yes.
I get that. I get that. I get that. Dr. Bennett, I'll give you the last word. It seemed like you were going to say something.
I would just say that these issues are going to take a lot of people at the table. We have started to do some invitations to that table, but it is, because there's so many people involved, it is a complicated conversation. But the work is ongoing, and I do think we can arrive at some solutions. We've been holding in some ways the health services plan because I want all this in it. And so I think we have made some good headway, and I think we can get there.
Understood. Thank you all.
Councilmember Parker, before you go, I was going to ask a question about a bill that you introduced. So at the hearing on Bill 25-759, the Child Behavioral Health Services Dashboard Act of 2024, it was mentioned that DBH and Healthcare Finance submitted a plan to CMS for funding to develop a behavioral health bed dashboard within CRISP. Do you all have any update on that?
For CRISP?
Nope. Submitting the plan to CMS.
Melissa
yeah.
can help.
Good afternoon. My name is Melissa Bird, Senior Deputy Director of the Department of Healthcare Finance. I can follow up with an update as to exactly where we are. What that bed board will do, if you recall, CRIS, which is the district's health information exchange, is really provider focused. So that is an opportunity we are exploring so that we can have that capacity for providers to see what beds are available or not available. My recollection is it's in the planning stages. The request to CMS is likely through something called an advanced planning document where we ask for the approval to utilize funds, federal funding to support that. Again, that would go back to mostly for CRIS would be something that's more provider facing and not to the entire public of what beds are available when.
Yeah, I don't think it necessarily needs to be, and correct me if I'm wrong, Councilmember Parker, I don't think it was intended for the entire public to be able to see from facility to facility. But if I have a hospital, for instance, that's trying to do a step down or a warm handoff, if you will, I think that would be appropriate for them to be able to have access to determine, okay, let me call such and such because it looks like they might have space available.
Exactly. And
that's a
again,
part of
it's
the
a
plan
provider
that
facing
we talked
tool,
about.
which is exactly what CRISP is. So that's all I was delineating. It would be very much for like hospitals or other community-based providers to see what is available for folks.
Okay. We've been going for a bit, and to just sort of put a finer point on Councilmember Parker as we sort of wrap up here, one of my impetuses of holding this hearing now is because I do feel like there are probably some budget implications, whether it be from the fee schedule or otherwise. So for instance, I mean, we don't have partial hospitalization programs for adolescents. Is that part of our fee schedule?
Yeah,
Is it part of our what?
Partial hospitalization programs, et cetera. I don't think we currently have them in the district, but is that already part of our fee schedule or reimbursement schedule rather? If a provider was to step forward to say, I think I want to provide these services in the district, is this something that we already have on paper?
Yes.
Partial hospitalization, I don't believe is currently, it's intensive outpatient that we do have the means already, but the partial hospitalization is something that we would have to stand up from a Medicaid
Intensive
perspective.
outpatient is in the spot.
Okay, so for intensive outpatient, when's the last time we've done a evaluation to say whether or not our rates are even competitive with Maryland and Virginia or comparable?
For which service?
In intensive outpatient.
Well, Maryland has a completely different reimbursement system, but we can look to see how what we pay compares to them.
Okay.
In fact, if you talk to most of the providers who are in Maryland, they would love to be in the district because Maryland is, has a very strict payment system.
Y'all keep saying that, but then they're not here.
There are other complications of it.
Correct.
Right.
Other complications. And I think the impetus of holding this hearing was for us to get clear on what are those complications, what are those barriers, and try to deal with them as we can.
Sure.
I know some of them are financial in nature. And so us having this hearing, I believe in October, as you guys are having conversations with the CA and the budget director around, right? No one, I don't think anyone is looking for like a $50 million investment, but we are looking for some sort of down payment to suggest that this is a priority issue for the administration. And it is something that we're working towards, whatever that might be.
So this is the facility, the youth facility?
No, not a youth facility.
it?
I'm literally talking about like if you all are saying for the patient case that we, or the patient population that we currently have, facility is not necessary, okay. But let's start to scale up, because right now we don't have an inpatient or intensive outpatient option right now for youth. What would it look like for us to do that? What would it look like for us to do partial hospitalization as sort of a mechanism? Because, you know, the physician from Sibley, which is literally like, oh, if I call Children's and Children's doesn't have a bed available, then I'm calling up to Baltimore to see if they can. And I think that it's a necessary, but I feel like we should be able to take care of that home.
Yeah, I'll sit down with Melissa and Eugene to talk about what would necessarily require a spa, or what we could or couldn't do under the existing paradigm. But whatever it is, then we'd have to treat it as an enhancement for budget purposes and put a price on it, which we can do. Only question then would be, is it an enhancement that requires a spa? Is it something we can do that generates a significantly higher cost, but is within the framework of what we're already doing? And we can look at that.
Okay.
So those are discussions we can have at our next manager meeting.
I think that's a question in terms of the healthcare finance space, right? Because that's a question that if somebody comes to Dr. Bazaran and raises their hand and says, hey, I'm a provider, I want to provide these services. And then they're going to say, well, how much money do I get for it? And then I need healthcare finance to be able to provide that information, right? In order to do that part. That's on one side. The other is, Dr. Bennett, you brought up a lot of regulatory things from an oversight perspective that you all want. Is that regulations? Is that legislation? Kind of need to know what we're talking about here. And then in terms of like, what's the runway?
Yeah. Well, we'll have the discussion in our management team meeting tomorrow on two quick points. You asked for data on what proportion of the days at PIW were Medicaid. It's 58%, almost 6 in 10 days are paid for by Medicaid. This was as of fiscal year 23, up from 50% of 3 years ago. And I want a point of clarification. Our SHIFTA director has reminded me that when Cedar Hill was being discussed for mental health beds, they were not youth beds, because UMC does not have a psychiatric facility for youth. So it was all around, you know, do we want to expand the number of adult beds for psychiatric care at Cedar Hill? And that's how we ended up landing on 16 as opposed to whatever number UMC was providing, which is like 30 something, I believe. So.
Okay. All right. I don't have any further questions at this time. We do have some things for follow-up, obviously, to keep talking. I want to thank you all for participation in the hearing today. I want to thank all of the witnesses who testified earlier. I think we discussed, and I think we can acknowledge there are some gaps, whether it be in regulation or oversight or just in access. And so I'm hopeful by the collaborative talk that we're having here, and that we just want to see some action on some of those things. Yeah. That concludes today's hearing. For those who wanted to submit public testimony, didn't have an opportunity to testify today, the record for this hearing will be open until Monday, November 11th at 5 p.m. You may submit written statements by uploading the document to the council's hearing management system, dccouncil.gov/hearings. There being no further business before the committee, this roundtable is adjourned. It is 5 o'clock. Thank you.
Here into 5 o'clock.